A very good morning to all of you. We welcome one and all to the Phacoemulsification and Refractive Surgery workshop being conducted at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. So we have a good amount of physical participation as well. This is a hybrid meeting, so people will be joining us both virtually and physically. So we welcome the delegates who have come over here. And just a basic introduction of the faculty. From Unit 1, we have Professor Sudarshan Khokar as faculty, who's heading the cataract and refractive surgery services in that unit. And with senior residents, we have Dr. Soumya, Dr. Diksha, Dr. Aishwarya, and Dr. Venkatesh. Unit 3, we have Professor Jeevan Estityal, Chief RP Center, and he's also heading the cornea, cataract, and refractive surgery services of Unit 3. Professor Tushar Agarwal, Professor Rajesh Sinha, Dr. Manpreet Kaur, and Dr. Sridevi Nair. In senior residents, we have Dr. Suman, Dr. Sohini, Dr. Sarat, Dr. Neha, Dr. Priyanka, Dr. Afreen, Dr. Mansi, Dr. Rakshay, and Dr. Shehnaz. Unit 4, Professor Namrata Sharma heads the cornea, cataract, and refractive surgery services in that unit, along with Dr. Praful Maharana. And in senior residents, we have Dr. Jyoti, Dr. Priyadarshini, Dr. Amog, and Dr. Vishal. Unit 6, Professor Radhika Tandon heads the cornea, cataract, and refractive surgery services, and we have Dr. Vanathi, Dr. Nupur, and Dr. Lomi. The senior residents are Dr. Amit, Dr. Nimmi, Dr. Tanveer, Dr. Navneet, Dr. Kusumita, Dr. Neha, Dr. Abhijit, Dr. Manu, and Dr. Preeti. I now invite Professor Jeevan Estityal, Chief RP Center, to officially inaugurate the workshop and start the first session. First session chairpersons are Dr. Radhika, Dr. Khokar, Dr. Vanathi, Dr. Rajesh, and Dr. Nupur. I invite them on the dais.
Thank you, Dr. Manpreet. I think we invite the chairpersons, Professor Radhika and Dr. Nupur, to be on the dais. As nicely introduced by Dr. Manpreet Kaur, we definitely like to welcome all the delegates who have come from different parts of the country. Physically and virtually, they have joined us today. We all understand learning is a phase which never ends. Till you are alive, you are doing practice, learning has to go on. In this direction, we keep holding these type of workshops year and year, and like to really innovate in a way where people can interact with us, with questions, with their queries, so that we can make a very lively discussion. I would request people who have joined us virtually also, they can send their questions, we'll discuss them. And the most, I think, attractive part of our workshops has been we do all the aspects, that is didactic lectures, question answers, live surgical demonstrations, and more importantly, discussion based on the videos, and wet lab in the end of workshop in the afternoon, which makes, I think, some sort of interaction which makes more physically and interactive if you have a wet lab sessions also. So we would definitely like to welcome all of you and people who have come from various parts of the country in this early morning on Sunday. Let's begin with the first session, which is on refractive surgery. Dr. Radhika to take over.
Thank you so much. Welcome everybody. So for the first session, we are starting with a very basic requirement, and it looks basic, but it's very important because it's crucial to decide properly all the various aspects when you have a patient coming to seek refractive surgery. So we have Dr. Sridevi Nair, who's a faculty in Unit 3, to cover the details about decision making in refractive surgery.
Thank you, ma'am. Good morning, everyone. I'll be speaking about decision making in refractive surgery today. So we can broadly classify refractive surgery into corneal based procedures, lens based procedures, or bioptics, which is a combination of lens and corneal based procedures in the same patient. So these are the most commonly performed refractive procedures that we know of, that is PRK, Lasik, and SMILE, and of course phakical implantation and refractive lens exchange. And in the table we can see the approved refractive correction range for each of these procedures as per the FDA, US FDA. So who is a suitable candidate? The suitability of the candidate is determined by, one, the age of the patient, which should be within the FDA approved age limit, the stability of refractive error, wherein there should be a less than 0.5 change in the spherical equivalent in the past 1 year. The patient should not be pregnant or breastfeeding, should not have any systemic or autoimmune disorder, should not have any ocular comorbidities active, and should be adequately counseled with realistic expectations. So these are some of the absolute as well as the relative contraindications to performing a the corneal laser refractive procedure. A comprehensive preoperative workup is important not only to screen out the patients who are not suitable for a refractive surgery, but also to choose what is the correct procedure in each of the patients. So for screening the patients, the most important part is doing a corneal tomography, which is commonly now done using a Scheimpflug technique such as the Pentacam. So first we look at the chord map in these patients, which has an anterior curvature map, wherein we look at the K max, which should be less than 48 diopters. The difference of K mean between the both eyes should be less than 2 diopters. The difference between K max and the steep K should be less than 1 diopter. Skewing should be less than 21 diopters. And the inferior superior asymmetry should be less than 1.4 diopters in the 5 mm zone. Superior inferior should be less than 2.5 diopter in the 5 mm zone. Next, these are some of the abnormal topography, the axial curvature maps that you can see. So there can be an inferior steepening as seen here. There can be a superior steepening, and there can be skewing of the axis as seen here. Next, we have the pachymetry map, wherein you look at the 2 points. One is the area of the thinnest pachymetry and the pachymetry apex. So the difference in pachymetry between these 2 points should be less than 10 microns. The distance between these 2 points should be less than 500 microns. And the thinnest pachy itself in an eye with a normal topography should be at least 470 microns. And the difference between the thinnest location in 2 eyes should be ideally less than 30 microns. So the abnormal patterns on a pachymetry map can be either a droplet pattern in case of a small localized cone, or a dome-shaped pattern in a larger cone wherein the thinnest location is displaced inferior temporally. Next, we have the elevation maps, the anterior and the posterior elevation map, wherein you look at the elevation of the anterior and the posterior corneal surface with respect to a best fit sphere or ellipsoid surface. And the cutoff for the posterior elevation points within the central 5 mm is 17 microns. That for the anterior elevation is 12 microns. The abnormal patterns that can be seen in the elevation map include either a central island as seen in this figure in the anterior and posterior, or a tongue-shaped or a skewed hourglass pattern, both of which are suggestive of an early ectasia. Then we have the Bellin-Ambrosio enhanced ectasia display, wherein on the left side you have the enhanced ectasia display, which actually essentially a best fit sphere is created which excludes the central 3 mm zone, so that the area of steepness is excluded and it gives you a flatter best fit sphere. This will accentuate any areas of ectasia or elevation when you apply it on the cornea. So the first, on the topmost you have the normal elevation map, in the middle you have the enhanced ectasia elevation map, and in the lower part you have the difference between the two. And this difference should be in the green zone ideally. Yellow is considered suspicious and red is considered pathological. Then we have the pachymetry maps on the right side of this map. First you have these three graphs, which are CTSP as well as the PTI, which essentially give you the change or the progression of the corneal thickness from the center in thinnest location to the periphery. And in a normal patient, his graph should lie between the 5th and the 95th confidence intervals. Then we have something known as two pachymetry indices which are important. One is pachymetric progression index or PPI, and the ART, that is Ambrosio relational thickness. So the PPI, it describes the increase of the corneal thickness from the thinnest point to the periphery in each hemimeridian. So you will have a PPI max, a PPI average and a PPI minimum depending on which meridian you are looking at. And the ART or the Ambrosio relational thickness is essentially, it is the ratio of the thinnest pachymetry divided by the pachymetric progression index in that particular meridian. So ART max will be thinnest pachymetry divided by the PPI max. So a cutoff of around 400 is given for a suspect, and for the PPI average, a normal value of less than 1 is usually expected. Then we have the D value, which is a very important multimeric index which is derived from all of these parameters, and it gives you a single value, a single point, which can help you differentiate between cases that have subclinical ectasia versus normal. So a value of greater than 1.6 is considered suspicious, and it has a 84% sensitivity in differentiating subclinical keratoconus cases from the normal eyes. Then we have the newer indices from the Corvus, which is a non-contact tonometer and gives you a biomechanical evaluation of the cornea. So the CVI can be seen on the Vinciguerra screening report in the Corvus, and it is derived from the following parameters, that is the deformation amplitude ratio, velocity, and the ARTH and the SPA1. And a cutoff of 0.5 has 100% sensitivity in diagnosing frank ectasia. Another important indice on this map is the SPA1 index, And this is the stiffness parameter, which again, it's a single index which gives you an estimate of the global corneal stiffness, and a cutoff of around 100 can help you differentiate between cases with normal cornea versus subclinical ectasia. Then one more important index on the corvis is the tomographic biomechanical index, which is seen on the ARV display, or the TBI. And here again, it basically integrates the Schimfleck based corneal tomography with the biomechanical assessment to give you this index using artificial intelligence. A cutoff of 0.29 has been found to have around 90% sensitivity for diagnosing subclinical keratoconus. So combining both tomographic and biomechanical indices or parameters improves the detection of subclinical ectasia. And as of now, among the biomechanical indices, TBI and SPA1 have been found to be most sensitive for differentiating subclinical ectasia. In addition to these screening parameters, we also have certain cutoff parameters such as the residual stromal bed strength as well as the percentage tissue altered, and also we have to look at the post of keratometry in these cases. Then these are the cutoff parameters that you look at when you are implanting a phacoemulsification, wherein the AC depth and the white to white is important. So suppose if you have a patient with around 5 diopter of refractive error in both eye, if you look at the pentacam maps, the chord maps for this patient, you see that the Kmax is okay. There is a slight skewing in the left eye. Thinnest pachy is less, it's on 482 microns. There is a displacement of the thinnest pachymetry in the right eye of more than 500 microns. And also there are localized elevation points in the posterior elevation map. Look at the PTA, it's nearly 40% in both eyes, and the RSBT is also borderline. So ART max and D value are also abnormal in this patient. So in such a case, what we look at is, if we consider it as a case of fomeophrastic keratoconus, you should avoid any corneal ablative procedures in such cases. Wait for stability to be established, and then you can plan a phacoemulsification if the ACT and endothelial cell count permit. Then these are some of the deciding factors that help you in deciding as a decision making in refractive surgery. So in a patient who's less than 40 years of age with sufficient RSBT and a post-operative K within the prescribed range, you can go ahead with either a corneal laser ablative procedure or a phacoemulsification. In a patient who's less than 40 years, but then the PTA is not above the prescribed range of 40%, or the RSVT is inadequate, or the patient has a subclinical ectasia which is stable, then probably a phacoemulsification implantation would be a better option in this case. In patients above the age of 40 years, you have to look at the lens changes. In those with a clear lens, depending on the refractive error and the corneal parameters, you can either go ahead for a presbyopic phacoemulsification or a presbyopic Lasik. And in cases of greater than 40 years with lenticular changes or those unsuitable for corneal procedures, a refractive lens exchange would be the best option. So when you're deciding the corneal laser refractive procedures, so in cases of myopia and hyperopia within the prescribed range for Lasik and an astigmatism of up to 6 diopter, you can go ahead and perform a Lasik. But in however, in cases where the patient is involved in contact sports or armed forces, and if he has a mild dry eye, so in such cases, a flapless procedure such as a PRK or a SMILE may have an advantage over Lasik. However, one should note that SMILE is approved for astigmatic correction up to 3 diopters only, unlike Lasik. And also in cases with mild dry eye, larger pupil also, SMILE will have an advantage because of its larger optical zone. So now we come on to the question of customized corneal ablation, which is much talked about nowadays. So as we know, there are 3 types of ablation: wavefront, optimized, guided, and topographic. Topo-guided ablation is what is really in vogue nowadays. So what essentially they do is that they look at the corneal topography, calculate the corneal higher order aberrations, and they plan the corneal ablation based on the manifest refraction as well as the corneal higher order aberration profile. So whenever you're planning a customized corneal ablation in such a patient, you look at 2 things. First, pre-operatively, whether the patient has a good visual quality, in any night vision symptoms, any glare, halos. If none of these are present, then most likely the patient has a higher order aberration within the normal limits. You expect these patients to do quite well with your routine wavefront optimized Lasik. However, if the patient has any of these symptoms, you should go ahead, do a wavefront analysis, look at the higher order aberrations. If they are raised, then look at the corneal pattern and look whether the higher order aberrations are predominantly from the cornea or from the internal aberrations. And based on that, if you have good aberrometry maps, whether it's topographic or ocular wavefront, then you can go ahead for a topo-guided or a wavefront guided Lasik in such cases. So who might benefit from a topo-guided Lasik? Any patient in whom you can acquire good quality repeatable topography scans might benefit from a topography guided Lasik, but patients who have mild irregularity in the cornea with a consistent refractive and topographic will definitely benefit from a topography guided Lasik. Now, this is a topography capture that we've done from a Topolyzer, and if you look, there are irregular Myers, lot of lashes coming. The analyzed area is just around 60%, so this is not a good topography map for using in a topo-guided Lasik planning. So again, if you compare this eye versus this one, so you see this is very consistent, all the maps that you've got, and the pattern is also consistent. So this might be a good case to plan a topo-guided Lasik, as opposed to this where you see the pattern of irregularity is not at all consistent between the maps. So make sure that the cornea is healthy, it's well focused, the Myers are smooth, perform multiple scans, the regularity should be repeatable in all the scans, and select the scan which analyzes the maximum corneal area. So in normal routine eyes, do topo-guided ablation have any advantage? See, so the visual outcomes and the refractive outcomes are essentially comparable for wavefront optimized as well as topo-guided in these eyes, at least at the 20/20 level. But yes, eyes acquiring 20/10 or 20/15 visual acuity have been found to be higher with topo-guided Lasik. These patients have been found to have a better contrast sensitivity and lower induction of higher order aberrations. So to summarize, it's very important to do a good preoperative workup and screening. Choosing the right procedure and tailoring it to the individual patient profile is extremely important, and the success of a customized ablation relies on proper patient selection as well as proper intraoperative planning. And least but not the least, always look at the patient expectations and motivations in addition to all the other parameters that we just discussed. Thank you.
Thank you, Sridevi. That was very nicely explained, covering all the important aspects. We are going to now, no, stay there, Sridevi. We are going to proceed with the live surgical session, refractive surgery. While we are connecting to the OT, we can have a few questions for Sridevi.
Yes.
Oh, they are already there in the OT. Are we ready, Dr. Khokhar?
Radhika, good morning. We are all
Good
ready.
morning.
We all set, actually.
Excellent. So we are going to proceed with the live surgery. Thanks, Sridevi. The first case is going to be thin flap femtosecond Lasik by Professor Khokhar.
Radhika, so this patient was a little nervy, so I've already started. I've just cut the flap. I'll show you the other eye when I whatever do again. So I've just created a flap on a Visumax. I've put in a marking here because there's always a doubt amongst people that when you're doing a thin flap, there's a chance of you getting a distortion of the flap and you're getting strias, which you don't get. But for the beginners, it's always good to mark. So I marked this one. Can you see the marks, Radhika, there?
Yes, we can see the mark now. Yes,
just stay connected. So whenever I ask something, just please respond to me, right? Thank you very much. So I wet the cornea. So the thing is, you cut it when it's wet and fry it when it's dry. So when I'm going to fry, when I'm going to zap it, I'm going to make it. I'm going to shift to the other machine now, which is my Mel 90. Please get the patient here. So why did we switch over to 80? Because there's no point in leaving 20 micron behind the flap, because once you cut the flap, even if it's 120, 180, 100 micron, it does not add to the strength of the cornea. So that means that if you can make a thinner flap, and why 80? Because if you go less than 80, you're almost reaching 60 is the limit for the epithelium. So you'll have a very fine, faint margin there. So we can't go less than 80. That's what is the limit of this machine. My chair has to go down a bit. Okay, so now I've switched the patient over to the Mel 90. And the moment you see the Mel 90 in your screen, just let me know. Is the Mel 90 feed with you?
Presently we have now we have it, yes.
Okay, so I'm focusing, so you see there are two red lights coming close to the green light in the middle, and that's what the flap looks like. So this flap is an 80 micron flap, and how we cut it I'll show you over the other eye, because I didn't want to waste time in between. The patient was getting a little edgy. Nancy, आप बहुत अच्छा कर रहे हैं, बच्चे से लाइट में देखना है. So what you need to do is you go deep first, vertical, and then change your hand direction. You see how simple it is. And be it 80, 120 or 100, it doesn't make much difference to lift it up. So definitely this is a thinner flap, and that's how the flap comes up. Okay. So now I said we should fry when it's dry. So I'm going to make the cornea as dry as possible. Nancy, I need your cooperation now, Nancy. You have to look into the green light. Do you see a green blinking light, bache? Perfect. And the green is your friend. So it's going to be taking about 11 seconds. This patient is a -7 diopter, and optical zone is 6, so we've taken about 8.1 as a flap size, and the energy we're giving is 1 millijoule, and it's going to take 11 seconds to finish off this procedure. Okay, so here we go. Look into the light starting now. into the green light, into the green light. You're doing very well. So you have to keep the patient edging on to stay in the center. Now that's how it's finished now. So the ablation is over. Hence you've done very well. You see it's very well centered ablation, and you still have about a 1.5 micron zone all around, millimeter, sorry. So that even if you have a cylinder in these ones, 8.1 is good enough for all these practical purposes. So let's see how it fits back. Okay. So see the lines are all straight. Of course there's a cut inside, but it's not distorted. Can you people appreciate that?
Yeah, very clear.
So if this is done, I don't stain it, I'm staining it for the teaching purpose, otherwise I don't stain it. So this is what it is, and that's the end of one eye. And this is the OBL which is on the surface, and OBL does not have any implication on the outcome. And it happens with 180 microns with all of these flaps, so there's nothing to worry about. Other thing you can do is you can just go with a semi-dry sponge, just touch it there, and you look for the edge, and you see the fluid coming in. It looks good to me actually. So one eye is done. Okay, when you take the speculum out, be gentle that you take one side out and the other one. You don't want the flap to be dislodged. Then ask the patient to close the eye, keep the eyes closed, open it up, and then open both eyes, bache. Open your eyes, Nancy, and blink. And blink. Okay, so this looks good. We're going to switch over to the other eye now. So you can have a question in between, Radhika, if you have, because they're going to shift the patient to this side now.
Yes, so in this particular one, was it 80 micron or 90 micron?
No, these Radhika, we're doing 80 in all patients.
Okay.
No, in this one, if it got 90, the PTA would have touched 40. So with
Okay.
80 only, it was coming to about 37 point something.
Okay.
Okay?
Good. Right, good.
So
And
these are the patients which would have gone for the ICL group. Now they have coming back to this one, and we've been doing it for last, I think now about 8 to 10 months. And on the follow-ups, we realized these patients are doing very well. No higher order aberrations are induced as compared to other one. No strias seen. And so the standard procedure of docking the, I've put in the PI, and I started the suction. If you can show from here what we're doing.
the screen can be shown.
You can increase the volume of that one,
The
please.
console, yes. The camera can go a little bit towards the, yeah, that's better.
Yeah, so that's why I finished the first eye so that I can tell you what we do now. So this is how we start actually, right? You can mark it before, you can mark it after the cutting also, because these are the markers which actually allow the rays to go through, and you can actually cut through the marking also. Normally they say that the light doesn't go through and it doesn't cut, but this one can penetrate through this marker. Okay, so that's a green blinking light. That's what the patient has to see, Nancy. The only thing is machine doesn't have an accelerator, so it comes, the bed comes up a little slow. Well, that's the way it is. Now, the three things which are most important here are exposure, exposure, exposure. When the patient is coming up, I'm trying to see if you can show this picture that the eye should be aligned and the nose should not be in the picture. Can you show this picture? Can you see the screen, outer camera?
Yes, we can
Okay.
see.
So now I'm coming close. Because the suction is too soft in these on this machine, so we don't want any confusion. See the eyes rolling up, so I'll just pull the chin up a little bit and roll it to the outside. Okay. Now the patient has to look into the green light. Okay. And just before you dock, you should wet the, no, bache hilana nahi. Nancy, you're doing very well, bache. Okay. So wet the cornea. Cut when it's wet and fry when it's dry is what you should remember. So I'm coming close. Nancy is going to touch your eyes for a few seconds. Perfect. She's a good lady. Okay. Into the light, bache. Now see, she's looking right. I already got the application. Now see, Radhika, I'll put the suction on it. It looks perfectly centered. That looks good there?
Looks good.
Perfect. And 17 seconds to go, and we're going to start it now. So you see it starts from the periphery. There's a little OBL which is coming, but that's okay. It doesn't have any implication, doesn't stick, doesn't hold on. And sometimes the OBL goes outside the cut margin also, even that doesn't have implication. And very good. So the 80 micron flap has been cut. Now I'll bring the patient under my microscope and put the mark again, just to be on the safer side. For the beginners, I think they should do it Later on, there's no need actually. Now you see the patient, the eye is not in the center. The most clearer down than up. So patient moved the eye. So it should have been in the center. They have more chances of actually breaking off. Give me the marker. So marker, you can just put in a line here and a line here. Okay, that should. Morning, last one, 5 minutes, max 5 minutes. Yeah. Okay, Dr. Tityal is also here. So Radhika, when the patient is shifting from MEL 90, from the Visumax to MEL 90, we always wet the cornea once or twice so that it doesn't get dry. The thinner the cornea flap, if it dries up, it can become a little messy. So we realize that if it always helps you more. And then the patient comes to me. And this procedure is going to be a repeat of what you saw, but anyway, I can't leave the patient with one eye done. So this eye has got a 6 with a 1 cylinder at 170, and his Pachy was 5 and 2. So with 80 micron, it's actually coming very well. We've done enough of the pilots once. Now we routinely have shifted to 80. Again, the lights are coming closer. Nancy, can you see the green light? It's a little fuzzy right now. Yeah. It'll become a little clearer, and just relax. I'm going to hold the eye for some time. You might feel like a little pinch, but that's about it. You're doing very well. Okay. So again, Radhika, you go vertical down inside. Down inside and rotate. And come all the way out and back towards the hinge and downwards. And downwards and downwards, and that's it. So now kholiye bache, look into the light. Shabash. Okay. Now I'm going to make it dry again before I fry it. Yeah. So because it's 6 with a 1, it's going to be about 12 seconds. All right. So green light, Nancy, for you. Good? You good, Nancy? Perfect. So about 10 seconds starting now. Now that's the cylinder taken care of at 170. Bit of light, green light, green light, green light, green light. Into the green light. About 5 seconds more. Into the green light. Into the green light. Perfect. For these higher powers, it takes a little more time, so you have to keep talking to the patient to ask him to look into the light. You see again the ablation is perfectly sent, but light me. Into the light. Don't move, don't move. You see the flap is trying to curl up because it's thin flap, so make it wet again. No problems. And then go under it and just throw it down. See Radhika, I haven't done anything, no manipulation, and still it's gone back to this position. See that?
Yeah, nicely settled back in position, and the lines are well aligned.
Perfect. So my suggestion is that even if it's 80 micron or 100 micron, it will happen the same way. So even if when you push it up, pull it up, you realize it's looking bigger because it gets stretched. It does not get out of its position at all. You can see it's fitting like a slip disc. And that's it, and the surgery is over. And any questions we have, a bit of light, you can ask me now or for later, whatever. I mean, I'm done with the case.
Thank you, Professor Khokhar. Wonderful surgery, excellent demonstration of an extremely thin flap that is 80 microns, pushing the limits of technology and getting good results. Excellent.
Yeah.
Any questions while we're preparing the next patient, which is going to be small incision lenticular extraction by Professor Tityal? Any question for Dr. Khokhar from the audience? Anything you would like to tell about your post-operative regime?
Sure. It's the same. It's the same. Doesn't make a difference. We give steroids, maybe fluoromethalone on the surface for 3 to 4 weeks. We give refreshed any lubricating agents on the eye, antibiotics for 5 to 7 days, and that's it. Earlier we tried it on FS200, which is the Alcon platform for femto, but we realized the moment we go below 100 micron, we used to get bubble breakthrough. At 90 micron, the bubble used to break through and come up. With this machine with 80, it's going wonderfully well. So I'd suggest everybody who has Visumax can switch over to 80. I think my time to step out is here because Professor Tityal is here. And thank you, sir, for letting me do this one. And I think people appreciated the thin flap. So,
oh yes, let's have a round of applause for Dr. Khokhar and the patient.
Yeah. Thank you.
Thank you. So the next surgery is SMILE, small incision lenticle extraction. Professor Tityal is in chair and the surgery will be starting shortly. So as Dr. Sridevi had mentioned in decision making, so at that time you must also gauge the patient's expectations, the patient's concerns, all that you should address in the pre-operative workup and planning, because that makes the patient the better prepared for the day of surgery, and outcomes are much better if patient is on board with all the aspects. Good morning, sir. We can see you.
Okay, a very good morning, Radhika, and good morning to all of you. And we had a very nice demonstration of thin flap Lasik Mel 90. I think it has its own advantages. But looking onto the little modern surgery, that is small incision lenticular extraction, SMILE, which has been there for last almost now more than a decade or so in our practice. Since 2016, it is approved by FDA. Very soon, it will be approved by FDA for a hyperopic treatment also. That is one part which is missing in this Bizumex system. Recently, they have come out with a newer version of Bizumex 800, which has a little different orientation. It doesn't, the patient head is static in that. The laser and the other parts are separate in those cases. We all know SMILE has its own advantages because we don't cut the large flap like a Lasik. So most likely, these patients should have a better biomechanical strength and the stability of refractive error for long term. And other important thing is the dry eye seems to be less in these cases. Therefore, the induced inflammation because of cutting the nerves will be definitely less in these cases. The first step is patient workup, which we had discussed with Dr. Sridevi. It has three important aspects. One is putting proper patient data into the computer, and this is what we call in patient contact lens interface, which comes in three sizes: small, medium, and large. So we are putting a small size interface for patient. It has to be attached to the laser head for calibration. It takes around a few seconds. In the meantime, we'll prepare the patient. So we have Miss Kirti with us. Wet the eye. Beta drop डालना आँख में, ठीक है? Interaction with patient is very, very important in these cases. The cornea should be wet and moist. And the sac, that is inferior, superior congenital sac, has to be absolutely dry in these cases. Because one of the major problems in low section devices like SMILE, the section loss is a major challenge in these cases. But if patient understands better, if you dry the surface more carefully, the chances of section loss is almost negligible. Okay, we are ready now, beta. I'll shift to the green light, okay? Kirti, you have to focus on the green light. When the laser starts, machine will sound ready. And you have to wait for a sound section off. The entire procedure is only 28 seconds. In between, you don't have to speak and don't have to blink. So best of luck, I'm shifting to the green light now. So these are a few instructions which is very important to make patient comfortable. It is a pupil-centric ablation. There is a green light. Patient has to fix on a green light. As soon as you have a two-third applanation and well-centered green light on the green in the pupil, you should press the section and you will have. Infrared light, you can see it is a very nicely centrally fixed. We're going to start a laser now, beta. The light will go off now, don't worry. keep waiting. So laser is completely done in 28 seconds. I think the important part is to have a very nice, smooth OBL formation, which will make the dissection easier. Now the second important part is to do a proper dissection of this lenticule, so that we do a very effective dissection and taking out the lenticule in a manner which doesn't cause too much of a damage to the surrounding structure, that is the stroma and the cap. We will just wet the surface. Can you just pull it down a little bit, Oculus? Yeah, thank you. And dry the area that is near the incision area so that fluid doesn't go inside. So we have outer one is the the flap or a cap. The inner one is a lenticular cut. So we have lenticule and outer cut. लाइट की तरफ देखना बेटा गुड ऐसे रखना so fix the glow with your left hand and just massage this area so that the bubbles go off. So this way you can see this line very clearly. This is the line for a lenticule S. So first we are going to lift the incision so that we can go anteriorly. So first will be anterior plane dissection. So I lifted the incision here. Don't go too much in at this stage. I just lifted the incision. Now I'll go a little anterior towards the left hand side. Open the entire incision, which is 2 millimeters. Now go a little deeper. So you are inside the second layer, that is a posterior dissection. You can clearly see a meniscus sign. So this is an indication that we have separated the posterior part of the lenticule. Now we'll go anterior dissection. Separate the cap. So this is a spatula which is little like a spoon shape, which gives a larger area of dissection. The most important is the pupillary axis. With 2 or 3 strokes, I'll clear the pupillary axis. Reach up to the inferior part, 6 o'clock, then complete the dissection all around. So this will be gentle. See how effectively, very gently, I can just take my spatula.
We just lost the microscope view. Can the OT please try to restore it? We got it. Thanks.
Okay. I'll go again. I'll do an anterior dissection. First, you have to clear the pupillary axis. Then go inferiorly. Then do a complete dissection all around. So this is an anterior plane dissection. Now I'll go posteriorly. Dip it. Go inside. So make sure you see this meniscus very clearly. Once you see meniscus, you are inside the flap, inside the lenticule. I'll do a refractive axis clearance first, that is pupillary area, then go to 6 o'clock, then come to 3 o'clock. Take another meniscus here, then go to another area, that is 9 o'clock. Complete that area. So I have a fulcrum all around so that I can do a very nice dissection to the adjacent areas. Now complete this edge, then come to this area. This completes the dissection. You can just move the lenticule in a way and just pull it out. This is the lenticule edge. You can hold it and pull it. Towards the end, you have to examine this lenticule for its completeness so that you don't leave the edge. So 90% of the time, you don't require a forceps to be used in these cases. And the complete lenticule is there. So this surgery takes very little time if things go wrong correctly. That means the most important thing is dissection anterior, posteriorly, and identification of the lenticule edge. If you do it correctly, you are through with the surgery. Towards the end, we'll put 1 drop of antibiotic. Normally, we don't irrigate the interface. There are many people who irrigate the interface also, which is not really required in these cases. Okay. Post-op treatment is almost similar to any Lasik patients, which we give a steroid and tapering doses for up to 3 to 4 weeks and lubricant for 3 to 6 months. And normally within the first day, the patient are 6'6", and they keep improving subsequently as the time passes. Okay.
Thank you, sir. That was
Yeah.
an excellent surgery. Very nicely demonstrated all the careful steps to be followed. Anybody in the audience has any question?
As I said, the basic difference which has come in the new system is, apart from the entire system being under one unit, now the patient bed is static, and they have one computer parameter, laser head and microscope head. I think three things have become now different, and the machine has become really faster. The entire procedure for laser takes hardly 6 to 10 seconds. Therefore, the chances of suction loss are totally gone off from the picture now, which was a major concern for many, many people. And the new system will have two more advantages. One, it will have a tracking system, so that whatever iris tracking, pupil tracking you can do very easily in these cases, especially for a higher degree of astigmatic correction in these cases. And the third important thing is once you have treatment so fast, things will be easier. Is the third case ready? Better. So today in the refractive live surgery, as Radhika would have told you, we are covering the entire range. We started with a thin flap Lasik, which has its own advantages and indications. Took back to the lenticular based surgery, that is mild. Third, we are going to take you to the topography guided contour vision surgery, which also has a significant clinical importance in many, many cases. So we are trying to cover all ranges of laser refractive correction today. Thank you. Now we will shift to the other OT.
Thank you, sir. So we'll go ahead with the next step. We have Dr. Namrata, who is going to be demonstrating the Contura Vision Lasik. Namrata, are you ready? Should we?
Yes.
Yes. Okay. Good
Yes,
morning.
I think Dr. Priyadarshini, can you tell about the case first?
This is a 21-year-old female patient who presented in the refractive clinic for cosmetic purposes. She had no history of contact lens use, and the last check power of glasses was 6 months back, which was found to be stable. The uncorrected distance visual acuity in the right eye was 6 by 60, left eye 6 by 36, and the best corrected distance visual acuity was 6 by 6 in both the eyes, with a PMT of minus 2.25 diopter sphere and minus 2 diopter cylinder at 15-degree axis in the right eye, and minus 2.25 diopter sphere with minus 1 diopter cylinder at 170-degree axis in the left eye. The pentacam maps in both the eyes were found to be within normal limits, and the epithelial maps were also done and were found to be normal. So we went ahead for a topo-guided planning in this patient, and the prerequisites were found to be fitting in this patient. This is the overview of the Topolyzer capture. We can see that the manifest cylinder and the measured cylinder are within the prerequisites of 1.25 diopter difference in both the eye, and the axis is also within the prerequisite limits.
I know.
These are the comparative examinations of the various maps taken for both the eyes, and they were found to be comparable.
Okay, so can we have the microscope view now? Or can we have the external view?
Yeah, external view is visible and you're audible.
Can you show here, please? So what we've done just now is that the diode lights, which are two lights in the center, they are brought to the center and to the periphery. And can you focus on this? This is the interface which is being inserted. So you put the interface first. Contura Lasik is basically contura planning. So it is done, the Lasik is done in a normal way that you do, but planning has to be done on a Topolyzer or contura, as Dr. Priyadarshini highlighted. Now after this, we are just waiting for the alignment to happen on the machine. ये दिखा देंगे जरा. So I think that has happened. So we remove the patient interface as directed by the machine. अब microscope view दिखा देंगे. And then we are just placing the suction ring. Suction on. So after the suction is on, ये दिखाना, screen दिखाना. The first suction is on here. So we insert the PI and then center the entire thing. And then get it down. You have to make the second suction active now. So now both section 1 and section 2 are green in color, so you know that the second section is on. Now Dr. Priyadarshini is just adjusting the flap to center it on the pupil. This is of prime importance, especially in contour Lasik. Are we ready? Yes, sir, ready. So we are now just going to make the flap and fire on the laser. At this point in time, your foot from the suction pedal should be miles away, because inadvertently also you should not touch that. And so our flap is complete. And on the swivel machine itself, the patient, there's a swivel bed there. The patient is going to be moved to the laser machine, which is our EX500. ये external दिखा देंगे, external दिखा दो ये how the patient is being moved. Can we just see here? So the patient, वो करती है sister. So with the swivel machine, the patient is now being moved to the excimer laser machine. Yeah, this. So light on, please. Now we just have to focus it. Microscope view. And you have to get, there's a green light and 2 red lights. बेटे आपको red light दिखेगा, इसी में ऐसे ही देखते रहो आप. So you have to put that green light and 2 red lights into focus, so you can focus on the flap. And now you have to elevate the flap. हिलाओ नहीं. So this comes in one go. सामने देखो बच्चे. Just wait. I'll show you the red light. Can you see the red light now? So you just elevate the flap. And you have to get that green light, green blinking light and 2 red lights all in one. Then you have to confirm the center of ablation with the foot pedal. So the pupil is centered. And now we are just going to fire the laser. And so now the laser is fired. You have to put the this flap back. बच्चे आप don't move your eye. Just you can see the red light. Just keep looking into this red light. Just put a drop of fluid here. Don't put too much, otherwise it will go into the fornices and then it will come back again into your interface. So little bit of fluid here just to smear it. Then go behind this hinge and put a jet of fluid here, because that elevates your flap, and then just allow it to go wherever it is going without trying to manipulate it too much, because it normally sits back on wherever it is supposed to sit back. Then now I'm using another cannula, because once you've put the flap back, you should not use the same cannula to irrigate your interface. And once I take it out, I'll not put it again because there's chance that you might, you might put epithelial cells inside. So if you think that you have to wash a little more, use another cannula. After taking it out, don't put it back again. Now she has meibomian secretions, which you can see, and all that you have to do now is just deposit this flap back. So it is quite stuck there. Dry then. And then you can also just dry the edges a little bit so that it gets stuck where the gutter is. Can we see the slit lamp? Can you put the slit here? So you may also put a slit here just to see, just to see what is the status of the flap, whether it is attached or not. This machine has this slit, and so this is the advantage of using this. Can you put it back again? Light on please. And now we put antibiotic drop. Aap samne dekhte raho, you are done. You did really very well. Okay. And then after putting this antibiotic drop, can we decrease the magnification? When you are taking out the speculum, one has to be very careful because again you should not be hitting the flap. So elevate your speculum a little bit and then take it out like this. And then when the patient leaves, 1 minute, ऐसे don't bring your hand up, and आँख खोलो, बंद करो, खोलो, बंद करो, good. So she's done for this eye, and if there are any questions, I would be happy to answer them. Patient can be shifted.
Thank you very much, Namrata. That was wonderful surgery, beautifully demonstrated. Any questions for Dr. Namrata from the audience?
So basically about contoura is the contoura planning, and you have to see whether your patient is fitting into contoura planning or not, and you have to actually spend some time trying to capture a very good acquisition of images on the Topolyzer. I think that is the most important thing. And your optic zone should be kept at 6.5, and the entire area with the Topolyzer should be covering more than 90%, and you should have at least 4 such images. And once you have those images, then you get the entire data into the this machine, which is our EX500, which is our laser machine from the Wavelight. And this data is then imported here, and according to that the machine itself calculates the ablation. Now there will be no problem if there is no difference between the measured cylinder and the cylinder by your Topolyzer. But if there is a difference between your measured cylinder by the Topolyzer and the manifest refraction, then there are some modifications which have to be made, and you have to feed the data likewise. And the company itself has given the nomogram as to what changes are required. So you do those changes and then you feed the data again into the machine.
Yeah, Namrata, I just want to ask a question.
Yeah.
If you do 100 patients of contoura, do you capture the image in all? I mean,
no.
How many percentage? 5%, 10%, 90%? I mean, how roughly?
So in 80% of the patients we are able to capture the data, but yes, whenever we do contoura planning in 100% of the patients, we can't do contoura.
Okay. And second thing, is there a contoura machine which people talk about? I use contoura machine. So is there something else?
No,
is it they using EX500 only?
I think, sir, that's a very good question. Like I said, this is a question which is asked by everybody, including ophthalmologists. But there's no contoura machine. It is the normal laser machine which does the excimer laser.
Okay.
Contoura is only planning. So you have to put it in the Topolyzer, and they have a software here. Which actually targets the nomogram, which targets the Topolyzer chart, which is there in the machine.
If somebody has a machine which is not a EX500 and they have a Topolyzer of their own make, like for example Well 98 Zone, so they also have a Topolyzer and they have a
yes,
so it's the same thing.
It's the same thing.
So contoura is just a name for a delivery of the excimer in a particular fashion so that you reduce aberrations, which can be done on other machines also.
Contoura is a proprietary name, a copyrighted name.
Okay. So there is no contoura machine as such.
No,
right?
contoura is basically also topo guided ablation.
Right. Thank you.
Which may be there in all the machines or in most machines rather.
And second thing, when you said that you don't take the cannula back again, I think those were when you're using blade earlier, Hansertome.
Yeah,
but
that was, but then yes,
yeah.
that has been, you know, ingrained so much that
I know.
you try not to do that.
Yeah, because what happens if you have a flap, your flap was what, 100 micron, 90 micron, this one?
110, sir.
Oh, 110? So
yours was thinner.
So it will go and sit back on its own.
Yes,
and you don't actually have to manipulate.
Yes,
unless you have fibers inside or you have a strias which are visible. Otherwise, there's no point in manipulating.
Yeah.
Right.
Yeah.
Thank you. Great surgery.
Thank you, sir. Thank you.
Thank you so much. That was wonderful surgical session. So please, can we have a round of applause for all the surgeons and patients? Thank you. Thank you very much to the OT team. So we now go ahead with some didactic lectures to integrate what we've learned so far. We'll begin with Dr. Manpreet Kaur's lecture on lenticule-based problems. Hey, mic, podium mic, please. The slide screen has also got, now we can see it. Good. Some connection is loose. Please check, come here and help. Laptop ka connection. Yeah. Okay. थोड़ा सा आगे करके देखना मनप्रीत, मे बी इज टचिंग समथिंग, थोड़ा सा अब इसको हिलाना नहीं.
So a very good morning to all of you. I'll be covering the lenticule based problems in small incision lenticule extraction. There are no financial disclosures. So we just saw beautiful smile surgery which went so effortlessly. However, it is not always the case. In fact, the learning curve of small incision lenticule extraction is much more challenging than conventional corneal ablative procedures that we are used to, and lenticule dissection and extraction is one of the most challenging steps. So during suction application, smile per se is a low suction system. It accurvates the cornea rather than applanates. Soft docking is present. So the pressure at the interface is 35 millimeter mercury exerted by the suction cone, which leads to a maximum IOP rise of 30 to 80 millimeter of mercury. So the issue with smile is that if you have an uncooperative patient, the tendency to get a suction loss is much higher. In fact, in novice surgeons, up to 11% cases may have a suction loss, and surgeon inexperienced, uncooperative patient and difficult orbital anatomy all predisposed to this. So there are rescue mechanisms now available if the suction loss occurs at the stage of lenticle side cut, cap cut or cap side cut. You can redock and restart the procedure from that point of time. However, you get a lot of opaque bubble layer, black spots, which further complicate lenticule dissection and extraction. So more than 10% of lenticule cut, if you get a suction loss, you cannot really proceed with smile. You have to convert to surface ablation or Lasik at the same sitting or a later date. Again, lenticule side cut, cap cut and side cut, you have rescue modes available. They do interfere slightly with the subsequent surgery. Difficult lenticule dissection, the pathophysiology one is related mainly to surgeon experience that you conventionally dissect the anterior plane first followed by the posterior plane. In the initial few cases, you may have difficulty in identifying the correct planes even though you are going anterior first, posterior second. Then one important issue that arises is the cap lenticular adhesion, in which you inadvertently dissect the posterior plane first. What happens is the lenticule gets stuck to the overlying cap. Since there is no stromal support now to dissect the anterior plane, the dissection is much more challenging. In fact, identifying the anterior plane when you have dissected posterior plane first is very challenging. You can have a host of complications, including retained lenticule, delayed visual recovery, cap and side cut tears, posterior stromal damage, epithelial defect, and irregular astigmatism. So how do you prevent this from happening? Meniscus sign you just saw during the live surgery as well has been used to identify the lenticule edge in small incision lenticule extraction. What you do is when you are delineating the anterior and posterior lamellar channels initially, you just push the lenticule away from the site of lenticule side cut towards the center so that this frilled edge is created. So this meniscus shaped gap is created and this frilled edge is the lenticule edge. So when the instrument is above this meniscus shaped sign, you are in the anterior plane. When you can see this meniscus shaped sign clearly, it's indicative that you are now in the posterior plane. So how is it useful? As you can see in this case, I dissected the anterior lamellar channel first. Now while identifying the posterior lamellar channel, I was going in the same plane, and if you see this again in slow motion, there is a meniscus shaped gap that was created while what I thought was the anterior lamellar channel creation only. So when I saw this, I just nudged the lenticule at the side of side cut only from the overlying cap. So this prevented a cap lenticular adhesion that would have occurred subsequently, because this meniscus shaped sign showed me that initially only I had gone in the wrong plane. So then I went anteriorly first, and the subsequent surgery was as any normal surgery. So what happens when you do get a cap lenticular adhesion? Sometime whenever if you're practicing smile, you will get, despite the best of precautions. So anterior segment optical coherence tomography is a useful tool in initial cases if you're not very clear what has happened. So it can show you which plane has been dissected. So here you can see clearly the posterior plane has been dissected. It is more hyper-reflective. The anterior one has not been, and the lenticule is more or less stuck to the overlying cap. This stromal damage when we were trying to find the second plane is also evident here. So you go with a Sinskey or any such instrument, just try to nudge the lenticule gently from the overlying cap, and when you see this meniscus shaped gap, you know that the lenticule was stuck, and then gently you peel it off using dissector or forceps and extract the lenticule. So this is another case in which there was a cap lenticular adhesion. So once I was sure that I cannot find the plane, I just went in and tried to nudge the lenticule off from the overlying cap. A meniscus shaped gap in this case confirmed my diagnosis of cap lenticular adhesion. So I brought this separation to the site of cap side cut, and then created a small anterior channel using this sharp blunt instrument. The dissector could then go in the anterior plane, and in fact recognition is more important than management. Once you know what's happened wrong, you can easily manage it. In fact, the subsequent dissection was more or less similar to the cases in which we go anterior first and posterior second, and I could extract the lenticule without using forceps. Double crescentic edge separation has also been described for the management of cap lenticular adhesion, especially if you use two side cuts as some surgeons use. So you can separate the lenticule, struck lenticule from the periphery from both sides, from the right as well as left hand side, and then gently separate it till the center. So decreases the chances of side cut tears and extensions. So this is another case in which there was a lot of opaque bubble layer and black spots present. So as you can see, the dissection is difficult. Even though we are in the correct planes, it was difficult to separate. A forceps was used to peel off the residual adhesions. However, as you can see, 6 o'clock, there is a significant adhesion present. The dissection is not complete. So the lenticule does come out. On examining, we see that there is a retained lenticule fragment. Very, very challenging to manage, because that retained fragment is not going to come out easily, and it is going to cause irregular astigmatism, which may cause suboptimal vision despite whatever you may do. Now we have also described a stepwise management algorithm for difficult identification of correct dissection plane in smile, so that you can avoid the complications at each stage. Cap tears and side cut tears are a corollary of difficult lenticule dissection and extraction. They are observed in the initial cases up to 16.2% cases cap tears and 1.8 to 4% side cut extension and tears, and they are mainly due to extra manipulations, and the bulky instrument hub gets entangled at the side of side cut, and you tend to ignore the proximal edge, and you're so focused on the distal edge. So bandage contact lens and lubricants usually suffice. So patient selection is of course important to prevent complications. You should, in the initial few cases, choose clean cases with a relatively higher magnitude of refractive error, so the lenticule is not very thin. Avoid uncooperative, anxious patient. Microscope integrated IOCT has emerged as a useful tool to visualize the dissection planes in real time. Disadvantages, it's not as yet integrated in the smile machine per se, and shifting OT may not be very comfortable for both the patient and the surgeon. So just to sum up, the initial learning curve of smile is surgically challenging. So during laser application, you can have suction loss, black spots, and opaque bubble layer. During lenticle dissection, missed dissection with cap lenticular adhesion, cap and side cut tears, and retained lenticule may be observed. Prevention, of course, is better than cure. However, complications are inevitable. Timely detection and management give both the patient and the surgeon a reason to smile. Thank you.
Thank you, Manpreet. Any questions for Dr. Manpreet? Thanks a lot, Manpreet. Very nicely demonstrated. So we're going to, supposed to have a lecture on flap-related complication by Dr. Namrata, but she's going to be coming from the OT. So I'll talk about retreatment after LASIK and smile. नहीं आएगा हमारा Yes. Good morning, everyone. I'm going to talk about retreatment after LASIK and smile. So when we plan the surgery, we go ahead with the idea of full correction of the refractive error. But there do come situations where you do have to take the patient up for retreatment. So either it could be an incomplete treatment because during the steps of the procedure could not be completed as planned due to some unforeseen circumstance. Or it could be a successfully completed procedure, and then again there is some reason for which you have to take the patient up for resurgery. Under incomplete treatment, as we have been discussing before, we are concerned about suction loss, excessive OBL formation and so on, where maybe the flap could not be completed, or during the laser delivery there was some mishap and the surgery could not be done as planned. And a successfully completed procedure, it could be that there is a residual refractive error or there is a regression and a reappearance of a refractive error. And therefore, the procedure that you may consider would be an enhancement. So this is broadly the situations where you go for retreatment. When we talk about LASIK enhancement, what does it mean? It's a kind of a touch-up or a fine-tuning or a retreatment or to tweak or tune up the residual refractive error. These are the various terms which have been used, and this is how you can explain to the patient. And what are the options? Basically, it has been reported to happen in about 3 to 5% after even microkeratome or femto-LASIK. And you should have a discussion of this with the patient at the time of the first surgical planning. The simplest way to tell them is that there is no 100% guarantee because there is physics and then there is the human biology. There are many factors. So just always introduce this concept in the patient's mind that every effort is to give you the full correction with a short first treatment. But you have to be mentally prepared that sometimes you may have these situations coming up. Now, if you have a patient who has had the surgery and now you have to go ahead with retreatment or enhancement, either you can cut a new flap or you can lift the old flap or you can go for surface ablation. Generally, lifting the old flap is simple, but you may have to avoid if there was a previous buttonhole, if there was excessive scarring of the flap edge, a decentered flap, incomplete flap, or striated flap. These are the situations. And then surface ablation is also a simple option which can be resorted to. When you're going ahead for the intervention, again, you can broadly divide your decision making into two broad categories, whether it is within 1 year or it's a late enhancement, which is say after 3 to 4 years. And here again, if it is within 1 year, you look at what is the situation. Remember all the steps which Sri Devi told you, because that is again what has to be repeated. You have to see what is the safety and do not compromise on safety. You have to see if there's adequate corneal tissue. You can lift the flap and treat as you have seen in the OT. And if it is late enhancement, for example, patient comes back with regression, then later on, remember that there is a risk of a flap lift leading to an epithelial ingrowth, and surface ablation is a good option, but there is a possibility of haze. So you have to consider using mitomycin C in such situations. Once again, I would like to emphasize that when you have a situation like this, be clear whether it's a regression or a residual refractive error, or whether it's actually a post-Lasik ectasia that you are dealing with. If it's post-Lasik ectasia, then it goes in a totally different direction. You have to do cross-linking, let the patient stabilize, and then decide what to do with the refractive error. So coming to smile retreatments, as Dr. Tityal and Dr. Koka were mentioning, these are considered as a little bit of a downside of smile surgery, because doing repeat treatment is not very easy to go ahead with the same smile procedure. You have to opt for other options. One option is you have to do surface ablation, which could be with mitomycin C. You can go ahead for the Lasik, where the flap thickness can be less than the cap thickness. And you can also use the Circle software, where you can convert the cap into a flap. So Lasik has an edge over smile currently for the ease of retreatment, and therefore if you have a platform of a refractive surgical practice, you really do need to have both options available. However, with the smile surgery, you do have now the MEL 90 platform, where you can do LASIK surgery using the same laser equipment. And this is an example of what the Circle software does, where it just makes a full 360-degree circle around the cap and converts it into a flap. Here's an example of a case. 27-year-old patient, he came for refractive surgery for cosmetic reasons. He worked in an IT company. He had used glasses since the age of 17, and he had a stable power for 2 years. He did give a history of occasional contact lens wear, but he had not worn them for 3 years, and he had no other contraindication or any problem, no previous refractive surgery, etc. He gave no history of contact sports or any active participation in any risky activities, and he had no history of any acne medications. Whenever you're looking at a patient for refractive surgery, always look at the uncorrected visual acuity. This is particularly important if you're looking at hypermetropes, because myopes, the uncorrected visual acuity is always poor, but in hypermetropes, it may even be 6.9, may even be 6.6. So this is something which is important, because the purpose of the refractive surgery is to give you excellent uncorrected visual acuity. So be little careful in hypermetropes, and also the outcome of hypermetropic treatment is not as perfect as you would expect as you get with myopia. So this again you need to discuss with the patient, and also there's a limit to how much you can correct the hypermetropia. Look at the BCVA. This was the BCVA, near vision, the power of glasses, the cornea. The patient went for surgery. The tear film assessment was fine. And on examination, all his parameters, as mentioned by Sridevi, were absolutely fine. Went ahead for the surgery. This was the calculation which was put into the laser machine. His percentage tissue altered was also going to be within the normal limit with an adequate residual bed thickness. So both eyes, femtosecond laser surgery was done on the 12th of March with a standard optical zone. And during the right eye surgery, unfortunately, there was a suction loss and an incomplete flap was created. So surgery was discontinued. Patient was happy to go ahead with surgery for the left eye, which went uneventful. And we had planned that we were going to do for resurgery for the right eye after a few weeks. However, that is the time when COVID-19 struck and the patient was not able to come for follow-up as planned, and he then came for follow-up about several months later. It was November. Complete refractive surgery workup was then done, and now he had an uncorrected visual acuity of 5/60 in that eye. 6/6 was uncorrected in the other eye. This was his near vision. The power was -3.25. The flap was seen. This is what the patient looked like, and this was the keratometric value and the refraction, and again we looked at the maps. Everything seemed safe to go ahead for surgery. We also did the Corvis, and the biomechanical parameters were also within the safe limit, and the AS OCT also showed that there was a complete healing. So in this particular patient, for resurgery, we plan to go ahead for a standard treatment, a flap diameter of 9, a flap thickness of 110, optical zone of 6. Resurgery was successful and uneventful, and the patient had 6/6 vision the next day, 6/5 vision the next day, and was absolutely fine. I'm just going to show you two brief videos of different situations where you may have to take the patient up for resurgery. This patient had a very tiny microscopic speck in the interface, which normally was not producing any inflammation. It was quite quiet and inert and could have been left as it is. However, the patient was quite troubled by ghosting, and as a result of which, can we have the video again? Anyway, running short of time, I can show the video later on. Basically, it was a case of a small microscopic foreign body. He was having trouble with ghosting of the image. So the patient was taken to the OT for lifting of the flap and removal of that foreign body. Why is it not working? नहीं आ रहा देखो. Recent, ये है presentation. वीडियो इसी में है. स्क्रीन पे नहीं आ रहा. ओके. ये है वीडियो इसके लिए. So he had ghosting. We discussed the issue with him, gave him some time to see if it would settle down, but the patient was very specific that he had a ghosting, a kind of a doubling of the image, which was corresponding to the location of the foreign body. So just to show you that if you had to go for retreatment also, this is how you would lift the flap. Be very careful, keep the cornea nice and moist, and that was the location of the foreign body, highly, very, very fine. It was actually a small fiber which was not producing any inflammation, and it was pretty difficult to visualize even on the slit lamp and even on the microscope. And as you can see, when you lift the flap like this, sometimes there will be a small speck there, and also you must check on the location of the flap as well. It's a very tiny foreign body, which then I thought I had got rid of it, but then I saw that it is still there on the flap. And then using the IOCT again, trying to locate it, because often with the process of using lubricating drops, often the foreign body may get misplaced from its actual location and go somewhere else and get stuck on the stromal bed. So as you can see, it's there on the flap. And IOCT again is being used to, confirm this location, locate it exactly, identify it, and then remove it, and it was replaced back. And here I felt it was still there, a small little speck, because often if you leave a little time, it may disintegrate during the removal process as well. So again, use this time a micro forceps to actually lift it up. And you have to be very careful, keep changing your instrument so that any instrument which has touched the epithelium does not touch the stroma and the interface. So you don't introduce any epithelial cells and lead to epithelial ingrowth. Then you irrigate the bed, and then bandage contact lens can be put. And then reconfirmation with the IOCT that the foreign body had been taken care of. And this is another example of a patient who had fiber. Now this patient came around a fortnight or so after the procedure with a very big clump of cotton. She had been using dry cotton to wipe her eye instead of wet wipes. And you can see there's a big location of a cotton ball there, which was then removed. And again, the care being taken that there's no residual fragments, and then irrigation of the bed, and then bandage contact lens has been put. So you have to be careful with retreatments. Again, explain to the patient the purpose of the surgery. And I'd like to acknowledge Neha and Kusumita for editing those videos, and thank you for all the SRs, JRs, and the staff. Thank you. With that, we go ahead with the next presentation on flap complications.
Okay. It's nice to see a full hall face-to-face physical with a lot of people who are from outside RP Center. So I would be talking to you about flap-related complications of Lasik surgery. Can I duplicate this here also? इसको भी duplicate कर दोगे? नहीं, ये नहीं चाहिए, यही चाहिए. Thank you. So all these flap-related complications related to the videos that I would be showing are actually ever since we acquired laser, which was almost in 1998. So you can't make all the complications. You can't afford to make all the complications in patients who are, 6x6 and who are young patients. So it is best to see how these are managed so that when you have them and as you have them, you know what to do. So flap-related complications, notice that the incidence is very less and it's much less than that is shown here. This could be a buttonhole, thin, irregular, incomplete, eccentric, dislodged flap or a free cap. The buttonhole flap can be superficial when it occurs at the level of the epithelium and Bowman's membrane complex, or it can be full thickness like this, which is a classical buttonhole. So the factors which are responsible for any abnormality in the flap are steep, flat corneas, deep orbit, conjunctival chemosis, inadequate suction ring placement, lack of synchronization between translational keratome movement and oscillatory blade movement, and more importantly, damaged blades. Whenever you have a thin or irregular or buttonhole flap, important thing is to know that you have one and then you defer surgery. Recut after 3 months, or you can even do a surface ablation, provided the refractive error allows you to do so. So this is a spree of buttonhole flaps that we had, and notice that there is a central hole flap there. So we had to just put it back again and align it with these Genesian violet marks, which have been pre-placed so that you know where to align after washing it. This is yet another buttonhole flap, again present in the center. So you have to again put it back again. And this is a third case, which was a post-PK Lasik we were doing, and this is a Z-shaped flap, an abnormal, odd kind of a configuration, mainly because the corneas are very steep. There can also be epithelial ingrowth in the buttonhole flap. So you can see that these are epithelial cells. We've been talking about it, that epithelium may go in, it may go in. So that is something you have to avoid. So when that occurs, one can even do a surface ablation, which will take care of this haze which is there and will also take care of the epithelial ingrowth of the cells that are there, as is shown here. You can have an incomplete flap because of the microkeratome jamming, which used to be there when we used microkeratomes, suction loss, drapes, lashes, or loose epithelium which come in the way of the microkeratome, or the precipitated salt of irrigating solution. And basically you have to look at the hinge. So if the, So if the hinge is peripheral, you can still proceed with the ablation after protecting the hinge. But if it is mid-peripheral, then one has to, or it is central, you have to reposit the flap back and you have to recut after 3 months. And if you've used a 160 or a 120 microns, it has to be at a deeper level and it has to be a larger flap. This is for microkeratome flaps. For femtosecond flaps, it is different. So this is, for instance, a torn hinge which is present in the periphery, and because it is in the periphery, one can still go ahead with the ablation. It doesn't matter. Only thing is, in the post-op period, one has to be careful because diffuse lamellar keratitis can occur through this epithelial defect and also through this torn hinge, and also there can be epithelial ingrowth. Then you can have a dislodged flap like this, which can be there in the post-operative period or even intra-operatively when the patient squeezes or you've suddenly removed the eyelid speculum without considering the edge of the flap. So all that you have to do is relift the flap, clear the undersurface, deposit the flap back, and there has to be prolonged drying time because the flap is, you are relifting it for the second time, and place a contact lens. Then at times you can have a eccentric cut. So the cut has become eccentric. Again, used to happen more with the microkeratome flaps, not so much with the femtosecond laser flap, because you can see the configuration of the cut itself. And again, when you have this eccentric cut, you have to see whether the optic zone is allowing you to do a laser ablation or not. If it is still within the optic zone, you can still go ahead and do a laser ablation. Then you can have a free cap. That means the hinge also comes out along with the flap. And this commonly occurs in the flat cornea. So if it is lost, then you allow for central reepithelialization to occur, defer the surgery, and whenever refractive stability is there, you can plan another procedure. But if it is retrievable and the size of the free cap is larger than that of the optic zone, then you have to do laser and reposit it after putting a bandage contact lens. But if the size of the free cap is less than the optic zone, then again you have to defer a surgery for a later date, which could be 3 months. Now this is a case of a free cap. So this was a case of a free cap in which the cap was there in the microkeratome itself. So that was retrieved and it was placed again, looking again at these blue marks. You can align them, and it is very important to always mark your flap. For instance, in this case, the ablation is still, continued just as one would do. And then after doing the ablation, one retrieves the free cap from the microkeratome, and then you realign them into your previous positions. And again, one may need to put sutures, or one can just put it like this with a bandage contact lens, and it gets quite stuck. We did publish this refractive outcomes of Lasik after flap complications, and if managed well, there is actually, in terms of visual outcomes, no difference. Then post-RK, when you are doing these cuts, these wedges, they tend to split. And again, in the post-operative period, you have to be careful that there's no epithelial ingrowth through these wedges. You are able to lift the flap, that's not a problem, but the split in the wedges may be there. Again, this is our publication, Lasik following RK, where we showed that the results are quite good. Then you can have, in the post-operative period, flap folds, and these have to be dealt with again, and this can occur more in the high myopes, hypermetropes, because of the tenting effect. They can be macrofolds or microfolds, and I think most important is that if they are visually insignificant, then do nothing about it, even if you are seeing them. But if they are visually significant, then you will have to refloat it back using hypotonic saline or deionized water, because that causes the flap to become a little edematous, and then it reposits its back into place. Then you can have these things in the slit lamp, which you can see. There can be a fiber, there can be meibomian secretions, there can be epithelial defects, but actually you don't have to do anything, because over a period of time they do disappear, and for the epithelial defect you can place a bandage contact lens. This is just to show that at 10 days there was a fiber in the interface and how it becomes a skeleton of itself in 1 year time. So even if you leave it there, it doesn't matter. Then you can have diffuse lamellar keratitis like this, that is in the interface. There is meibomian secretions, debris of the bacteria from the lids, etc. That is there, and this can be quite a bit in some of the cases. All you have to do is topical steroids and topical antibiotics very frequently, and it does respond over a period of time. Then you can have the buttonhole flap with infections, such as in this case. The flap is quite edematous. Now, all that you have to do is sacrifice this flap, because even if you put this flap back, it is not going to get stuck, and the healing is not going to occur. Of course, in all these cases, you should take a scrape, send for microbiology, and treat the case medically. This is how it healed. The best corrected visual acuity was 6/60. This is the publication of the same. Then complications can also occur after femtoLASIK. This was all about microkeratome LASIK, and femtoLASIK we showed you in the morning today. There can be air bubbles which are present in the anterior chamber. So when you are trying to make a flap such as this, there's an opaque bubble layer here, and there can be air bubbles. Now, if there is an opaque bubble layer here which is not obscuring the visual axis, you can again go ahead with the laser. But if this OBL is obscuring the visual axis, or your air bubbles are there, then you have to put the air tracker off, because the tracker has to be off. Otherwise, the laser is not going to fire, because the tracker detects these air bubbles. So you have to put your tracker off, and you can again do laser ablation. Then this was about the opaque bubble layer. This is less now, because we have increased the size of the hinge. So if you increase the size of the hinge, the OBL will be much less. Then there can be vertical gas breakthrough. Sometimes what happens is that there is a vertical gas breakthrough of the laser from the laser machine, and you get a black area like this. So whenever that black area is there, that means it's not cut. So it will be a difficult task to cut this now, because there is no femtolaser actually has not penetrated, and there is no flap there. So it is always better to defer such surgeries. Now, there can be suction break in incomplete flap. So when the lamellar bed treatment has been completed and there's no side cut, then the procedure can be completed immediately. But if it is there while making the side cut, then again do not lift the flap. Now here it is opposite. For microkeratome flaps, you went larger and deeper. But for here, you treat with a smaller flap, but you go deeper. So it is smaller and deeper here. Now then, this is just to show the suction loss, how it can occur. Now whenever the suction loss occurs, as soon as you detect that there is a suction loss, immediately you should stop the procedure. In this case, the procedure was not stopped, so you have that odd looking flap. And this is the surgery which was done at a later date after 3 months, because you have to allow that to heal. And so on, a flap is now forming. But then this is just to highlight the fact that there can be two edges, one the previous cut edge and now the second edge. So it is present in the periphery, so it actually visually doesn't make too much of a difference. But then these two edges can be there, and you can actually appreciate them in the post-op picture. So this was your original one where the suction loss occurred, and this is your final one where you've actually done the laser ablation. So to conclude, flap-related complications do occur both with the microkeratome Lasik and femtosecond Lasik. They are best diagnosed timely and managed appropriately, and it is best to learn from other people's mistakes rather than to make all of them yourselves and learn. So thank you very much for your kind attention.
Thank you, ma'am, for a very comprehensive overview of flap-related complications and a wonderful collection of videos.
They are not mine, they are everybody's complications.
So I said collection. So we go back on the live surgery session now. May I call Professor Vanathi, Professor Tushar, and Dr. Praful on the dais, please.
Yeah, good morning, everybody.
Good morning, sir. We can hear you.
Perfect. So give me a cue when I want to start, right? Whenever it's my time, just let me know, please.
So you on the screen, we can start.
Yeah, but is it my time?
Yes, sir.
Well, most of the people are on the screen, but it's not their time usually. Okay, so we'll send you a presentation first, yeah.
Yeah. So the first,
Aishwarya?
the first patient is a 4-year-old female child whose mother complained of child keeping objects close to face for a year. The child presented to RPC where she was diagnosed with both eyes subluxated lens. The visual acuity in the right eye was 624 improving to 6.6 on refraction and 5/60 improving to 6/36 with a near vision of N10 and N18. The pupil dilated well up to 5 to 6 mm in both eyes, and lens showed a clear subluxated lens in both eyes. The aphakic refraction in the right eye was around +16 and +14 in the left eye, and phakic was around -18 in the vertical and -9 in the right eye and -14 and -16 in the left eye because of the lens. We can see the slit lamp images of both right eye and left eye showing subluxated lenses. The biometry was similar in both eyes of axial length 23.15 in right and 23.54 in left. The keratometry was also similar with a 43.5 in right with a steep axis of 45 at 111 degrees and 43.7 in the left with a steep axis at 62 of 45.18. The calculated IL power in the right eye was 19 diopters, which is a 3% undercorrection for the age, and 18 diopter in the left, which is 3% undercorrection. Last OT, we operated the right eye, where you can see the intraoperative UBM images of the right and the left eye showing clear subluxated lenses. Today we have planned a left eye lensectomy with a retrofixated iris claw IOL under GA. Over to you, sir.
Right. Thank you, Aishwarya. And hello. Okay, so I'm going to start. So this is what you see from the microscope. Can you see the microscope image now? Tushar?
Yes, sir.
Prafulla? Whatever. Okay. So my first incision going to be with my left hand because I'm a right-handed surgeon, so non-dominant hand. One incision and two incisions, one opposite. So this are basically meant for so what I've done is I've gone all the way into the lens here. You saw that?
Yes, sir.
And that's my technique of interlenticular aspiration. So let's see if I'm able to demonstrate it today also. Okay. All right, so here we go, one incision here and one incision there. All right, a dash of adrenaline. So put in a dash of adrenaline so that the pupil dilates, all the receptors will get saturated and they'll open up the, okay. Yeah, it's opening up slowly. So now I'm going to do is, I'm going to put a little methylacetylene at the edges when I put my probe in. So I'm surgery, my surgery is going to be for a lensectomy, to remove the lens without letting it drop into the, if they can quite, into the vitreous. You can see the stretch zonules there, and Prafulla, you on the other side, right?
Yes, sir.
So just stay connected, and whenever you want to ask something, please go ahead and ask me. So I'll go inside first and take the bubbles out so that you guys have a better view. Okay, so bubbles are out. Alright, so you can see two openings. What do you do when you see opening? You go and plug it. So I'm going to put my fluid inside one and my aspirate the cutter from the other one. The cutter is on the IA cut mode, and I'm going to aspirate this lens out. So that's how I start. My suction is 500. And this you can do in any machine actually. You don't have to have a fancy high-end machines for this. Dr. Arshad, can you please talk a little softly? Sorry. Okay. So Dr. Arshad is an anesthesia in charge, and our life hopelessly depends on them, and he is such a great person, because without GA, we can't show these cases to you. We can't do these. Okay. So what I'm doing is I'm just trying to aspirate it in the bag. If something comes out, you can just step out, tuck it out, and then go back again. Posterior capsule should open only and only when you want it to open. Till that time you should be in the bag only. You see the cortex is coming. You can see the edge, the shining edge, telling you the edge of the lens, nucleus rather. Okay. First we thought we'll pick up a phakic patient and show it, but I thought you should know how the phakia has been created. So if you get these patients, you should be able to manage them. So simple, slow and steady. May not win the race, but yeah, it'll
you already won the race, sir.
Namrata has come back. Your flight landed on time, madam?
Yes, sir.
Good, very good. Welcome back.
Just in time to...
I know, I saw you come, Rashid. No, you were some stamina, madam. Okay, so what I'm doing is I'm just staying put, staying calm, and smaller patients need more patience on half of parents, the doctors, and everybody, because if you try to push them, so see what I've done, we've done the anterior, you see the anterior opening, and little cortical frills, I'm going to take them out. Okay. Okay, now this is the time to eat this up. So cut IA, please. I'm going to do the cut IA mode with the same hand pieces. I'm going to eat up the bag, the vitreous, and vitreous is already fluid in these patients most of the time because the morphinoid, beels, all these patients, spherophakia. Morning, Dr. Radhika. My peripheral field actually picks up people more than the central field, so.
Yes.
Magnocellular and parvocellular. I know. Okay. So the trick is when I'm going to cut this frill at the back, I'm going to put my probe cutter upside down. See, my cutter is facing downwards. I can eat it up without problem. I have burned my fingers about 15-20 years back, and my residents do it, but then they learn it and then they don't repeat the mistake. And it's a good idea to remove all the membrane from the at least 3 and 9 o'clock, because that's where the lens is going to be parked. So if you leave the membranes, they might get fibrosed later on and cause issue. So most of the vitrectomy is done now, and what I do is I just sweep it. I just sweep it under here, and I sweep it under here. So there were 2 incisions, and nothing is stuck onto the wound. So I'm good. Now this is the time when you put little helon onto the iris. Onto the iris, make the chamber go a little down, and onto the iris on the other side. So the 2 incisions, I'm going to make 3 more incisions now, and we are. These first 2 incisions are basically to facilitate me to perform the tucking. So they don't go straight, they are actually at angle. So this is the angle you should make. Okay, it's 1. And the second one comes talking here. Radhika. That's the second one. So you hold it and just go all the way in. Okay. So the 2 done. Now the third incision from where the lens has to go in. This is a 5.2 millimeter lens. It's a rigid PMMA lens. So make a little valvular attempt. And that's when you put the helon, that helps you. It might ooze a little bit. And if it's a bigger kid, you can actually do a scleral flap also in these ones.
So what is the size of this incision?
Incision, I'm going to make it a 5.2.
Okay.
So that's what the lens size is. Okay, so this is a 2.8 first, and then I'm going to enlarge it by a 5.2 blade. Okay. Give me a 5.2. Okay. You see, I haven't put a pilocarp in yet. Okay, so that's a 5.2. I'm going to just enlarge it. Oh, this is a better blade. Yesterday we had the other blade which was not working well. So at this stage, either you can put pilocarpine or you can put the pilocarpine later on. So I have my own technique, so I'm going to just follow that technique and I'll tell you what I do. I'll use the pylo a little later. Give me the lens, please. Now this is a lens which actually is a copy of an artisan lens. It's an Indian make, comes for about I think 1100 rupees or 1200 rupees, and it works wonderfully well. So the lens, please. So this lens has come in now. Since I'm putting retro, I'll have to put the lens upside down. You see that's convexity to my left. Flush it please once, and concavity towards my right. So the concave one goes upwards. So I'll just push it in and push it in. See, the pupil is too much dilated. That's okay. I'll tell you when we want to constrict it. This is not the time. Okay. So I've gone in the blue stick. Now I use a manipulator to put it in its final parking place. In front of the iris first, and then the same thing will be tucked behind.
Why do you defer putting pilocarpine, not put it now and do
Yeah.
it later?
One, the pilocarpine is not freely available since the people have started marketing it at high cost. Second, when I manipulate this iris, the lens, sometimes the pupil starts constricting on its own. I don't want it to be constricted too much. Flush the cornea, please, properly. Okay, so lens is parked. So you can see it's a little more on one side. So this is a time when I need a little pylo. So sometimes with the manipulation itself, Namrata, the pupil constricts a bit. Okay. So then you can avoid the pilocarpine. But in this case, I'm doing it. So, okay, now I put in a dash of pylo from the side and just wait for it to settle down. And you see the pupil started coming in, especially on the left side, you can see, even the right side. If you notice, there's a little atrophic margin seen here. The pupil has a little atrophic margin around it. Okay. No, give me the lens, helon first. Okay, now I want to push this lens back, so I would like to put little helon in the front, not behind the lens. Okay, so now this is a needle I'm going to use to tuck it in, right? And I'm coming from here, holding my lens, and my right hand is the most important here. It has to hold it firm, so my left hand goes inside. See that it's so easy to go this angle, and now I go behind it, and I'll push the lens upwards. See the lens coming up, it's telling you where I am, and one side is done. That's why I wasted more time earlier, because the surgery doesn't take more time actually per se. So that's why I thought I'll just fool around a bit, because I had 15 minutes to kill. Okay, now see, one is gone.
Perfect, sir.
Yeah, so the second one I'm going to plan now. So this is the same instrument. You just flip over for the right and the left. I'll show you the instruments in some time. I'll use entire 15 minutes, don't worry. So now,
I thought you said I'll give you the entire set.
I'll give you the set. You can take it anytime. Namrata, for you anytime. If anybody wants to learn this technique, they're most welcome. Okay, now I've got a grip again. See, so it's the grip. That hand is more important than the this other hand. So I'm going to just it's at a little tight position. Yes. So give me Adri. Little extra pylo. This is the first time it's happened. So that's why Namrata I started avoiding pylo totally.
Yes.
So this, because for the retro it doesn't work well. For the front one it works very well. No problems, no problems. So I want to see the angulation, and now I'm going to do it. Yeah. I'm glad it's something different has happened. Otherwise it's the same routine thing. So okay, again my left grip and my right hand going inside, and I'm going behind it, and again I want to make an impression. There's a bubble there, but I can see the impression. Can you see that? It's gone in.
Yes.
And that is about it. Even if it's a little distorted at this stage, by morning, once the pupil goes up and out, it starts becoming okay. Give me the suture, please. So basically, tucking is the most important. In fact, I'll be showing a video of a patient in which we did a surgery in a patient who had a iris, the sister suture ऐसे देते हैं, needle तो पकड़ लो कम से, put the needle properly. Needle is not holding. So in that, I'll show how to disenclave a lens which is anterior. So that will be in the afternoon session. So stay tuned. Okay, so I'm going to put sutures. So this is you can put 2 sutures, but if you have a doubt of leak, always can put 3 sutures and get over with it. You can have a scleral congenital flap if you really want it clearer. And in the adults, we normally make a scleral flap. But here, the congenital flap, here the sclera is very thin in these patient marfans. So normally a clear corneal incision does work well. Of course, it will induce some astigmatism, and once you remove the sutures, in 4 weeks' time, they're as good as new, and we don't have any endothelial cell loss extra in these patients as compared to anterior chamber implants. So that's why it's safer. So that's one. I put on a superior rectus bridal suture in this case because sometimes the eye roll upwards. It causes a problem, but today I think the anesthesia is so good that it's not rolling the upwards, so that's working well. No, I think it's not holding well. No, I think I'll replace this suture. Flash karo usko. Anyway, I'll come back to this one. Okay, so I'll cut this one, leave it. I will not bury this. I'm not happy with this suture. So we'll come back to that. I think most of the people don't suture now because doing sutureless surgery, so they don't have good needle holders. So I think that habit you have to get out. Everybody should have a good set of needle holders. Okay, so that's where I go in. I see the sclera. I lift the sclera and go in. I still have time left, right?
Yes, sir.
And number 3, if you notice,
Yes,
the pupil which was oval has already started becoming round. Notice that?
Yes, yes.
Okay. So whenever there's a grip first and when the lens moves a little bit, it gets adjusted actually. So that adjustment you have to give. Now I think the pupil looks pretty round now.
Yes, sir.
Okay. So even if it's not round, don't lose the sleep over it because by morning it's going to settle down. Okay. And see, there's no vitreous coming anywhere. No, only conjunctiva is extra. That's why it's looking a little boggy. This looks fine actually. Okay. And we do routinely EBM in these patients, and we suggest that you should remove all the membranes, the lenticular capsular chain membranes in a cutter. Don't leave anything there. Because later on they can get fibrosed.
Thank you, sir. I think that was an excellent demonstration and so beautifully done, and all the tips and the tricks.
Suture change. Yeah.
In the case, you have.
Is the time up?
No, your time is not up.
I thought you said demonstrate. I thought.
No, I'm concluding. I mean, I'm.
Okay. All right. Okay.
I'm just admiring your surgery and saying that so elegantly done.
Yeah, it's a simple surgery actually.
I'm sure everybody's got motivated to do this. It's
they can do step by step. I think we can start with anterior claws if they know how to do it, and then they can switch over to posterior one. It's not difficult once you have a setup in mind. I think that's what is for everything. Once you have your mind set on it, you have to do it. See, I've got lots of pediatric patients in which there's no back support. So what do? Doing a SFI IOL with a sclera which is thin, I don't think is justified according to me. So we have to find out a way where we can help. The needle holder is slipping away, but well, that's what I got. Sister, needle holder change ho sakta hai? I've taken a longer bite. No, it's not a very great suture. It's a clumsy suture. I know that, but anyway, they're going to come out in 3 to 4 weeks. In all average, we remove in 5 weeks, but in kids, we can come out after 3 weeks, and the suture wound will be healed. So that's about it. Now, this is what we have here. Yeah, that looks good now. I'm just going to bury these knots, and no PI is required. That's the other advantage here, because you're putting the lens upside down, so there's never going to be a pupillary block in this patient. So I think these two sutures are holding well. And I'll just bury these knots and we're done.
Thank you, sir. Can we move to the next OR?
Of course, you can.
Thank you, sir. Thank you, sir, for excellent demonstration.
No questions? Okay, later on maybe.
So you answered all the questions that we possibly had in our minds.
Top minds, how many do you have?
So many minds, sir, in this.
Okay.
Excellent, sir. You can hear the applause.
Yeah, I can hear few of them, yeah.
No.
Right, thank you, Namrata, thank you, bye. Go ahead.
Can we go to the next OR, please?
Mic on kar do. Who's coordinating?
Sir, I am me, Praful and Nupura here, and we are looking forward to seeing your surgery, sir. So we can see the external camera now.
Good morning, everyone. So here's the next section on phacoemulsification and female IOL implantation. Our patient is a 34-year-old male with complaint of diminution of vision in both eyes for the last 1 year. He's a businessman by profession, and as you can see on the clinical picture, he has both eye posterior subcapsular cataract. This is the eye trace of the patient, and according to the biometry, we have planned a TNFT 20 of plus 23.5 diopters at 91-degree axis.
Can you see the
Yes, sir.
optical picture?
Yes, sir. Now we can see the microscope picture, sir.
So this patient, I have already done the surgery. So I'm doing aspiration of a sub-incisional cortex. And this is the best way we can do it. That is hybrid mode. Remove the irrigation tubing attached to irrigation bimanual. You can take out very simply the sub-incisional cortex, and that safeguards the most of the things.
Sir, only you can do it.
No. Tushar and Coherence described this. And he's a young person. He had a posterior subcapsular cataract. So I'm going to show the actual surgery in other patient. Here we are going to implant the toric panoptics trifocal lens. We have selected multifocal trifocal toric lens because we all think of a refractive cataract surgery nowadays, where we need to correct all undesired refractive error and give the patient as far as possible spectacle free post-op vision with highest quality. Though we know that little bit of glare and halos would be there in all these multifocal lenses, but with the newer generation lenses, this has come down. So this is the auto stud which I am using in which is attached to the Centurion, which gives you advantage of your left hand is free when you are inserting the IOL. So you can, with the second hand, as you saw clearly, my second instrument, I could manage the intraocular lens in a proper position like this. So if your second hand is free, your foot switch is pressing onto the IOL injector. That's the best possible manner. But with the recent generation Alcon Claron lenses, there again the lens is driven by the carbon dioxide cartridge, and that also gives you a free left hand or a second hand where you can manipulate very nicely in these cases. So this is a patient had with the rule astigmatism. So you can see that my requirement for a placement is around 90 degree in this patient. Use the image guided system in this particular case. I'm trying to take more time so that lens opens completely inside the bag and rotation will be less. You should go underneath the IOL also. Remove the viscoelastic as far as possible. If needed, you can do a little bit of anterior capsular cleaning, especially the margins, though it hardly makes a difference in the most cases. But it looks better if you are manipulated to remove the anterior subcapsular thing. So this lens is anti-clockwise. I'll have to rotate all the way to get into the proper position. So this is one learning we have to know about these open loop haptic lenses. So you can't rotate these lenses backwards. That is anti-clockwise. You can only rotate clockwise. And for a vertically oriented lenses, you have to be a little more careful, because the orientation little different than a horizontally oriented toric lenses, which is mostly 90% of our cases will have against the rule astigmatism in the age group where cataract is there. You can see the lens is mobile, so it's not open properly in the bag also. So I'm just trying to get into a position around 5 degree to my desired axis. Leave it here, and then rotate subsequently.
So you are operating on a 3D heads-up system, as we can see.
Yeah, that's true. That's a new thing which we have been doing for last now 2 years since COVID time, and has its own advantage in a teaching and research institute. Apart from giving a good clarity for a surgeon also with magnification. And if patient is uncomfortable with the bright light, you can decrease the light to a minimum possible light so that patient can see. Beta आँख खुली रखना, light में देखना. And this has attachment of Callisto as well as the advantage of IOCT in cases where if needed you can use them, especially for retina and corneal surgeries. It is very, very useful to have IOCT attachment. Same thing for a refractive surgery also. I think most future refractive microscope will also have a OCT attachment, especially for if you are doing a pocket-based surgeries or lenticular-based assisted surgeries in the cornea, you would require that. At this stage now lens is little captured, so we'll have to tuck it in. Beta light में देखना शर्मा जी. So first lens is in. So we know that lens is around 10 degree away. The first thing is inferior placement. I'll go from superior just tuck it. It is almost there. Then go for an inferior side port and tuck it the superior one. You should be little more careful because sometimes it can rotate against the clock. Then you will have a difficulty. The lens is opening slowly now. This is almost there. So maybe little 3 degree I have to shift. Infrared. So you can shift the lens a little bit. This has to be done under the formed chamber with your incision totally hydrated. So the lens movement is less. If it is done without the hydration of wound area, sometimes you struggle and that can create the problem. In heads-up system with the magnification of the screen, these 3 lines become very, very small. So difficult to really, it gives you a much more better orientation, unlike the callisto system where you can see 3 lines quite wider. So we are almost there now. We'll leave it at this stage and shift to other patient. Toward the end, we normally put little bit of antibiotic, that is moxifloxacin. I had already put intracameral, they are putting over the surface. Many people put little bit of a diluted betadine at the end of surgery also, which I normally don't practice. We normally practice in the beginning. Actually, the preparation nowadays has totally changed the betadine culture.
Can we have the external microscope now?
Yeah.
Can you enlarge the external one? Yeah.
So we are shifting the other patient number. Any questions in the meantime?
Are there any questions from anybody here? So can we have the external view to show where the heads up is and how?
Sure. That will show towards the end because the external camera is positioned towards my left hand side. So
all right.
Our next patient is a 56-year-old. Our next patient is a 56-year-old male with complaints of diminution of vision in both the eyes over the last 6 months. He is an OT technician by profession. As you can see on the clinical picture, he has IMSC NS2 cataract, which is more in the left eye than the right eye. This is the eye trace of the picture. Angle alpha is 0.242 mm at 2 degrees. And according to the biometry of the patient, TK is 0.98. So we have planned a TNFT20 panoptic storic IOL at 105 degrees axis.
Okay, thank you. Satish, light mein dekho. So we are trying to capture the image of microscope, which will be aligned with the image taken from the IOL Master 700, so that we can actually guide the entire system. And Mr. Satish Chand is my patient today. He is my own OT technician. He used to assist us. Now today he is assisting for live surgery also. He had a nuclear sclerosis of around grade 3 plus. And for all toric lenses, your incision should be always in the area of your concern. That is, always make it in the same area which you have been doing. So that will give you a uniform acceptance of your SIA. Though it is not very significant nowadays because your incision is so small, it normally doesn't change your SIA. But don't change your incision as per the steeper axis, which is not desirable nowadays because your calculations are totally based on your incision, which is at normally for a left eye, mine is around 0 to 10 degrees. We use a very clear sodium hyaluronate, 1%, so that you can see the anterior chamber better. It has 3 purposes. One is maintaining the space during your procedure. Second, keeping the anterior capsule in the same pressurized manner throughout your procedure of your axis. Therefore, I'm doing from my side port so that the leakage of viscoelastic will be minimum. Especially the people who are using methyl cellulose, their leakage can be there if you use for a main port, which is much more in our cases with people using the utrata forceps, which is normally done from the main port. Initial linear incision, this will take you to the area of your rhexis. Subsequently, never go to make a 5.5 to begin with. And normally aim around 5 millimeter or 4.5 millimeter to begin with, which I can enlarge subsequently if needed by doing the spiraling technique or after the completion of phaco also with the implantation IOL. Because best judge of a rhexis is when you implant the IOL inside the eye. Because you all know the normal optics in a usual lenses available nowadays will be 6 millimeter, and that will guide you how big, how small your rhexis is. Because sometimes with the depth difference from cornea to anterior chamber, your size may not be as you think of. That's why many people mark onto the cornea for giving a guide to a rhexis, which keeps changing with the corneal curvature also and AC depth. So it may not be uniform. So image guided systems are a best way to analyze the actual size of rhexis. So we have around 4.5 to 5 millimeter rhexis here, which is continuous Kelvin area, which is going to help us in a subsequent phaco procedure. Now at this stage, all beginners should learn the viscoelastic should be removed as much as possible. Then going to do a hydro dissection first. So always take a smooth, if possible 20-30 gauge cannula, lift the rhexis margin, then inject the fluid. So I'm gently trying to inject. You can see the wave has come. Now this wave has to be released from the either side. So this is one side I'm trying to release. Fluid has come. This is the inferior side, and this is superior side. If you want, you can add this hydro again. You can see another wave has come. So this will help in releasing fluid from this upper side. Yes, you saw that it has come from all around. The nucleus should be mobile at this stage. So with a single instrument, you can move the nucleus also. For beginners, maybe sometimes you can take a bimanual procedure. At this stage, if you want, you can do a delineation also. That will also help you in management of a nucleus with the epicortical cushion. So this is called customization of epicortex, which depends on a case to case. Especially those cases where posterior capsule is weaker, like posterior polar cataract, where you want a little bit of a cushion, then this delineation is very useful. And also delineation will help you in a better nucleus emulsification because you will be safer in relation to posterior capsule. So I filled the anterior chamber with the soft shell technique, that is viscode first, that is dispersive viscoelastic, then pushing that with a Helon or subsequently with the sodium hyaluronate. That will coat the endothelium and maintain the coating till the end of surgery. So we are at, ozil power will come to 40 and rest of the power will be alright. This is the Centurion system. So first idea is to remove all these loose cortex from the area of concern. This is a central area which I am bothered now. I will go to maybe a good hole, then subsequently you can chop also like this. Or you can do a little bit of trenching to get into a depth of nucleus. I can see better now. To depth hole, wait for a occlusion sound, then chop it. Use your left hand much more than the right hand. You can see I am holding and my left hand will chop and separate. The right hand, which is heavier hand because of handpiece, should not be mobile that much. Like if you see here, I'll just move my left hand and chop it. In this way, you can make a multiple chops that will help you in making a better emulsification in the central area. So I have a small piece now. So I'll eat this in the central area. You can see how effectively these pieces will come to the port and you can emulsify them. The central area is the safest area because you are away from the posterior capsular area as well as from the central part of the cornea. If you work in the periphery, the more chances that you will be nearer to the cornea and cause damage. And these systems are so well controlled in terms of fluidics, you hardly have chances of wound burn happening nowadays. Because your flow, everything is well managed. So your handpiece would be static and the pieces will be eaten out simply. The nucleus has come out, now we have an epicortical cushion that has to be removed gently. Go with the aspiration only, don't go to the foot level 3 where phaco might come up. Once you hold it, then you can just pull it to the center. It's a thick epicortex. If you pull it like this, then entire thing has come into your port. That is the time you can use a little bit of phaco power and that will be eaten very fast. But this will come at a one go if your delineation and hydrodissection has been perfect. So now you have only cortex left that can also be aspirated. As I showed in the previous case, we can use the hybrid technique. Advantage of not taking out handpiece is, the chamber fluctuation decreases. Each chamber fluctuation will cause vitreous-based disturbance. That has to be avoided. So I have taken out the cortex. The next step of mine would be to fill the bag. So I fill little bit of Helon before I take out my handpiece so that my chamber remains absolutely static when my handpiece comes out. So that is also very important in a difficult case scenarios. As I talked about posterior polar, subluxated, bag dialysis, my chamber should be always stable. So my IOL is ready, which has been nicely, put into cartridge by our assistant sister. They are much more expert than most of us. Autosert is again being used here. With the left hand, you can just put the lens in place. To shift to now irrigation aspiration, you can use bimanual as well as the coaxial one. I am very comfortable with coaxial here because that will take out the viscoelastic faster and there will be less chamber, fluctuation, because sometimes the bimanual your irrigation doesn't support the aspiration which happens in a case like this where you require a little more stability with the lenses. All cases with multifocal, the posterior segment has to be managed very, very effectively. We should not have a CME macular edema coming up. So vitreous management is also very important, prophylaxis wise. A little bit of fibers, you can just pull it off. Now this is the capsular polishing, which I do with the lens itself, which has a larger surface, uniform surface. So you have to be a little gentle. This is the right position for doing a little bit of massage with the IOL to the posterior capsule. Lift the IOL, go inside, remove all viscoelastic plus the fibers. Again, I'll just take this lens like this and just clean the fibers from the posterior capsule. So you have to be a little careful doing this technique, especially in weak posterior capsules. Now next step is to align the lens. I decrease a little magnification. Take the lens to around 5 degrees away from the area of fixation of lens in terms of toricity. Almost there. Now I'll come out gently. Don't let the chamber flatten very fast, because this is a stage chamber will get flattened because you are coming out with a handpiece, especially younger patient where you have a little bit of vitreous upthrust happening in these cases. In some cases, your chamber remains absolutely stable where the patient is more comfortable. Sometimes they don't stress. So that is one teaching I give to my resident. Always put anesthesia on other eye also. So that in a topical anesthesia, if other eye is comfortable, this eye also becomes comfortable. आँखों सतीश light में देखो शाबाश. So this stage I'll put little bit of intracameral moxifloxacin and little bit on a wound area, because inferior area normally is a critical. Now chamber is reasonably well formed. Tuck the lens inside so that it goes underneath the capsular axis. Then shift the lens to a desired axis. So there are two important things here. One is aligning the toric axis and aligning the central part of a toric lens also. These three coaxial lights should be coincided with the central ring. So these are two things are very important for alignment in a multifocal toric lenses. Light में देखो सतीश, हो गया complete तुम्हारा. Little bit of adjustment is required. Okay. Thank you for listening and wish you all the best for the entire day, Dr. Namrata and team.
Thank you so much, sir. That was an excellent demonstration. And a big round of applause for you from the whole house.
Thank you for
so
those
much.
people on the dais for making sound.
No, sir. The people who are watching are making the sound.
Okay, thanks a lot, and we thank all the staff in the OT. They have come on a Sunday, and all the delegates who come in such a large number today. We are very, very, happy. We appreciate them being in our center today.
So can we see the external microscope?
Yeah, please. Can you come to this side so that they can see this screen? दिखा दो जरा बेटा. Machine करो. बैठे रहो भाई. सतीश ऐसा रखो जरा. बढ़िया हो गया सतीश. Can you see the screen now?
No, sir. We can see Satish's eyes now.
It's a microscope.
अरे microscope off कर दो.
Yes, sir. We can see now. Yes.
So we have this, large, you can say this is a 5K system. 4K or 5K? 4K, no? 4K system, and gives a very nice contrast for people like me also. And very, very large magnification can be done. And
decrease the zoom, please. Can we decrease the zoom to see the machine?
Yeah. इसको बेटा छोटा कर दो. OCT पे you can see the
zoom नहीं,
machine का zoom कम करो बेटा.
External camera का zoom कम करो.
ये भी दोनों आ जाए ना?
हाँ, now we can see.
So you have OCT you can see also in the side.
Yes.
So this is one advantage of this, you can say this digital system is OCT is beautifully visualized, which is sometimes difficult looking through the oculars also. So this is very advantageous for entry segment surgeons. Now you can see the entire, especially cornea things. You can see the right side corner also. There are, you can see three, linear scales, which is equivalent to a 1 millimeter. So you can measure this with this also grossly. So this is the new attachment which has come in the OCT with this new Lumina 700 microscope. Thank you again and wish you all the best.
Thank you, sir. Sir, a number of people have joined us virtually also, almost 100 participants.
Good.
Dr. Ashok Mulani, he wants to ask something. EV team, can we connect to him?
Can we connect to?
Dr. Ashok Mulani.
Yeah, he's my friend and I wish him good morning, sir.
Dr. Ashok Mulani is from Pune. And
yeah, what's his question?
He had raised his hand. We are trying to connect to him so that he can directly ask whatever his question is.
Okay.
Can you unmute Dr. Ashok Mulani, please?
Yeah, उनको chat में ले लो ना.
Okay. So, Praful, can you tell his question?
No, he hasn't put any question on chat box. He wanted to say something, so we'll have to.
Okay. ठीक है.
So there is one more question from your previous surgery, sir. Smile surgery. Can we do smile in a patient with mild nebular haze with -2 diopter myopia?
I would say yes. If it is a very mild nebular haze, especially if it's not in the optical axis, because optical axis is a very critical area for any refractive procedure. If it's a little peripheral area, we might succeed if it is mild one. Otherwise, sometimes laser doesn't pass through that opaque area. You'll have a black spot. And if it is a small one, even that can be dissected out from the periphery also. Central I'll avoid. In those cases, it is better to do a microkeratoma assisted flap if you have a slightly thicker opacity. Lobby BIP patient. Thank you again. Let's shift.
Thank you, sir.
Yeah.
We'll shift to the next case, please. I think Professor Radhika Tandon is going to show us about the ICL.
Yes, Dr. Radhika.
Good morning. Am I audible?
Yes.
Okay. So I'm first going to load the lens. This is a Phakic IOL.
Can we see the microscope view, please? Yes.
AV, you can see. So this is the cartridge. I'd like to prime it with some BSS first. Then make sure that the air bubbles are out of the viscoelastic. This is hydroxypropyl methyl cellulose. Once I've primed the injector, I just like to set it down here, stable. And then we've checked the IOL, that there is no particles or any turbidity in the fluid. Then we have this cotton-tipped, sponge-tipped applicator, where you first give a few seconds to let it hydrate and become soft. Then use it to retrieve the lens, which is very soft and pliable. You set it on the platform, align it vertically, so that there are two dimples that you need to pay attention to, leading right and trailing left. Make sure it remains well hydrated. Gently nudge it into position. So here again the leading dimple on the right, trailing on the left. That maintains the proper orientation. Load it at the base of the platform where it's adequately wide so the lens fits nicely. Make sure it's well aligned, not tilted. These 3 dots should be centered and these 2 feet should be uniform. Again, reconfirm the alignment. Okay. Now we will use the forceps to hold the lens and drag it into the cartridge. Check that the forceps is well aligned and the jaws are meeting properly. Open the jaws, grip the edge of the lens and drag it into the injector. Again, paying attention to where are your 3 dots, because that's going to tell you a little bit about the orientation of the lens. So when injecting, I'm again going to watch those 3 dots to make sure that it doesn't open inverted. Then again, I pinch the base of the platform, engage it, lock it. You had put that, you had put, right? The cotton-tipped applicator had been fitted. That is going to be used as a plunger to inject the IOL, just checking that it is stable. Just a little tiny nudge to make sure it's moving properly and well attached. So it had moved barely a millimeter and I'm confident that it's well attached. So now the lens is now dipped back into the bottle in which it came in, and we now go ahead with cleaning and draping the patient. While we're doing that, the senior resident, Dr. Kusumata, will tell you about the refractive error.
Here is a 29-year-old patient presented to us for refractive surgery. Her uncorrected vision in both the eyes was 1/60 with a best corrected vision of 6/9 in both the eyes. Her refractive error was -20 diopter sphere and -3 diopter cylinder at 10 degrees in right eye and -20 diopter sphere and -3 diopter cylinder at 170 degree in the left eye. Axial length in both the eye was 31.71 and 31.14 respectively, with a wide to wide of 12.1 mm in the right eye and 12.4 in the left eye. Endo ACD of the right eye was 3.2 mm and 3.4 mm in the left eye. The specular count was 3238 in the right eye and 3016 in the left eye. So the patient was planned for ICL surgery. With the IS power being around 18 diopter sphere. So Now we are planning for left eye ICL surgery, toric ICL lens. The left eye power which we had planned is minus 18 diopter sphere and plus 2 diopter cylinder at 80 degree with a residual refractive error of around minus 3.5 diopter sphere and 0.4 diopter cylinder at 78 degree. Thank you.
Thank you, Kusumita. So normally we do the right eye first, but the pupil was not very well dilated with the right eye, so we are going to do the left eye first. Patient is under topical anesthesia. We have marked the axis initially.
So Radhika, as I understand, the patient is being slightly undercorrected?
Yes, the patient will have a slight undercorrection, and we had discussed this before, and we had agreed that what we would do is after the surgery, we'll see how she is satisfied with the outcome, and if necessary, she can also have a bioptics extra procedure done later on. So I'm marking the 5 degrees. So this is that's going to be my alignment. Yeah. Okay.
So the marks are there and we can see.
आप रिलैक्स होइए, हाँ रिलैक्स, हाँ डोंट वरी एट ऑल, सीधा बत्ती में देखते रहिए, शाबाश.
So I think these incisions are very important because it's a clear lens sitting there. So all your movements have to be towards the roof and not towards the floor. You can't do like you do. I mean, you have to unlearn your phaco a little bit here. You can't do as you do in phaco because the lens is cataractous. Here it's a clear lens, so you have to move, all your movements have to be upwards.
Thank you. आप बहुत अच्छा करा रहे हैं, रिलैक्स करिए, बत्ती की तरफ देखना, बीच में हल्की चुभन या कोई दबाव या प्रेशर महसूस होगा तो डोंट वरी, हाँ हिलना नहीं, शाबाश.
I think this is also important that the after making the side port, you put Helon there, because again you want space when you are making your main incision. You can't afford to have a little shallow AC there and then make your main incision. And that again has to be directed upwards,
बत्ती में
not
देखते
downwards.
रहिए, just irrigate the wound a little. बत्ती में देखते रहिए, हल्का दबाव महसूस होगा अभी. आप कोशिश करो कि आंख हिलाए नहीं, वो बत्ती की तरफ ही देखते रहिए, शाबाश. रिलैक्स, बहुत अच्छा करा रहे हैं, रिलैक्स, शाबाश.
So that was an absolutely very elegantly it unfolded itself.
Helon.
So as soon as you put the ICL, the next step would be just to put a viscoelastic. People do it under BSS also, but it is always best to put viscoelastic.
Wash karna.
So that it kind of sits down. And then the haptics are now being engaged with the slider, which comes actually with this set of instruments. These are different set of instruments which you may have to purchase, or it will come, the company, the manufacturer will give you.
Helon. Thank you. आप बहुत अच्छा करा रहे हैं, ठीक है, थोड़ा सा बत्ती की तरफ आंख सीधी रखना, थोड़ा सा और, 3 बत्ती है ना, उसकी तरफ, शाबाश.
So one haptic has already been tucked in, and now some more viscoelastic is being put, so that again the whole lens kind of sits down.
हल्का सा सर ऐसे करना, सीधा देखेगा, शाबाश. वेरी गुड, लाइट की तरफ, वेरी नाइस.
So important thing is in these cases the pupils have to be dilated. They should not be excessively dilated, but they should be dilated.
I'm now aligning the IOL according to the required axis. You have to make very gentle movements and be very careful not to touch the optic because that is very fragile and it may get damaged. It's almost aligned. There's a little bit of parallax when we're doing it this way. So it's just a little bit more adjustment required. The other thing you have to see is the centration of the lens. It should not be too much inferiorly or superiorly. It should be along the horizontal axis, the maximum white to white. Okay. So we confirm that the alignment is parallel to this line. There's a little bit of parallax in the location of the axis marker, but the axis seems to be correct and the alignment is also good. आप comfortable है? Very good. 2 seconds और लगेंगे, relax कीजिए. There's a little bit of discrepancy in the pupil size also, but I'm satisfied with the alignment. Now I will remove the viscoelastic, Sinski, and larger incision. So we use the wider irrigating sleeve, blue sleeve, rather than the pink sleeve which we normally use. As you can see, the axis is well aligned. I'm taking little time to allow the viscoelastic to be removed. Using the aspiration port aligned with the central aqua port. It's almost done. Okay, that's good. Hydration. I'll hydrate the ports, deepen the AC. Make sure the wound is stable, mirror cell sponge. Being high myopes, you have to maintain the stability of the eye at all points of time. Initially, we had a discussion about whether to do under block. The patient has been very cooperative for topical anesthesia, having a very large axial length of 31. There are attendant problems that one may encounter with giving a block. So I'm satisfied, my alignment is also fine. Just make sure it's well hydrated and the eye is stable.
Very nicely done, Radhika. Thank you so much. Very nicely done.
Just check the wound. It's well apposed. I just put some moxifloxacin and subconscious topical. Moxifloxacin also externally. And topical gentamicin decaderm. Again, when removing the speculum, you have to lift it up. Be very careful that you don't distort the wound and have a collapse of the AC. Okay, thank you so much.
Thank you so much. Thank you so much, Dr. Radhika. You can hear the applause that you have got, and it's not from the dais. It's from the dais as well as all the delegates.
Thank you so much. Thank you, everyone.
So Dr. Manpreet has a announcement to make.
Operation आपका ठीक हो गया है,
बहुत अच्छा कराया. Also going on in the first floor. So whoever wants to go for wet lab for phaco or extracapsular cataract extraction practice, they can go in between now also, and we also have a session towards the end post lunch. But those who want to go can get a head start.
So nobody wants to go, Manpreet.
Okay.
So it is my pleasure to invite Dr. Khokar sir to give his talk on, again, very important topic, post-refractive surgery challenges.
Yeah. Start.
Thank you, Dr. Namrata, and Namrata, high flyer. Okay, so what are we doing? We're doing refractive surgery. So in the morning session, refractive surgery. So when these guys come back to you after 30 years, 40 years, when they have a cataract, what are you supposed to do? So you're putting very happily enclaving the iris, you're cutting the cornea, you're putting RK marks. What will happen when they come to you? If they don't come to you, they'll come to your colleague, yeah, maybe your son. Like lots of the ophthalmologists are putting their kids into this street, so the kids will have to operate these patients, so they better be prepared. Okay, so let's see what happens. So let's see what all surgeries we talk about. We talk about the maximum patient we're getting is retinal keratotomy, because that's been there for donkey's years. They've been there for long time. So maximum patient we get at my center, at our center, is RK, post-RK. Okay. Then you have PRKs, few cases, because PRK will not come to you. PRK will, most of the doctors will not even pick up the PRKs done, because there's no haze, nothing, and the cornea actually go flat. So if you don't have machines, topographers to pick it up, most of the people will actually miss out a small refractive error PRK, and they'll treat them as a normal cataract patient, which I think is still okay. Lasik, very few patients, because again, it's not been there for too long, but yes, we started getting patients with Lasik, especially from a certain group down south, in which they were doing about -10 and -12 for Lasik for these patients, with cornea about 500, and now these patients are very thin corneas are coming, and that becomes a challenge now. What are the problems? We'll come to that. Smile, none yet, because we just started 2-3 years back, and Professor Titial had written a book 2 years back, so it's just a beginning. So maybe later on you'll have these patients and challenges will be there. We don't know yet what we're going to get there. Artisan lens, phakic lenses, the artisans came before. So those lenses are still there, and they are being removed. I removed one lady came from Canada yesterday to get the ICL removed, artisan removed, because nobody knew how to remove it there. So we did a surgery yesterday. I'll show you some glimpse of that. And ICL, also few patients we have seen in which we've done. So what is happening? You're changing the biomechanics are changing. There's a dry eye which substitute angle which comes in. So your IOL power calculation will go for a toss. You have reflexes and the biometry issues. Now, what is the biometry issues? Whatever keratometry you pick up, all these machines, they presume lots of things. The presumption that the cornea is fair and you take 1.3375, these are presumptions. These are not actual findings from the cornea. So when you cut these cornea, make them oblate, again it goes for a Tinsley spell, and you don't know what way you're heading. So what you basically need is you need to have a double K method in which you know a pre-op K and post-op K. So what is the advantage? The pre-op K, when you do it, before the pre-op means pre-op refractive surgery. So that K will help you in finding the ELP. So effective lens position changes, so that K you should have. But most of these surgeons will not give any data to the patient. They'll just give them a receipt for the money they charged, right? And you have to have a post-refractive surgery K, which can tell you the Vergen's formula. So that will help you in calculating it in SRK, whichever formula you want to use. So you need to have both the Ks. If you have double K, you can be quite accurate. But 99% of these patients will not have a pre-operative data when they come to us after 30-40 years of surgery, which is a big shame actually. Okay, so you can use a Snell's law, ray tracing. Yes, we have machines with eye trace and all that. You can use a ray trace, which can give you accuracy, but not everybody can afford these machines, and they work on Snell's law. I think I'll go to the surgery, and here also the ELP calculation is possible if you have certain formulas in these machines. I'll not go into the... so the best formula for you should be what? You remove the lens, do a refraction on the table, aphakic mode. You take away the ICL, do the surgery, make the patient aphakic, and calculate the IOL power depending on the refraction. So these two formulas are time tested. People have done, there was lots of studies on this one. So with this one in mind, there's a system called ORA, optic abrometer, which is actually by Alcon, which takes the lower order aberrations into consideration. So basically sphericals and cylinders, and they'll give you the calculation of the power on the table after you have created aphakia. After you remove the lens, you push in viscoelastic into the eye, make the chamber formed, the cornea should be taut, it should be clear of all the viscoelastic from the surface so that you don't have any aberrations from there, and you can get it. So we've done lots of work on this, and it's pretty accurate actually. Okay, so I think we already talked about, now we'll start with the surgery. So this was a paper published in AGO about, I think, 20-25 years back by us, in which we found out that these patients, when you go for surgery, there's a splicing. The incisions will open. I think I'll talk about, I'll show you in the videos only because my time is short. So the concept is, if you have 8 incisions, the concept of 2 pi r holds very good here. So everybody know what's a pi? When you cut the pizza, each one, that's called a pie, right? You eat that. It's 22 by 7, which is 3.14697825, and it goes on, right? So use that one to calculate. So what if your white to white corneal diameter is 12, R becomes 6, then you can calculate. So if you have 8 incisions, you're good to go between the incision with the 2.2 or 2.8 incisions.
Okay, if you have 16, it becomes half. So then you override at the incision. So that could be a problem. So depending on the white to white, so use this concept to plan it beforehand. Okay. Okay, so if you're doing an ICL and you want to calculate the IOL power, there's no problem at all because the exit length does not change with the ICL in situ. We did a study in RP Center in which we did about 200 patients in which we did a pre-op assessment and we followed this patient for 1 year and we realized there's no change. That means the light which is going through does not change much in nature to cause the lengthening or shortening of the exit length. So CALT, which is a calculated exit length factor, will be normal in these ones. So whatever patient gives you, you just take that power and do the surgery. So that's the best because you haven't done anything to the cornea. When you've done a cornea flattening by a Lasik, SMILE or PRK, those patients have an issue. So those, and especially even the RK patients. So let's see what we do in that one. So this study we already published. Okay, let's go with the videos now. So first let's see a patient with RK. This patient was operated at the age of 20 years outside for RK, and then he came to us when he was 30 years. He wanted an ICL, so we put in an ICL. With ICL, his vision was 6/9 partial, and he was happy in both the eyes. Now he comes to us with a little cataract there. So you see the incision. I've gone in between two incisions. Can I have a marker here? Pointer. Grover's pointer. So I go with a 2.2 incision. The ICL goes in with the 3.2, and if you want to take it out, you can always take it out from 2.2 also without any much problem. Which one? Okay. So it's gone. So you can see the ICL coming here. It came as a surprise. Okay. So you go with the Helon under the ICL straight away. So you lift it up and then you hold it and pull it out and use the other forceps. It just folds on its own. It's like a flimsy membrane, and especially if it stayed in the eye for such a long period, 20 years, it becomes more biodegradable. Actually, it becomes more fragile. So you can actually pull it out. Don't pull it out too much. Just let it hold and let it roll. Once that comes, next is a simple thing. You can do a rexis, and if you're not good at rexis, you can always buy a machine called Flax machine, which can help you in making the rexis. But if you're good, then you don't need to buy that machine, right? So then you can do a rexis with that and do a hydro procedure, keeping in mind that you're operating on a myopic eye. The myopia has not gone away, so vitreous degeneration is there. Eyeball is big, the cornea is thin, so you keep getting these movements. So if this is happening, it's not your fault. It's there in the system itself, and then you go do the phaco and get away with that. So that's a simple one. So there was RK, there was ICL. So you will be getting these patients soon. So everybody who's smiling, I want you to be happier later on if you're able to manage this patient. Okay, IOL power calculation is one of the things. I'm talking about the surgical problems now. And see the rexis look, it's not very good, but yeah, I don't, and this is what we do. This is what we done. This is called ORA system, and the power was coming 22.5 with a residual cylinder of 4. The patient has a cylinder of 4 now also, but he's happier because he can see better with the 4 cylinder. So although he went to remove his glasses 30 years back, but he's back with the glasses. So if you don't pick up your refractive procedure well, these are things which can happen to you. And especially when you have cylinders, most of the answers of RK are no, it's ICL which works the best, which Dr. Radhika showed so beautiful. And when you do the hydro in this patient, you always find that the fluid actually goes along the marks. So you don't push too much fluid, otherwise this might reach the center also. So that's video number 1 gone. Okay. Now what happens when you have an artisan lens? So this was the patient, we published this work, I think about 8-9 years back. So this is the patient with the artisan lens. You can see that lens. It's in the front, and you see how big the enclavation is. Huge. Enclavation has to be 1/3 of the size of the claw, but this was actually more than half. So this is true. So I didn't remove it. If I wanted to remove, the pupil would have gone small on the table. So what I did the entire surgery with the lens in situ, with having a viscoat in the front and Helon at the back. Okay. And you have to be a little gentle, that's all. So if you know your surgery, otherwise you can always depend on a machine called Flax. So you can always go and cut the patient. But still you have to do the phaco. It might emulsify, make it softer, but you still have to use the handpiece. So only problem was when the handpiece was going in, the lens was going down. That's the only time. So we could have started doing chopping a little earlier. Don't go in the center, start in the periphery, you can split it open. And the lens, once it's gone, then you do the IA. And I'm telling you all the steps. So all steps are possible if you're handling your tissue well. So you see that its claws are still intact, everything is good. There are lots of publications in which people are disenclave one haptic and push the thing down and done the surgery, but there'll be more turbulence. They'll hit some great surgeons also. But now I'm enlarging the section after putting the implants. My IOL goes inside the eye. So there are 2 lenses in the eye. Right. So This is the old, you can make out it's a yellow lens. I stopped using the yellow lens about 8-10 years back, so this is the old video. So now I make a side port and I disenclave, and see, after disenclaving the pupil goes small. If the same thing happened if I disenclave earlier, you can't do the surgery. You have to put sutures and so many things will change. So once this is done, you can suture it up and finish it off. I think I'll fasten it up. So now, how do you disenclave? This is a lady which was done yesterday only. Okay, so this has almost a clear lens. Endothelial cell, when the surgery was done 20 years back, was 2000 something, now it's 1100. And she came from Canada all the way to get this done. So how do you do? You have to make the chamber formed, and you have to have your forceps in your hand. Now, enlarge the section enough so that your forceps goes in. The enclavation, the forceps which holds the lens. So the trick is to hold the right hand. Right hand has to be firm if for the left side enclavation. If your hold is good, then you come from the side port. Okay, I just go a little fast forward on this one. Okay, so get this grip, get the grip, get the grip. So once you got a grip, yeah, then you come from the other side now and disenclave. Okay, and you did it so gently, you didn't pull it. If you pull it, the pupil will start going small. So once the lens is out, you can do whatever you want to do in this way, whichever want you to do the surgery. So once the lens is out, I think I'll stop it. And the last video is RK splicing. So this is important because your RK can open up during the surgery, especially you can count the numbers, 16 and some few cuts in between, and they're not at the regular interval. If you notice, some are closer, some are away. So you actually can't put 2 pi r by number of incision because the distance between the incision is not the same. Okay. So again, you can do the rexes. Again, if you have any hesitation, if you have money, you can go ahead and buy a flax machine. Okay, once that done, now you see I've opened the incision, but I am very close to the incision, see? Okay. So during the entire procedure of IA and Phaco, nothing going to happen there. But the moment you want to put in the lens, because lens goes with a little force, it's folded. You'll see the splicing there, and that's why this is fast forwarded. Okay, so IA also doesn't have a problem. And in case you have an issue, you can always use a biomanual in these ones, because that will take a smaller opening to go in, and you can use biomanuals. Since the 2.2 Phaco didn't cause any opening, we went with this one. The moment you went in for the IOL at this one, come on. Okay. You see it's already started opening up. And we tried to put the lens in, it didn't go well, so we had to enlarge the section. So we just gave a side cut while going inwards on the left side, right? And the lens goes in. And once the lens has gone in, you have to suture this wound and suture it radially. I'll just show you, and I think that'll be the last video. Okay, so once you do that, the main wound will get hydrated on its own. Once you do the hydration, you have to bury these knots. All these knots have to be buried. Once that's done, you've done the hydration, and that's the end of the surgery. Okay, for patients of a PRK or a Lasik, you don't need any surgical skills because the cornea is clear, right? And only thing is the eye will behave like a myopic eye. So that's the only thing you have to keep in your mind, that it's an eye which is going to fluctuate. A post-vitrectomized eye or a high myopic eye is the one you should behave it like that. Treat it like that, rest is all good. So you can get away with that, even with the splicing, you can do it. You can make a scleral incision to do Phaco, but the problem is when you come scleral, the moment you go and dip your probe down, your fluid will get squeezed, the sleeves will get squeezed, and fluid will stop, and you will have more problems. So either you make a big tunnel at the periphery, or you can get away with a suture like this, okay? So at the end, I would like to say that all of us should be ready with nomograms and better surgical methods of IOL power calculation and surgeries, if you can be more skillful, because what are we doing now today is going to come back to us. These are big boomerangs we are throwing in the air. Lasik, smile, anybody who comes, you cut contoura, no contoura. These patients are going to come back to you. So don't do anything which you can't undo. So that's with that thing, a caution in mind. Refractive cataract is a wonderful field, but let's not make it a one-way path. We should have the system to come out of it, to give them the good cataract IOL power calculation later on. With that, I think I'll close my talk. Thank you very much. Any questions? I'll be more than happy to answer. Yes, Vanati. You too, Brutus. Yeah. Lovely. So premium IOLs, these eyes are usually myopic eyes. If you have a patient with a 8 incision RK, or you have a patient with a low refractive error in which the retina is pretty good, in those one you can actually try IOLs, provided you don't have cylinders on the cornea. If you have cylinders on the cornea, they don't work well, because whatever surgery you do now, they're going to get, it's the, what do you call, the counter forces are so many in the incision on the cornea. So it's going to be a big hassle. So if the cylinder is more than 1.5 to 2, please do not put multifocals in these ones. Okay? And toric ones you can try in these patients, provided it's stable. And that's about it. And I think monofocal lenses are the best in these patients because your power calculations are good in that one. The problem is that the cornea has gone so flat that whatever calculation you do, whichever K you take, you still end up being hyperopic. And that's what we don't want. So we have, at the center, we have a formula in which if you have 8 incisions, you don't undercorrect. But if you have 16 incisions, you undercorrect the keratometry value, lowest K value by 25%. And you will be very close to the myopia or hymetropia. You want to err on a myopic side, not on a hyperopic side. Okay? Because the patient always had a myopic vision from the childhood till now. Smaller image with a brightness. But if you make it hyperopic, he won't be happy. So I think I'll take that with a pinch of salt. Okay.
Thank you, sir, for a very informative talk. Wonderful videos. Now I'll call upon Professor Namrata Sharma for her video-based talk on posterior polar cataract. Ma'am, please.
Thank you, Nupur. After seeing those wonderful live surgery, now we move on to the talks, and I think we saw beautiful videos in Dr. Khokhar's talk. Now, I would be talking to you about posterior polar cataract, and there are no financial interest in any of the products which are mentioned in the presentation. This is how posterior polar cataract is going to look like with the central disc in place. And if you see this in one eye, always you should examine the fellow eye also, because there may be some telltale signs there also. More importantly, if on a slit lamp you see a total cataract, then always look at the fellow eye, because you might have a picture like this or somewhat like this, and if you don't know in a total cataract that it is a posterior polar cataract, then it is a complete disaster, because you would go ahead and do a hydro dissection, which should not be done in these cases. So always look at the fellow eye in a case of total cataract in one eye which you are going to be operating. Now this is just to show the intraopposity pictures. It just makes the things easier to highlight and to show. So this is a posterior subcapsular cataract. So you see the hydration, wave of hydration which goes right up to the center, and in this case there was also a Wegert's ligament which is being seen, but then the whole thing, it just lifts up in a posterior subcapsular cataract, because there is no attachment which is present between the posterior capsular opacity and the underlying posterior capsule. Now this looks like a posterior polar cataract on slit lamp, but in this case again one has to look on the intraopposity microscope or on the ASOCT if you have it, and notice that when this case was done, there is a PC intact which is present. So although it looks like a pseudo PCR, but it's actually not. Now again in this case you notice that basically you have to look at the intersection of this where it is focusing. So if you notice that this is a posterior polar cataract with some gap which is present posteriorly, and so this may be actually a defect may be present in this case. So this activity or this exercise can be done intraoperatively if you have an intraopposity microscope. Otherwise one can always do it on the anterior segment OCT. Now this is a case again where relatively younger patient where posterior polar cataract was there, and you notice that there is a disc shaped opacity over there. In these cases hydro delineation is what is advocated, and one should not do hydro dissection. And then one ideally one should do a layer by layer dissection and eat the area which is disc shaped or which has that opacity in the end. Here it is tending to come much before than desired, and notice that already there is a defect there which can be seen. So viscoelastic is being injected from the side to close the defect, and this is followed by irrigation and aspiration. And Subsequently, the vitrectomy is also done because there's some vitreous which is coming out from the gap, and then intraocular lens implantation can be done in the bag like this, or alternatively that can be enlarged into a bigger posterior capsular excess, and capturing can be done. Because this was present a little eccentrically and not that much in the center, so that is why in this case the lens was implanted in the bag, and subsequently the irrigation aspiration is done. Now this is yet another case in which this was a young patient in which the staining of the capsule was done because it was a white cataract. This is the anterior capsular excess which is being done, then the hydro maneuvers are done, and notice that there is a gap which is present. It's the vitreous you can see, and it's actually opening posteriorly. So in this case the posterior capsular excess is done, and this again can be seen on the intraopposite microscope, the two gaps, and 3-piece intraocular lens is being placed inside here, which is advocated, and then this is subsequently then captured. And as you captured, you will see that there is a spindle which will form here, and this also will be seen as a stretched out area on the posterior capsule over here. So this is the capturing along with the lens which should be done in these cases. Now here it looks like a posterior polar cataract, and important thing is that even though the PC may be intact, one should not be very adventurous, because even when the PC is seemingly intact and you try to do some maneuvers and you think that the PC will not give way, it gives way. In this case, of course, the central disc can be seen over there, and PC was intact, and so one got away with doing the surgery as one would do normally. PC is absolutely intact, and there is no polishing which was attempted in this case. But in this case, there is, if you look at the intraopposite microscope, there is no visible gap which is there posteriorly. The central disc is present, and the irrigation aspiration was done. The PC looks absolutely intact. But as you become a little more adventurous and try to do little bit of polishing, notice how, because the PC itself is weak, even this maneuver, which is so gentle, can cause a rent there. And so all those cases which are actually posterior polar, one has to be very careful. Sometimes even while inserting lenses, you can, in a weak PC, you can cause a tear. And this is of course the intraocular lens which was implanted after converting that into a posterior capsular excess. Now flax is important in these cases, and several of the techniques have also been described from our center by Dr. Tityal, where where spokes are made radially as well as 3 cylinders are made, so that you have these quadrants, or you have these pieces which are already split because of the femtosecond laser. So there is no traction which is there, and no additional maneuvering, not too much of maneuvering which is required during emulsification. And in this case, as you come out just before the epinucleus, one has to put viscoelastic, but there is a PC tear there, and generally these occurs vertically like this, such as which is shown here, and then you have to do a good cortical cleanup, and then subsequently irrigation aspiration. And in these cases again, one can do the implantation of a 3-piece intraocular lens in the back. Generally you tend to have these kind of linear tears, classically horizontal in cases of posterior polar cataract. And we always try to counsel the patients who have posterior polar cataract for flex. Then sometimes you can have a very large rent when everything has been kind of not because of the posterior polar cataract, but because of your own maneuvering, the PC rent becomes large. In these cases, whenever the rent becomes large, one can always do a reverse optic capture, and by placing the viscoelastic first, and then form this spindle sort of a thing from the margins of the anterior capsule. And important thing is that the lens should be stable and should be in place. Like this is what I was talking about right in the beginning. This is a hard cataract. There is no glow absolutely, and in these cases, if you do a hydro maneuver, then hydro procedure rather, not hydro maneuver, these cases you should do a hydro delineation. Then there is already a rent there before you realize, and this was a case of bilateral case which had total cataract. So one has to be careful and always look at the fellow eye. Sometimes the fellow eye may have a AC eye well, then you know that this eye got complicated, and so always look for posterior polar cataract in the eye that you are dealing with. This is the posterior polar cortical disc defect, sign of intact posterior capsule, described again by Dr. Tityal sir, which says that if you have this disc, the visualization of the intraoperative disc, that is of the posterior polar cortical disc defect, if it is there, then the chances are there that there will be less intraoperative PCR. So to conclude, a meticulous slit lamp is mandatory for evaluation of morphology of the cataract. You should examine both the eyes, especially the fellow eye, for morphology of the cataract, or for a complicated course if the surgery has already been done. Special caution in cases of total cataracts. Defer hydrodissection, hydrodelineation may be done, and layer by layer nuclear emulsification technique should be followed. Anterior vitrectomy may be required in these cases. So IOL implantation in the bag or in the sulcus with or without optic capture is what is advocated, and femtosecond laser and IOCT may help to optimize outcomes in these complex cases. Thank you very much for your attention. I would like to acknowledge Dr. Amar Pujari and Dr. Rahul Bafna for this presentation.
Okay. Thank you, ma'am, for wonderfully demonstrated the videos of this very difficult case scenario of posterior polar cataract. If there is any questions for ma'am, then you can take it. I mean, Radhika ma'am. Okay, if there is none, now we move on to the next speaker. There is Dr. Radhika Tandon. She will be speaking on pseudo-exfoliation syndrome, Phacoemulsification in this another difficult case scenario.
During intraoperative OCT, if there is no, if you see that the posterior, there is no indenture or capsule is intact, would you like to go for a slow hydrodissection? Because some people recommend slow hydrodissection.
Polar cataract. Some people do recommend that you can do a limited kind of a hydro dissection, or you can do, don't do it completely, just do an incomplete kind of hydro dissection. Don't go right till the center. Slow hydro dissection. Manpreet?
When we started using IOCT, we did observe that if you can see the PC clearly along the entirety of the opacity, then a gentle hydrodissection did not increase the risk of PCR, and you can go ahead with it, and in fact the cortical cleanup was much faster and easier.
Hello everyone. I'm going to give you a little sort of practical tips for pseudo-exfoliation. Cataract in a patient with pseudo-exfoliation, also known as PXF or pseudo-exfoliation syndrome. As you know, there's a deposition of this distinct fibrillar material in the anterior segment of the eye. It's an age-related phenomenon, and the target for the junior people who are just beginning their careers to remember. At the moment you see this, you need to think of both glaucoma and certain specifics about the kind of cataract and the kind of surgical challenges you will face. The other thing I'd like to emphasize is that you can have a whole range of presentations of pseudoexfoliation. So remember that every patient of cataract, you must screen on the slit lamp properly, looking for any slight subtle changes of pseudoexfoliation. Now coming to the cataract, you have to be sort of proactive. When there is pseudoexfoliation, it is likely that it is going to be a more dense nuclear cataract, it's likely to be harder, and be prepared for a higher rate of complications. So if you anticipate the problems, modify your surgical planning and technique accordingly, you may be able to have a better outcome. There is a tendency for poor pupillary dilation, so do check the patient pre-operatively when you're assessing, and make a note, because you may be seeing the patient that day and another person may be taking care of the patient on the day of surgery. So just make a note that the pupil dilates at to how much. And remember, if you have a patient like this, don't keep pouring buckets of phenylephrine and tropicamide in the eye, because it's not going to dilate beyond a particular limit. And the other thing is there's likely to be zonular weakness. So therefore, as a result, there is high likelihood that you may have lens dislocation during the surgery, and then of course a risk of a PC rent. If everything goes well, still post-operatively, normally we don't worry so much about raised intraocular pressure, but these patients may have post-operative IOP spikes. They may have later capsule phimosis, prolonged inflammation, and corneal decompensation related to all these factors. So all of this you need to look out for. There are actually some systemic implications. Some biochemical abnormalities have been sort of implicated. There could be elevated homocysteine, but this is important. There may be associated systemic disease, and therefore the corollary or vice versa will also be true. You may have patients with cardiovascular or CNS disease. Look more carefully in them for any evidence of pseudoexfoliation. There has been found to be a positive correlation with hypertension, angina, as well as MI, and it has found that 50% of patients with pseudoexfoliation had cardiovascular disease, which was 3 times more than normal. However, this is not data from India. It is data from Europe. So we could look at our own patients and see what it actually is. There is a genetic association. It could be familial, and there are gene mutations which have been described, lysyl oxidase like 1 gene, which is responsible for synthesis and maintenance of elastic fibers, which is biologically expected. However, the role of genetic testing is not validated. So you do not need to genetically test such patients, but you need to be proactive in terms of expecting the complications. And these are some very nice papers that you can consult. So before surgery, as I said, each patient may not be the same. So look for glaucoma, poor pupillary dilation, zonulopathy, poorly dilating pupil with white flap, and prepare for a poorly dilating pupil, as well as intraoperative floppy iris syndrome, which may also be because of the associated cardiovascular condition and any other additional medication. So iris hooks and maybe a pupil expansion ring. Now during the capsulorhexis, nucleotomy and cortical cleanup, these are the points where you may have extra problems. So if there is zonular weakness, watch out at the time of initiating a capsulorhexis. Is there any wrinkling coming, or is it difficult to initiate your rhexis? Because often that would indicate that it is elastic and loose. Place CTR, be prepared with a CTR, control the rhexis, and what should be the size. If the pupil is too small, you should put the iris hooks and do the rhexis after that. Watch out for stress on zonules. Hydrodelination again, put little small bursts of fluid at different pockets and gently rotate the lens rather than very aggressive. And you could consider horizontal chop in such patients. When doing the cortical cleanup, strip the cortex tangentially towards the dehiscence if you notice a dehiscence. That's it basically. So you have all these extra practical tips that you need to take into account when you have a patient like this. Thank you.
Thank you, Professor Radhika, for highlighting all the nuances of managing pseudoexfoliation cataract effectively. Now I would like to invite Professor Vanathi for our talk on intumescent white cataract. If there are any questions in between, we could take up before ma'am sets up her talk.
Good afternoon. So, continuing on the surgical tips of managing special cataract scenarios, I'll be speaking to you on intumescent white cataract, no financial interest. So I'll just take out or highlight salient features which one would encounter when you're managing intumescent white cataracts. All of us have handled these scenarios. And the swollen lenticular material causes an increased anteroposterior lens thickness here, and also increases the lens capsule, makes a lens capsule tense, thereby resulting in raised intralenticular pressure. And these are the particular scenarios you will have to be anticipating when you are managing intumescent white cataracts. So preoperatively, the concerns here would be the biometric imaging in these patients here. And sometimes, as already highlighted by our earlier speakers, when you have a very dense posterior nuclear plate or you have a posterior polar associated in these, then biometry imaging becomes difficult, and you will have to resort to manual methods of axial length estimations in these patients. So when you are planning premium IOLs in such cases, you will have to probably look and relook at your biometry before you are planning toric or trifocal or multifocal IOLs in such patients here. Again, posterior polar cataracts associations can usually be missed if they have not documented in the patient's medical records earlier. So that's something you will have to keep in the mind. And several times patients do miss telling us a history of trauma here when you are looking at it in a relatively younger patient. So always examine more carefully for looking at pre-existing zonulopathies. Look at intraocular pressures here for the association for glaucoma here, especially when you're going to dilate these pupils here. The shallow ACs because of increased anterior posterior lens thickness is also a concern which you will have to look at, and probably you will pre-plan on the oculoviscoelastic device you will need to use in these conditions. And of course, fundus imaging is difficult, and you will not be able to pinpoint any other pre-existing fundus pathologies in these patients here. So what is most difficult, or what intimidates all the surgeons who are just starting these cataracts is always the capsulorhexis here. So completing or being able to achieve a good capsulorhexis is something which is most challenging in these because of the salient features as I highlighted here. A tense anterior capsule because of the increased intralenticular pressure in these patients here. So a tip here is always keep your chamber watertight here. Do not have any leaks. Use good or higher viscoelastic agents here so that you will be able to control your intralenticular pressure here. And whenever you feel your capsule is running out of control, go back and form the AC well again before you resume your capsulorhexis. So the intraoperative problems which can again compound managing is if you have a presence of floppy iris syndromes, and if you have poor dilatations, always pre-plan in your surgical planning to think about using pupillary expanders to help in better surgeries in these patients. Your incisions need to be made well so that your chamber is always watertight here. And again, the emphasis is on capsulorhexis. The multiple punctures or the first puncture to release the capsular tension can lead to elongation of the tear of the anterior capsule in the same axis as that of the puncture. So I think this is more important in understanding some of the newer additions in management of tense capsules in intumescent cataracts here. So always beware of the Argentinian flag sign and be prepared to manage the subsequent events in such a state here. Remember, most of these white cataracts can be nuclear cataracts here, so you do not have the luxury of having a posterior cortical cushion here, and the associated and the risk for posterior capsular dehiscences, nuclear drops, and inducing zonulopathies can be higher, especially if you are beginning surgeons here. So what are the particular tips you need to, or what are all the various described maneuvers for managing capsulorhexis here? Again, aiding it with trypan flu staining here, use of higher molecular viscoelastic higher molecular weight viscoelastic agents in order to flatten and manage the capsule tension in these cases. Managing intralenticular pressures adequately when you're initiating your capsular access is probably the most important or the commonly adopted method in managing these white cataracts, by just making a simple nick here and aspirating the intralenticular fluid before you continue with your capsular access here. A two-stage capsular access, which is a spiral out capsular access or a double capsular access, are also described maneuvers. Puncho access is something which has again been widely talked about recently, using endo eliminators and Warner scissors for managing these cases. And of course, the one single or the best advantage which a femtosecond laser assisted cataract surgery affords in white cataracts is that it gives you a very predictable and controlled capsular access. And you will know that in flax, in white cataract, the nucleus is usually not cut, and you have to complete it with your manual methods. What is new in intumescent cataract capsular management is the sewing needle microcapsulotomy technique here. And before I go on to elaborate something which has been, I think, described from our center, and it is a matter of pride that this is a very highly internationally quoted references coming from Professor Tityal, our chief here, and comparative evaluations of femtosecond laser assisted cataract surgeries have given very predictable outcomes as compared to conventional phacoemulsifications here. And again, the classification of the types of intumescent cataract morphology based on intraoperative OCT imaging here is something also helps you to look at what are the type of maneuvers you would have in these patients here. So due to lack of time, I'm not going to elaborate this, but this is available for free reading for all of you, and please go and look at it. And it also elaborates the kind of maneuvers you would need to adopt when you're looking at the type 1, type 2, type 3 or the type 4 morphological patterns of intumescent cataracts using IOCTs here. Again, simple, I think we'll skip most of the videos because I've already highlighted most of the factors here. Just a small note on if you're doing punchorexes here, you could do it with your phaco probe with a setting of 50% phaco power, continuous phaco power, a vacuum of 400, and best done with a tip of 0 or 15 degrees. Avoid using higher viscoelastics and a HBFC when you're adopting to cause a punchorexis, because this gives you a controlled opening of the anterior capsule and helps you to maintain the, helps you to reduce the intralenticular pressure. This is something which is latest described from India by one of our own alumni here, and this is a sewing needle microcapsulotomy technique which helps to avert the Argentinian flag sign here. The concept behind or the logistics behind this is that because of the rounded shape of this particular instrument which has been divided, it gives you a controlled round shape of the micro incisions made on the capsule to release the intralenticular pressure, and that helps to avert or avoid an Argentinian flag sign. Again, I think I'll stop here, and thank you for your patient hearing.
So thank you, ma'am. That was very quite interesting, and then like you have wonderfully pinpoint all these important points that we have to take care of while handling case of intumescent cataract. So moving on to the next speaker. If there's any other question in meantime, anyone can put on. If there's none, then. So for the next speaker, I invite Dr. Nupur. She will be speaking on the challenging case. Another challenging case is handling a case in case scenario of soft cataract. Yeah.
So good afternoon, everybody. Managing soft cataracts may sound very simple, but it may become a beginner's nightmare. So As we know that the surgical profile of our patients, the maximum number of patients are actually soft cataract, which was not so maybe 3 decades back. With increased visual demands and more patients being aware of cataract coming to us early, we need to be proficient in this managing soft cataracts. So what is different? So the biggest thing is that we have to unlearn our nuclear disassembly techniques and phacoemulsification techniques to actually manage variety of soft cataracts, which some of them may be amenable to phaco chop techniques, but some may just have to be flipped and eaten with our phacoemulsification probe. So using vacuum to hold the nucleus may sometimes be difficult. It may lead to cheese wiring with the chopper, and the phaco probe may rapidly go through the soft lens, causing PC tears. So we need to have the main steps that are very important in managing soft cataracts are basically a very good capsular rexus of adequate size of 5 to 5.5. It is very big. Then the nucleus will prolapse out. It will be very difficult to emulsify it. And a very good hydro procedure. So hydrodissection and hydrodelineation, as demonstrated by Professor Tatyal in the live surgery, is the very important step, with an adequate rotation and adequate use of low power and high vacuum settings for managing soft cataracts. The nucleus can be aspirated or sculpted, as the case may be, and there is a technique which is described by Malazi et al., which is viscofracture. Because of the softness of the cataract, you can actually divide it with the visco elastic rather than with the chopper, which is difficult. So there are various techniques described, which we will go through in the videos. So this is a case of cataract where the incisions are being made, OBD is being installed to maintain the chamber, and a capsular access has been initiated. We can see the hydrodissection wave, which is very crucial and important. A multi-quadrant cleavage can be done with the hydrocannula, and a nucleus rotation has been done. This cataract is slightly nucleus sclerosis grade 2, which is choppable. So chopping can be done, and after cleaning of the cortical matter, which is loosely attached, it can be divided into pieces. We would encounter some other videos where it's very difficult to actually chop the nucleus. So this will be like a routine cataract surgery. At the end of the nuclear emulsification, a good cortical cleanup is actually very important in soft cataracts. So the good hydrodissection and other hydrodelamination procedures also helps in removing the sticky cortical matter, which is very common in these cases. Then the epinuclear bowl is then being aspirated out. And after the cortical cleanup, the lens is implanted. So this is another case of a soft cataract with a toric IOL implantation. The marks have been placed. It's not a digitally guided toric implantation. So after the good curvilinear capsular access, a hydrodissection wave with a hydrodelamination, the golden ring is evident. And here you see that the surgeon is actually having difficulty in rotating the nucleus, as well as there's some problem with it. So it's being the nuclear material is being flipped and eaten with the phacoprobe. The chopping could not be done in this case, and then the epinuclear plate is being aspirated. And after a good cortical cleanup, the toric IOL will be implanted. Another case of a soft cataract where a hydrodelineation ring is evident, and again it will be difficult to chop, so the nuclear. So it's not a full phaco chop that has occurred. So the heminucleus will actually be aspirated with the phaco probe. So care is to be taken in these cases because the nucleus is very soft and the holding power of the phaco probe is not very good because of the soft nuclear material. So low phaco power settings with high vacuum should be used so that there is no chances of any PC tear or going through the epinuclear plate that has been created for safety. The process then completed with a good cortical cleanup and placement of a toric multifocal lens. Just to complete the description for a femtosecond assisted cataract surgery in a case of soft cataract, though it doesn't provide any useful advantage like a posterior cataract or a white cataract, it does help in chopping of a non-choppable cataract by manual techniques. So you could see that you can see these lines whether it is chopped, and it is easier to remove them with low energy. So less of phacoemulsification energy will be used in such cases, and you can see the pie is very nicely demarcated and that have been taken up by the phaco probe. And after adequate cortical cleanup, the lens is placed. Thank you.
Thank you, ma'am. That was quite illustrative and then quite informative about managing a case of soft cataract. If there is any question, you can ask for Dr. Nupur. If there is none, now we have another very interesting interesting case which will be presented to us. And then we are indeed privileged to have our chief sir, Professor Jivan STTL. In the morning session, we have seen wonderful videos demonstrated by sir. Now again, we have very much privileged to hear the lecture from sir again on the topic of flex in challenging situation. Sir.
No, it doesn't matter. I have two talks.
Okay.
So I'll combine both of them, and a very good morning to all of you. It's so can say pleasing to see so many of people have come today physically. I think that shows that we have become immune to all difficult situations. Same as during extracapsular surgery, if your pupil is small, the surgery becomes very difficult. So we have to really see how we are going to tackle that situation, because one of the major teaching is for extracapsular, you need to have a very nice dilated pupil, so that you can do all the procedure very comfortably. So small pupil is relatively challenge for us. So I would say it starts from the examination and the preparation for that particular case. Both the things are important. So if you have a very old patient, may have a senile meiosis, a patient has a uveitic process, then you have a synechial formation that may be causing the small pupil. They may have a fibrous membrane, or patient may be on anti-glaucoma medication like pilocarpine. So if you have those things, then you know that how this pupil can be tackled. or patient may have some systemic disorder like a male patient taking a treatment for a benign prostatic hypertrophy. So those things will combine your difficulties on the table. So you can say pre-op, if you look into topical medication which we put in these cases undergoing cataract surgery for extracapsular or a phaco, so topical mydriatic or a cycloplegic is compulsory for all these cases depending on a patient's indication wise. And if you add NSAID into that, that will really increase the sustainability of dilatation during the procedure. That is very important. And this NSAID drops will also decrease the post-op pain and inflammation also. So that's an added advantage to all preparation for our patient, and this is quite effectively used by all of us now to add NSAID drops in a pre-op preparation in your case. Intraoperatively, you can use a pharmacological agent to dilate your pupil in case it's not dilated well, or you can use various other techniques to dilate the pupil to a size or expand the pupil to that size where you can do a good phaco in your cases. So this is one study to prove that the pre-operative NSAID will really be a benefit or not a benefit, especially now you have a concept of putting a single drop for your patients, especially bromphenic and naproxen, which has come to 0.3% naproxen or a 0.09% which is bromphenic. So we did a study to compare single dose versus twice dose. We know that both are effective as such in these cases. The other agents which can be used intraoperatively, intracamerally is, you can use a combination of drugs which normally would have a lidocaine or a xylocaine as a primary constituent because that's going to decrease the pain if you are doing a topical anesthesia surgery. You can add various other things. Phenylephrine can be added. Now you have a combination of phenylephrine and tropicamide also into that. So you can have a very nice sustained dilatation and control the inflammation in these cases. So this is how to identify which type of people we are dealing with. This attack from Ukraine. So how do we identify which type of people we are dealing with? So this is the one sign which I call a flutter sign. Your flutter is smaller, that means your pupil little more rigid side. If flutter is too much, that can be either a floppy iris or it is not fully prepared by you in a pre-op condition. So this is just to show how we identify a flutter sign. So I'm making an incision here because normally all incisions are aqueous free. No aqueous leaks out at this stage. So I have done all 3 incisions without any difficulty here. Just see when I am injecting the viscoelastic to form the chamber, see the pupillary margin. Could you see that? So that's a flutter. So this was a slightly smaller flutter, and maybe intracameral device or a pharmacological agent might dilate the pupil to a size and sustain to complete your surgery. So under the viscoelastic cover, I'll inject little bit of adrenaline, which is 1 in 1000 solution, just underneath the pupillary margin and see what happens. Beautiful dilation of pupil. So what we have learned here, 2 things. One is the appearance of pupil when you are intervening inside the antechamber. That can be your incision where the aqueous leaks out, or when you are actually going inside the antechamber by various agents like a viscoelastic instrumentations. So that will decide which type of pupil you are dealing with. Second is you are using the intracameral medications. You should avoid damage to the surrounding structures. Which are those important tissue? One is the corneal endothelium. So you saw here I injected the entire adrenaline under the viscoelastic cover. So nothing will hit towards endothelium. So that is very important, a very small amount. So normally these are either 2 cc syringe or a 1 cc syringe. So don't inject in the bolus. And sometimes under topical anesthesia, this injection of fluid hitting the pupillary margin, patient will cry because it's a painful step. So it should be very mild and very gentle in these cases. This would allow a completion of surgery, and see that I can inject viscoelastic and complete this surgery. So this is another pupil, which is a small, you can see hardly 3 millimeter. So this would be a little, you can see I'm doing a 2.2 incision. Let me go a little faster. Made a 3 incision here and absolutely injecting the viscoelastic. There won't be too much of flutter at all. So this is a rigid pupil, and this pupil will sustain throughout your surgery, may not constrict at all. So we have to identify rigid versus the floppy iris at this stage. If you have rigid pupil like this, maybe we can complete the surgery without requirement of any this thing. Only consideration here, if you are doing a toric IOL or a multifocal IOL, your exercise may be little tough to attain a 5.5 millimeter here. So in case such cases, you need to stain the capsule so you can see better. Or maybe your rotations normally goes little underneath the pupillary margin. If rotation is better as per your routine surgeries, you can complete the rexes in these cases. Now this is the case of a rigid pupil where I could complete my surgery without, you can see the size has remained same. I didn't use the adrenaline in this particular case. So this is what we talk about, rigid versus or a floppy iris pupil in these cases. So this is a case where you have a floppiness. Again, the flutter sign will be there. Incision here, you can pupil size shape also gives you an indication this will be a little floppy. You can see I'm injecting the adrenaline under the viscoelastic cover. Did not dilate that much, but I knew that I can manage this case very, very nicely. Unfortunately, I don't have the Phacoeparameter here. Once you suspect a pupil which is little floppy, then you have to have a Phacoeparameter little moderate. Don't have a too much of flow rate which will disturb your anterior chamber that much. Do a slow motion phaco, go little deeper, don't let your iris tissue get damaged. So this is a classical floppy iris picture. You can see the pupil is not round, clear, and the surgery is definitely going to be difficult. So I would have decreased my, normal, my IOP is around 50. In this case, it will be around 30-35, so that I can manage. Good hydro procedure is mandatory in all cases where you have a smaller pupil. And this is a soft shell technique, as you saw here. So again, the same technique being used. I'll just go a little forward. This is a soft cataract, managed chopping, which is normally, the phaco power or OGL power is almost zero in such cases. See, the pupil is nicely maintained despite being a floppy iris. So this is an important parameter to be checked, that your parameters should be less. So this is a toric IOL. I am showing this video how to manage a toric IOL in a slightly smaller pupil, because sometimes it's difficult to see the marks either side. So both sides will be difficult to see here. So this is towards the end of surgery. Take out viscoelastic. If I can see marks from one side, and I have put my marks during your viscoaspiration to a clearer side, this also gives you an indication your axis is in the correct position. But in the most small pupil, difficult to see the marks. People would do a stretching the pupil at that area to see the marks, or you can put devices to increase the pupil size to see your lenses properly oriented. I remember Dr. Siri Ganesh had devised the sort of putting a mark across the lens also, so that you can see the entire toric axis in these cases. So this is one small trick for floppy iris cases. You can see the indication of floppiness is, see this particular area. The iris will come to that area where you have an outflow going on. There are two areas of outflow when you are doing phaco. One is the main wound, second is side port. Main wound is well controlled by your instrumentation, because your sleeve will cover the entire diameter of a wound which is getting stretched. But the side port is not controlled. You're making incision maybe 1 millimeter, 1.2 millimeter, but the second instrument is not uniform. The tip will be little smaller diameter, the outer area little bigger diameter. So there will be always a fluid leaking from there. So if your pupil is not rigid, iris here. So how do we manage such cases? You have a reasonably good pupil, but the iris is floppy. So what we do here, we inject a little bit of a dispersive viscoelastic, like viscoat, which will remain as a bolus that area and prevent iris to become a floppy, because the fluid will not go inside the pupillary plane at that area. So this is what is happening here. I could complete surgery effectively in these cases. So to look into that, few videos I have showed for a small pupil. The first thing is do a good pre-op management. Add NSAID for all your cataract patients, not only for pupillary maintenance or dilatation, but also for pain factor also, and decrease the inflammation. Second, identify which is floppy, which is rigid pupil. That can be done pre-operatively also, but classically it is seen intraoperatively. Then you can use intracameral various devices which can enlarge the pupil, like rings or hooks, but intracameral drugs can also manage without disrupting the pupillary margin. high molecular weight can be used, viscoelastic can be used to expand the pupil little bit. But these are normally cohesive viscoelastic and they don't retain inside. They'll come out as soon as you enter with the fluid. So cohesive viscoelastic is better in those cases. Low fluid phaco is, as I told you, for a floppy iris is important. And if you are doing an aspiration of a thick epicortex, which is normally in these cases remain because your pupil is small, your hydro is not complete, you have very thick epicortex. And you can't take out with the phaco probe also because you're worried to damage the posterior capsule. So irrigation aspiration becomes very tough. In fact, you have a more time going in that area than a phaco per se. As you have seen in one of the cases shown by Dr. Nupur. So it's difficult to aspirate the epicortex. It's normally thicker in a soft cataract. So bimanual aspiration will be very helpful in such cases. So any question at this stage before I shift to other one? Dr. Damartha is asking Phenocaine, which is a new product from Intold Pharmaceuticals. They have a good combination where apart from the lidocaine or xylocaine, they have added tropicamide also in that. So that will have a longer lasting pupillary dilatation. And if you see, if you compare all these cases, the pain factor also decreases in these patients and the pupillary dilatation maintenance is much better if you have these patients. But if I do a case control study, I'm not sure because I have not used phenocaine type of medications intracamerally till date. I've been doing topical anesthesia surgery since 1996 or 97. Never used intracameral xylocaine till date. It may be hard cataract, it may be small pupil, it may be hooks, it may be anything. Not used. The only time I use phenocaine is the samples provided to me for a CAM surgery in Ladakh, where we thought that patient may not be cooperative, but they were very cooperative. So it is definitely beneficial. The only consideration I will say all of you is don't inject these drugs in an open chamber. Like you inject a dye, like for staining the anterior capsule, you can inject anyway. But these drugs may be toxic sometimes, though they are now preservative free. But it's always better to use under the cushion so that you don't hit the other structures. If you use these drugs, if you use adrenaline also onto the corneal epithelium, the epithelium becomes edematous immediately. So you can imagine what will happen to endothelium. So you should be little careful in those cases. Thank you, Namata, for asking that question. Any other questions? Because you all deal with these situations. Because initially we used to get a cardiac adrenaline which was preservative free. Now the supply is not available to us, so we do have adrenaline which has a preservative. We would dilute 1 into 1000 and use a very small amount that will be less than a 0.1 cc inside the eye. And it is under the cushion of viscoelastic that doesn't come out to any other place. So that's the only effective way you have to use. No, it is intracameral use. Irrigation is a large, 500 cc system. So whatever you use, either the concentration will become very less, it will not be effective, or it will be running for an entire, normal average fluid for a surgery, for a phaco surgery, for a surgeon like me, around 80 cc. For a beginner, it may be 400 cc. So imagine 400 cc running throughout the system will cause more problems. Even adding the antibiotics in the bottle should be restricted because that fluid keeps going on for the entire duration of your surgery, and especially aminoglycosides, they can cause macular infarct also. So very careful adding into the bottle. We should not now in today's generation not be cutting anything because you have so many devices where you can manage these areas. The cutting of sphincter would be, I would suggest in those cases where you have a absolutely fibrous membrane on the pupillary area, which sometimes you see in uveitic patients. So you cut and you can sometimes release the adhesion from the pupillary margin also. If that is not possible, you may have to cut those membranes. Otherwise, for normal people, don't cut the margin. You use various devices. You can have hooks that are very good. People have come out with a 4 hooks idea to begin with. Then if you see those manufacturers, they give you 5 hooks nowadays. So 5 hooks is not a good idea at all. If needed, it should be 6 hooks. So that you have a very nice hexagonal appearance of a pupil, less stress on the pupillary margin. 4 is less, 5 is inadequate, and 6 is the best way to handle this small pupil. That is as good as a, intracameral devices. It may be like a Melugan or a B-hex. They all give you a hexagonal appearance. That's why the name B-hex, because it gives a hexagonal appearance. Okay, thank you. Let me go to the next part, which is femtosecond laser. Some of them are nicely covered by Dr. Vanati. And thank you, Vanati, for showing my publication there. So we talked about casselotomy. Casselotomy, we all began with the casselotomy. When we are doing extracassular surgery, ECC, IOL, we learned how to do casselotomies. And one of the best was a beer can capsulotomy in those cases. And you had to do a very small nicks in the capsule so that it doesn't tear out in those cases. So same has been replicated by laser system. If you do a femtosecond laser, it gives you a capsulotomy, not a capsular excess. So that's the difference here. But fortunately, this capsulotomy is quite strong and it would resist the tearing also if done properly. So this is what people say. If you do a femtosecond laser, you get a very nice circular capsular cutting into the anterior capsule and manage. And this is our study where Vanati also showed. We compared in the wide cataracts femtosecond versus the manual capsular excess by an experienced surgeon. And two important things are classically, you can look into two areas. One is the circulatory index. How circular is your excess? That is better in definitely the femtosecond laser, because it gives an automated placing of the lasers in area which cannot be replicated by a handmade capsular excess. Second important thing was, diameter wise, because diameter is important whenever you're looking for a lens to be under the capsular bag. So both were equally good, though femtosecond was a little better than your manual excess in those cases. So it is all depends on how experienced surgeon is in these cases. So let me just show you one of the wide cataracts which we manage. There are few, I think, indications. We can manage all type of cataract by manual surgeries, but there are some indications where you may have a little advantage. So one of them is a wide cataract, especially the intumescent wide cataracts, where you have a more tendency for a excess getting to periphery or uncontrolled, which will be better in a femtosecond laser. So you'll see in this particular case, this is an intumescent wide cataract, though it is type 4 of my classification. If you see the OCT here, the entire anterior capsule is a convex. Convexity indicates there is some sort of pressure. And see the uniform, echo generated by the OCT in the femtosecond. So this will be a more of a fluid type of cataract here. So we are now doing a capsulotomy size, which is normally 4.9 for all cases. So you'll see now we'll be delivering the laser. Once you program, just see this area, the gush of fluid coming through. So you can see how much intralenticular pressure people talk in a straight line examination. Looking into anatomical configuration, they say this case has a increased lenticular pressure. That can only be confirmed by this procedure, where we open the capsule under the normal anterior chamber pressure. You saw that fluid coming out of the gush. That shows that there is an increased lenticular pressure, which may be fluid, which may be hydrated lens capsule also. So these cases would require a little bit of a manipulation of like a capsular excess, because you may have a tax. So all wide cataracts might have a tax when you actually look into. If you see here, I'm staining the anterior capsule with Japan blue dye. So this is the area where fluid leaked out. From fluid, the area from fluid leaks out, it will be completely cut, but other area may not be completely cut. So that area you have to manage by doing a proper rhexis type of picture, and it will normally get a nice rhexis orientation also. So this is what completes the surgery in these cases. So this is one more case. If you the intumescent wide cat, you can see the OCT picture will give you classical appearance of a type 2 type of wide catheter, which I had on our classification. You can see entire range of a length of cortex is hydrated. The fluid pockets are inside that. They are not outside. So if even you make a puncture, the fluid will never come out. A pressure will remain high in these cases. So this is a manual surgery. Just to compare that, you can see, I'll just go faster. You can see this has a, you can see the bulge which is there in these cases. After the staining, I'll make a nick. So once you make a nick, there's a tendency for it to go to periphery because there's so much of intumescence. So this case, I would have initiated either the swing needle type of description which Dr. Vanati talked about, or I made a small nick and made a small opening. So what to do here? I think Dr. Namrata is very experienced in this for having more of Argentinian cases. I was lucky. I had to use a very high viscosity viscoelastic. It didn't go that fast. So I was thinking what to do. I made then I made a cruciate incision so that the forces transmit into 4 directions, and that decreased the thing going to periphery here. So high viscosity viscoelastic is important, and not going to periphery is also important. I'm just thinking, it's not edited. So I make a 1 nick here. That is true. That's a sometimes that time. See that what I'm doing a 4 incision here. So this is one way you can tackle if the time permits, if the situation permits you. Then subsequently I could complete this surgery as people would do it. So other important area for femtosecond, this is a instrument where it can give you access to a toric marking also. So it gives a little bit of nudge in the capsulotomy. You can put in the axis as per your topography analysis. Picture is transported and laser machine will give you, and this is the nudge here, and that gives you orientation also. It can be used for various other devices like patient with phakic IOLs with cataract. You can do all the procedure. Capsulotomy, nucleotomy can be done before you remove the phakic IOL, because sometimes phakic IOL removal would cause so much of disturbance in the antechamber. If pupil constricts and the pigmentation comes up, the surgery becomes very tough. If this can be done beforehand, the surgery becomes simpler. The last thing I will talk about is a posterior polar cataract, because this is the technique which is very useful. This is an actual translation of a previously described technique of a layer by layer phaco. Here we do 3 chops and 3 rings of safety, or a nuclear, you can say femto delineation in these cases. So that gives you segments, first tier, second tier, 3 tier segments of nucleus in blocks, and you have a cushion of epicortex which is normally 1000 micron in these cases. So this is what you'll see in the video here. So this is a posterior polar cut. You can see here posterior polar, which is and we do around 4.9 millimeter capsular axis. Posterior pole is seen here. Then we'll do a 3 chop and 3 rings, which gives you a segmentalization of an entire nucleus. And this is useful in those cases where your nucleus is a little on the harder side. If you have very soft cataracts, then you may not do a chop in those cases. You can just do a rings, which have been described by Dr. Abhay Basavada group. Just rings of safety can also manage in these cases. Just see how it looks on the in the microscope. I've taken out the free floating capsule. And this case has not been hydro delineated, hydro dissected. That's the advantage of femtosecond. You don't have to do delineation. As soon as I'll separate this chop area, the bubble will come out and the fluid will seep into that space. And that will create the internal hydro delineation happening. You can see that bubble has come out and fluid will go inside. Subsequently, the pressure comes down. And because of cushion, it will not translate into the posterior capsule also. Simply it can be separated. This is the second block I am taking out. This will be another block which I'll take out. You can see each block can be picked up without causing stress to the addition of posterior polar cataract to the capsule or to the general area. The same concept can be also be used in cases with the subluxation also. You can see each block can be just picked up by your instrument, or a second instrument can also detach these blocks from the periphery. Now you're left with a epicortical cushion that can also be taken by layer also. So that's a beautiful advantage of femtosecond in describing. You can use the same technique in your manual surgery also by doing a good delineation or a multi-layer delineation of posterior polar cataracts. This is a step very important. Don't come out before you make the chamber stable, as you saw in a live surgery also, and that makes things absolutely clear. Thank you for kind listening, and any question I can answer. सबसे होशियार लड़की सबसे पीछे बैठी हुई है. So she is asking, is SICS will be better in a posterior polar cataract? That's your question? Okay. Those people, students or those teachers who are only doing SICS, yes, it will going to be beneficial to those people. But if you have access to a phacoemulsification surgery and you are well versed with the technique, or if you have a femtosecond laser device in your setup, you should use these, because these will give you a pre-programmed planning of your surgery, and also give you the right size capsular access or capsulotomy, and pre-fragmented and pre-softened nucleus for you, where surgery would become simpler. And that is important. SICS, we all know it's going to cause, definite upshift of a posterior capsule when you are removing the nucleus. And sometimes this device, which you use, various techniques used for SICS, might damage the posterior capsule at that stage. And it is totally uncontrolled surgery when actually nucleus is coming out, which is not there in a phaco surgery, where it is well controlled in your visible area. That is the only thing I deviate onto SICS. When actually the nucleus is coming out, we are not seeing anything what is happening inside the anterior chamber. Till the nucleus comes out, then you see what is happening there. Entire bag would have come out, or sometimes the entire posterior capsule would have come out. I've seen people getting the entire iris also coming out, and then it becomes aniridia in some cases. So that's a difficult scenario. But yes, if somebody is experienced, they should do it. Please, mic जरा बड़ा करो. इसका next किसका?
Sir,
Lomi.
Post smile, any patients who have to undergo this small incision cataract surgery, so will that affect the outcomes? So while making the tunnel and all, if a person has already had a smile surgery, post
No, you mean to say this particular case has to undergo cataract surgery subsequently?
Yes, sir.
Which type of surgery will be feasible? All these cases, Lasik or a smile, the incision is quite anterior to the limbus area. And all cataract surgery incisions are, phaco are a near limbal incision. SICS is far off. You are making a pocket starting at least 1 millimeter behind the limbus, and which is inside the anterior chamber, that is, in a deeper part. It's not going to affect your smile incision or a Lasik incision. Yes, if you are doing a vitreoretinal surgery, then you should be careful if patient undergone Lasik procedure. I've seen people are taking off the entire flap during vitreoretinal surgery because they want to scrape the epithelium. Cataract surgery, no problem.
Thank you, sir.
Yeah, thank you. Most welcome.
Thank you, sir, for sharing all the tips and tricks of challenging cases. I'll now invite Dr. Lomi for his talk on supra-hard cataract, managing this challenging condition.
Okay, very good afternoon. Thank you, ma'am. So I'll be speaking on phacoemulsification in supra-hard cataract. So when you look at case with a hard cataract, you will be finding, you'll be expecting or anticipating some difficulties. Since they are old age, they have a poor corneal endothelium count, they're weak zonules and hard to chop nuclear fragments, take longer times for emulsification, and also have a higher risk of wound burns. So in this, I'll be showing the basic two videos, the stop and chalk technique and the divide and conquer technique for phacoemulsifications. I have no conflict of interest of any product used during this procedure in the video. So this is a grade 4 hard cataract. So we need to stain the capsular axis. This is very important, and an adequate size of capsular axis is paramount, at least or not less than 5.5 millimeter. And a gentle hydro dissection into the 3 quadrants, and then gently rotate the nucleus. Then followed by making a trench. You know the lens anatomy, the center is thick, the thickest part. So like you have to have a trench of around 80 to 90% depth. Using a scalp scalp setting, that power is around 80% continuous torsional. Here your left hand should stabilize the nucleus, and then you should avoid pushing the lens, that the phaco tips to flawlessly go enter and then do the scalp strange. This followed by chop. Chopping is like you do the lateral separation. You put the phaco tips deep enough and then put a second instrument, and then you do a lateral chopping. Here you need to increase the vacuum power, vacuum pressure to around 500 millimeter of mercury to hold the nucleus. So you do the this chopping into around 4 to 5 fragments, which will be followed by, you can put a viscodispersive to coat the corneal endothelium, and followed by the normal fragmentation. Using this setting, you can use a very low power also, around 40 to 50%. That is good enough to continuous torsional, and the flow rate is around 40 cc, and the vacuum around 500, and then infusion pressure you can keep around 50 to 60 millimeter of mercury. So the idea here is like you should have a minimal turbulence and a minimal lens chatter, and your your chopper should be on the nucleus to prevent that to frequent touching of the corneal endothelium. So this is how you complete this phaco-fragmentation, emulsifications. Our next video, I will show you a divide and conquer technique. Here you need to make a very deep trench again with the similar setting, around 80 to 90% of continuous torsional power, and it is trench made in all these 4 quadrants, and it should be deep enough, so that, and while doing this chopping, your both instruments should be deep enough so that you can do the lateral separations, and it should be gentle enough that you did not put any stress on the zonules. This is very important, because in hard cataract you will expect that the zonules is usually weak. This is followed by you can place the viscodispersive to coat the endothelium again, and then you do the quadrant phaco-fragment emulsification using this setting around 50% continuous torsional, or you can use the IP mode on with this flow rate around 40. So 3 points that is important here is you have a deeper plane of emulsification. Try to do in the capsular axis plane or in the pupillary plane, and minimal turbulence and minimal lens chatter have to be maintained. And one important thing is like the combination of the flow rate, vacuum, and power have to be well balanced with the foot pedal. And all the time your second hand, that the chopper can be placed over on the nucleus side, so that to prevent the nucleus from rubbing the endothelium. This is followed by the normal routine irrigation aspiration of the cortical matters, and followed by this implantation of the IOL, and removal of this viscoelasis, followed by the wound hydration. So you can see even in the hard cataract you can get a fairly decent clear cornea. So to summarize, what we need to understand is we need to have a larger capsular axis size so that we can manipulate the nucleus well, and also it will give a less stress to the already weak zonules. A deeper trench and deeper placement of the instrument is important for separation of the nucleus, and use of viscodispersive product to coat the endothelium. Minimal turbulence, minimal lens chatter, and deeper plane of emulsification. And also most important is the balancing the power, the flow rate, and the vacuum. Thank you all for your attention.
Thank you, Dr. Lomi. It was a wonderful videos demonstrating the hard cataract management. I think few important things he highlighted. One was, debulking the hard central core of a nucleus, which is so important to if you are doing a chop technique. That is making the grade 4, grade 5, or a 5+ nucleus to a grade 3 or grade 4, because you have taken out the central thick core. So that where you can do a trench and chop or a crater and chop, which is a described technique for a very hard cataract. Second, he showed a very beautiful video of making a divide and conquer technique, which was the first technique described by the various phacosurgeons for all type of cataracts. So it is still useful for grade 3, grade 4, grade 5 cataracts. Works in the same principle of a debulk in the center area. Many people would do a direct chop also, and many people do a cracking of nucleus. That is also advisable if you are having a good control of your system, that is phaco, hand and eye coordination and foot switch also. Especially those cataracts where you have like a Morganing type of cataract where the bag is almost free, nucleus edge can be seen, because you can crack those nucleus where the edge is visible. That means you have to go deep into the nucleus and pull the nucleus up to the rexal edge, so that you can take your long chopper to the periphery and then crack the nucleus. So that requires a little experience and can be done in many cases here. And third important thing he highlighted was to cushion out the endothelium by doing a soft shell technique in these cases. And most cases will have a difficult scenario sometimes. The pupil might constrict sometimes. Sometimes your last piece may be too bulky, and your capsule may not be very taut. Sometimes there is a floppy posterior capsule. So many people have described doing some sort of a scaffold technique. You can put the IOL in the bag, then take out this last thick piece towards the end under the viscoelastic cushion. That will safeguard the posterior capsule in a especially hypermature cataract where the capsule is very, very frill and very weak in those cases. And many patients will experience the little bit of edema next day. Patients should be counseled. Accordingly, you should treat those patients, and if possible, all these difficult cases should have access to a specular microscopy for these cases for documentation. So you know that what type of endothelium they have. Accordingly, you can advise them. Recently, many people use Rho kinase inhibitor in these cases. May be useful or may not be useful, but people do try in these cases. Thank you, Lomi, for a wonderful showing videos in these cases. Now we invite the person who is savior for a posterior capsule, the Dr. Praful Maharana, who will be talking to us on how to manage posterior capsular damage or a rent, and how to predict and how to actually come out of those difficult scenario. Dr. Praful, please.
Thank you, sir. Good afternoon, everyone. So I'll be discussing management of PCR and torn rexes. I'll be showing you a few small clips to tell you what you should do and what you shouldn't. I have no financial disclosure, but I have an agreement not to disclose surgeon's name. So please don't ask me surgeon's name. No. So whenever there is a PCR, I'm not going into the theory part of that. So whenever there is a PCR, what you should do immediately, as you can see in this patient, everything went fine, including hydrodissection. Yes, then the nucleus division, but unfortunately during the last part of nuclear emulsification there was a PCR. So whenever such thing occurs, the one thing that you should never do is don't come out in a jerk manner and let your chamber collapse. If you do that, a small PCR would become much larger and there will be vitreous prolapse. In this video you can see the surgeon perfectly removed the second side port instrument, and then he removed the phaco handpiece. Now in the second clip I'll show you what to do. Once you have done this, what should be done. So you can see this was a case where it was a challenging case done by Professor Namta Sharma. You could see there was a pre-existing PC defect, but everything was managed so nicely. I will not show you the complete clip, but this is what you should do. After nuclear phacoemulsification, you could coat the area of defect with visco-dispersive viscoelastic. On top of that, some visco-cohesive viscoelastic. This is like a modified SNOS technique. Why this will help you? Because the viscoat or the visco-dispersive will create a barrier, and then the visco-cohesive will allow you to maintain that barrier. Subsequent to that, you can remove all the cortical matter using either a bimanual or a vitrectomy machine. So important point to remember is so that was converted to a circular PCC. I can show you the video if time permits, and IOL is put inside the bag. So if you find vitreous is there, so you have out with your instrument, but vitreous is there, you have to do vitrectomy. So this is the we have Infinity as well as Centurion, but most of our resident use this machine. So this is the standard parameter that you should be using here. Default parameter will be the cut rate is something around 1500 and this vacuum is 500. But when you are dealing with a case of PCR, it's better to start with a cut IA mode, and while using that mode I would prefer to keep the cut rate little bit on higher side, and the vacuum is almost half of what the default mode suggests. And look at the bottle height, this is all 65. The standard phaco is done with bottle height between 90 to 110, but while doing vitrectomy you have to bring it down. And once your cut IA mode is done, you have removed the vitreous in back, then you can go into the IA cut mode as I showed you in the previous video, and then you can remove all the capsular tags that is still remaining in the eye. What next? That depends on two factors. First, at what stage and what is the size of nuclear fragment that is remaining. But the second and most important is your surgical expertise. So most of the time you may have to convert it. When converting, you have to remember few points with use of viscote as well as Hilon that I've already told you. Relaxing capsulotomy. If you think that the capsulotomy is diameter is less, then you have to give some relaxing capsulotomy so that the nucleus can be prolapsed. And enlarge the wound. Don't be too conservative about enlarging the wound, and always use a vectis or a loop to bring out the nucleus, the large nucleus. Don't try pressure, counter pressure. I'll show you one clip of that. And always achieve a watertight closure using sutures at the end of the procedure. The second option is if the nuclear piece is not that big, and if you are expert enough, then you can still go ahead with phacoemulsification. But for that you have to achieve a viscote and Hilon coating and move the nucleus to a safer area out of the area of PCR. Do enterovitrectomy and then use a phacoemulsification with little bit high vacuum, low flow as sir suggested during the PCR during the post-polar video, and moderate phacoemulsification. So I'll show you few subsequent clips where this was a clip where the PCR occurred in the initial stages only while attempting to divide the nucleus in two half only. There was a PCR. The surgeon was smart enough to recognize that, and as you can see, as I was telling you, using viscoelastic, the nuclear piece, it was moved to a safer area away from the area of PCR. Then the wound was enlarged using a 5.5 blade, and the nucleus was delivered using a vectis. So this is another video. Here the surgeon was not that smart enough, but this is a classical case of capsular block syndrome. The rhexis was small and there was hydro dissection using a massive flow of fluid, and the Hilon was still inside the antechamber. So the moment hydro was attempted, Hilon came out in a force and the PC ruptured. While because the fluid doesn't have any space to egress. So in such cases, it's always better to convert, but I think it's at times the surgeon is under stress. So at times your vision, your brain gets clogged, and you often fail to recognize what has happened. So in this video, as you can see, by the time the surgeon realized there is a PCR, the nucleus already dropped inside the vitreous cavity. Here another problem, as I suggested you, whenever the capsulotomy size is small, you have to make relaxing incision. In this case, the relaxing incision was not given, and an attempt was made to prolapse the nucleus into anterior chamber, but subsequently the nucleus dropped into the vitreous cavity. PCR can occur during phacoemulsification.
Can you hold on for that video? Can anybody point out why this capsular, what is it? Block?
Capsule block syndrome
happened in this particular case? Sorry? Wave was not created. The one thing he said that the person did not remove the viscoelastic. Or kush? Smaller capsular axis. Third? Okay. I think if I'm correct, the person was trying to do a hydro procedure from the side port without making the main port. So that will also keep everything inside.
Yes.
So it's normally my teaching for younger people would be to do all three incision before. So main wound is always a savior for you. With a larger incision, if the pressure goes up, main incision might allow things to come out, which doesn't come out the viscoelastic from the side port. They never do hydro procedure from the side port. That's a teaching. It's very difficult situation. So nicely pointed out, which Praful also showed, small rexes, viscoelastic inside and side port.
So this is another video where the PCR occurred during phacoemulsification. As you can see, after making 3 or 4 division, the nucleus will tilt. One of the pole will tilt anteriorly. So you can see here, so there was a PC defect, so that's why there is a tilting of the nucleus. But the decision was right in this case. Immediately visco coating was done and the nucleus was prolapsed into anterior chamber. Then the wound was enlarged and the nucleus delivered. But as I said you in that part, the wrong thing that in this case is don't use your counter pressure technique. You can see the surgeon is pushing the cornea from here. So if you do, you can see a blob of vitreous here. So it's always better to remove the vitreous from behind the nucleus little bit and then go in with a vectis and remove the nucleus completely. Don't try counter pressure technique when you are dealing with such complications. Subsequently, I think the next, even after this, few of the pieces were left. So subsequently it was removed vectis only. Once you have done the nucleus expression, then you have to remove all the vitreous from the wound. Then you can remove the remaining cortical matters using either Simcoe or your bimanual cutter system. And after that, if you are sure that your vitreous is completely out, you can put the IOL inside the sulcus. And if you are little bit doubt, if you are not sure that the vitreous is completely out, few surgeons they use triamcinolone acetonide to take help of that. You can always take help of that, or you can use pilocarpine, which is nowadays difficult to get, to achieve a pupillary meiosis and see if there is any pupillary picking. But most importantly, all these cases you should put suture and you should achieve a watertight closure at the end of the procedure. So this is another video. Here the surgeon took a right call and delivered the nucleus. Here you will see even when the nucleus piece was much bigger, phacoemulsification was attempted, and you will see subsequently the nucleus will sink inside the vitreous cavity, as you can see. And here I have noted a lot of our residents also, they have a expectation that if you stay in the center and press your foot stitch fully, then the pieces may move around and come back. But that is a very wrong concept. Most of the time it will go into the vitreous cavity only. Very rarely you may succeed in getting those pieces. So if your phacoemulsification done, most of the time we are little bit relaxed ki chalo theek hai phaco ho gaya, but then you can have rent during your IA also. And this if you see, everything was fine till this point. You can see everything was okay. I don't think there was any cortical fiber left, but at times surgeons becomes too much involved in the surgery. You can see nothing was there, but still there was an attempt to take out some fine fiber. You can see there is a triangular rent that occurred during this, and patient further complicated that by squeezing the eye, so the rent become very large. However, since nuclear piece is out, you are not that much bothered. You can remove the vitreous and do a nice IOL implantation in the sulcus. But as I said, you have to ensure that there is no vitreous tag in the wound. You can use Vanna scissor or even your vitrectomy also. And this is another trick to ensure there are no vitreous tag in your wound, because at times even after doing all the attempt, you will find some vitreous strand may be there subincisionally. Then you, as I said, do a good vitrectomy and put the IOL inside the sulcus. So this is the last clip. So IOL insertion also can lead to PCR. I have shown this video so many times, but here important thing is two things. If you are loading the IOL itself, that's fine. If somebody else is loading the IOL for you, always make a habit of asking that person if it is loaded properly. And second thing, no, it will come back. The second important thing is, while you are inserting the IOL, please see if you are encountering pressure which is not usual. If the pressure that you have to apply is too much, then it's always better to reload the IOL and inject it. So then come to management of torn rexes. So this was a case of intumescent cataract, as you could see the MIOCT picture suggested. So everybody is not that lucky. You cannot wait. The moment you make a neck, it can extend into periphery immediately. In this patient, initially some aspiration was done, but in spite of that, the rexes extended on both the sides. So whenever there is a torn rhexis, you have to decide whether it is possible to retrieve it or it's not possible at all. So if it has gone into periphery, not beyond the equator, what you can do is you can use this little trick of retrieving the rhexis. Here, so if the rhexis is going peripherally, remember, don't try to go by the usual way of doing rhexis. Rather, you should put the flap back and pull it little bit backward, and you can see the direction of the arrow. Once you pull it back, the direction of this extension may come little bit inward, and after that you can pull towards the center to achieve a rhexis. However, this trick is not always possible. If possible, then you are lucky enough. As you can see, it's not the perfect little technique, but what the surgeon is trying to push it back little bit and then change the direction towards the center of the rhexis. But if it is not possible, or if you have little bit doubt, some surgeons, what they do, they start from the other end and try to get to the initial point of extension. Again, this may not be true, but if you are confident that it's not possible to retrieve, you can judge based on the density of the cataract. If it is a soft cataract, as was in this case, you can achieve a minimum capsulotomy opening and do a lens aspiration. However, if it is a hard nucleus, then it's always better to convert. Here I want to show you one important sign that you can use. If you see this flap, this is the people have named this as flap motility sign also. So always look for the direction of your flap. If it is inverted like this, that means your rhexis has extended beyond the equator. If it is inverted like this, that means the rhexis has not gone beyond the equator. So if it has not gone beyond the equator, there is a possibility that you can still get away with phacoemulsification. So in this patient, the rhexis was capsulotomy was little bit enlarged. At the end of the procedure, to achieve a good visual axis, you can do a little bit more modification with the rhexis. You could see the flap is still inverted, so it has not gone beyond the equator. And then you can put the IOL, and you can do a lot of all the combination of optic capture with whatever you are comfortable with. With this, I'll end with this slide. Remember, all these patients, the surgery is prolonged, and there are a lot of intervention maneuver has been done. So always continue steroid for a little bit longer time. Watch for the IOP spikes post-operatively, and whenever possible, because there may be corneal edema post-operatively, please examine the retina and do a proper screening. Thank you very much. Yes, ma'am is suggesting you can add NSAID like Nevanec, that will prevent the CME. I don't agree if I am giving a steroid of 2 early or 6 times, then yeah. But after steroid, you can continue for 3 months. I think sir can. Okay. Sir had a paper on that.
Thank you, Praful, for showing so many videos from other surgeons. I think you're not recording your surgeries. Because we cannot be free of a posterior capsular rent, which keeps happening in many cases. Sometimes because of anatomical predisposition of a case per se, or sometimes there's something happening during your procedure which may be machine related, or your instrument interaction may be like that. But it is important to realize what stage you have, as Praful nicely pointed out, and how to manage those cases. And effectively managed cases will have a same outcome as normal patients. We know that posterior.
Just to add one thing, each time I get this talk, for last 2 months I am searching for PCR videos from my resident, and it's very difficult to find a video where everything is done perfectly. And this is the important point to carry forward. Whenever there is a PCR, you get into a panic mode and you start doing things wrongly. So it's always better to ask for some experts' help if somebody is around.
No, you can take my videos also. It is very important to manage them very effectively to have a same outcome as routine patients. And Dr. Banalti talked about to initiate NSAID in these patients. And if you see my own protocol, in fact, I give NSAID for all my patients in a post-op period, because my steroid is tapered within the first 3 to 4 weeks. And the classical time of having CME in a cataract patients are after 6 to 8 weeks. So we need to cover them for that period, and subsequently NSAID can go for the next another 4 weeks, and that covers the main time. And various studies will prove that if patient on a NSAIDs, the the edema in the macular area or thickness of macular edema may be significantly better with NSAID, but yes, it may not be able to prevent the CMA happening in some of the cases. In the high-risk patients, diabetic patients or uveitic patients, you may still have CMA, but chances of a visual recovery may be better in those cases. Visual acuity wise, after 3 or 6 months, they may be similar. Okay, thank you for that. And normally we use naproxen or bromphenic nowadays. They are safer and their penetration is much better. If I look for a prophylaxis of macular edema happening in these cases, maybe I'll prefer a bromphenic there because the vitreous concentration of bromphenic is better than naproxen. If I just look at anterior segment inflammation, naproxen may be a better choice. Because the previous generation drugs like ketorolac and other things are no longer being used nowadays. Now we have Dr. Manpreet. He is going to talk about another difficult area, subluxated lenses, and how to manage them.
Yeah. Good afternoon, everyone. I'll be tackling the management of subluxated lens. So the management, the decision-making factors, conventionally we are taught about the grades, the clock hours of dialysis, in addition to the extent of subluxation, the grade of nuclear sclerosis and the etiology, whether it's a stationary or progressive zonular loss, also play an important role in deciding which surgery to opt for. So conventionally less than 3 clock hours, you can go ahead with a low fluidics phacoemulsification with IL alone and a CTR implantation if required. For 3 to 5 clock hours, a capsular tension ring is required. 5 to 7 clock hours, in addition, a capsular tension segment or CONE fixation may be required. For more than 7 clock hours, as you saw in the live surgery, also in intralenticular aspiration with a secondary fixation of IL, retrofixated IL, or a scleral fixated IL may be required. If the lens is going posteriorly, a pars plana lensectomy may be advisable. So this is a case of post-traumatic subluxation with around 3 to 4 clock hours subluxation. One important thing is whatever you assess in this mid-dilated pupil, once you start surgery, the extent of dialysis is going to be 1 to 2 clock hours more than what you see. So the first thing is corneal incision. The main incision should not lie directly over the area of zonulopathy, and any pre-existing vitreous prolapse in AC has to be managed once you make the corneal incision. So we have made a clear corneal incision. Rhexis is the most challenging step. Initiate in the area away from the dialysis. Forceps may be preferred over a cystotome to give you a better control while you're doing the rhexis. Make it an eccentric rhexis so that it's centered with respect to the capsular bag and not the limbus center as you see in this dialyzed state. And at least a 2 millimeter rim between the anterior capsular edge and the equator should be left so that the CONE etc. Can fit in properly. Then you stabilize the capsular bag once you have made the rhexis. Iris hooks or capsular hooks can be used. Some people also advocate that you can put in a CTR at this stage. However, it's challenging to insert at this stage, and the subsequent nucleotomy, nuclear emulsification is more challenging. So iris hooks, the only disadvantage is that it can lead to a tear of the rhexis edge, and once you have a torn rhexis, then implanting a CTR is very challenging. Nuclear emulsification, do a hydro dissection and delineation, do not rotate the nucleus. And low fluidics phacoemulsification of course is preferred. You do not want any sudden chamber decompression. So whenever you come out with the phacoprobe, first inject a dispersive OVD so there are no chamber fluctuations, otherwise you can lead to an increase in the amount of dialysis. Bimanual or hybrid irrigation aspiration is preferred for cortical cleanup so that the dialysis extent does not increase as it may with coaxial alone. The hooks are removed at this stage. So you just evert the hook so that they face upwards and do not entangle in any intraocular structure while you are taking them out. After this, you have to do a permanent fixation of the capsular bag, either with any of the capsular support devices available based on the extent of subluxation. In this, we implanted a CTR. So you have to tamponade the area of the subluxation first with the CTR. Trailing haptic has to be left within the bag carefully. If it goes in the sulcus, it will entangle in the zonules and a mess is created. You will lose the bag after that. If you try to dial it back in, there's no way. So I use a Sinskey, you can use a McPherson, you can use 2 Sinskey, but it has to be left within the bag. After that, an intraocular lens can be placed within the bag and OVD is removed and the lens is well centered, in this case towards the end. So this was a case in which, since the extent of subluxation was less, we could get away with the CTR alone. In this, it was around 6 to 7 clock hours of subluxation, so a CONE was planned. So just a few surgical tips. Scleral flap has to be made before you make the corneal incisions. Rexes, of course, will be more challenging since it's a higher grade of subluxation, so use a forceps if you want. The rest of the steps, surgical steps, stabilization of bag, etc. are similar. This was a softer nucleus, so nuclear emulsification was not that challenging. Important is when you have to dock the 90 proline, so we use straight-ended needle, and 26 gauge is introduced through the scleral flap, and then the needle is docked in the 26 gauge needle. This is a proline needle being docked, and it is exteriorized. Similarly, you do so with the other end, and the exteriorization of the two ends of the proline needle have to be at least 1 millimeter apart, so that when you tie the suture, there is no cheese wiring and cut through. Again, inserting the CONE ring, you have to be very careful that the thread does not entangle in the ring. The ring goes in the bag, and the eyelet and the hooked end has to be above the capsular bag. The sutures have to pass above the anterior capsular rim, not through the bag. And this eyelet goes as a trailing end, and you can titrate the sutures simultaneously so that they do not entangle while you are inserting the CONE ring. Leave the trailing haptic within the bag, that is the most important step. Then you can tighten it. The final tightening of the sutures can be done after you implant an IL as well, so that you can titrate the centration. The scleral flap is closed with the help of a glue. And as you can see, there's a well-centered intraocular lens. So much more challenging, but much more rewarding in the post-operative period. So just the key points: management is based on the etiology, grade of nuclear sclerosis, and extent of subluxation. The surgical principle is to avoid chamber fluctuations and minimize further zonular loss. Incision, avoid the site of subluxation. Rexis, continuity is imperative for successful surgery, because any device you can only implant if the rexis is intact. A capsular tension segment can be implanted even with an extended rexis. Nuclear emulsification, avoid rotation, and a slow motion phaco is preferred. And stabilization of the bag, iris or capsular hooks may be used during emulsification. CTR is much more challenging to insert before phaco, and CTR, CONE or ring segments are used for permanent stabilization of the bag. Thank you for a patient hearing.
Thank you, Dr. Manpreet, for highlighting important tips for managing subluxated cataracts. We know that they are really challenging, and you can have a different scenarios of amount of subluxation. And one thing I like what she pointed out, what you see on the straight lamp may not be the end point of subluxation, and when you actually get into the microscope, when you inject the viscoelastin, you realize the subluxation is much more than what you think. And sometimes if even you don't have good dilatation, it's seeing the anterior capsule, once you put a needle in the anterior capsule, you realize it is a subluxated lens. So many points is highlighted. Any questions now?
There is a question about iris prolapses on wound hydration. Any tips? Mainly when it's also prolapsing during phaco, difficult to close such case. So if iris is prolapsing, you have to first know why it is prolapsing. Either your wound is very posterior, or you have injected too much viscoelastic. If it is too much viscoelastic, you can decompress a little bit, and then I prefer, I inject some viscoat just above the iris area where it is prolapsing. Then that will help you. Or else you can suture it. If nothing works, then you can create a new incision and complete the procedure from that part.
This was a question from Dr. Sagil Khan, and he had also asked a question on there was a pupillary snap sign also, and he had noticed that. Capsular blocks, and very nice. Otherwise, there are a lot of comments on various presentation, nicely demonstrated. Thank you, Manpreet. We shift to the next session now. Okay, next session is a very, very important session. I'll invite Professor Tushar. He's going to take us through all those challenging scenarios. How do we manage? And I think that is the best part of this workshop. Take over.
So how much time, sir? It's about till 2 p.m. 32 minutes. Okay.
You can make it faster.
Yes, sir.
Show more things.
After start kar do. So now in this session, right till now you have been seeing things, how they are done ideally by experienced surgeons who have done literally tens of thousands of surgeries. So sometimes it is difficult to relate to those cases and techniques. So in this session, we will only learn from videos of cases done by our own residents, and especially for beginner surgeons, it's quite a useful exercise that you can relate much better to these surgeries, and we go very in very small fine detail on each movement, on each hand movement, placement of instruments, and just go through each step individually. So Dr. Afri, start. You can start. So just to get a baseline, so how many of you have done less than non-RPC residents people? How many of you have done less than 100 cases, 100 Phacos? Okay, so most of you have done more than 100 cases. Okay. Okay. So 0 to 100. 0 to 100. I meant 0 to 100. Okay.
Have you been to wetland?
Okay, so this is taken from one 3-month period, last batch. So we'll go step by step, and we'll see multiple videos of the same step. So starting with incisions. So you can just keep on playing. We'll keep catching things. So we'll pick up small points from each case. May not be the complete thing. So one thing is that whenever you make your incisions, make the main port first and then the side ports, because especially the left side port is married to the main port, so it has to be made at a particular orientation of 2.5 clock hours from the center of the main port, and that cannot shift. So if you make your side ports first, it is difficult to align the main port later on. So always make the main port first, side ports after that. Then secondly, when you make any port, make sure that your limbs comes directly across the at 180 degrees to the blades. It will always give you the best possible traction on the globe. It will avoid the globe rotation sometimes, which can happen, more so when you are making the main ports.
AV team, switch on to that mode for virtual.
Sorry? No, so incisions will keep on coming. So most of us are now making near clear corneal incisions. The sign is that it should bleed minimally. If it is not bleeding at all, it means that you have gone clear corneal. And if it is bleeding too much, then it means that you are too posterior. So it's a retrospective sign, but then it can give you some idea. So the second side port comes around 2.5 clock hours from the center of the main port. If it's too close, you will not have the lateral separation while doing nucleotomy, and if it is too far out, 3 or more clock hours away, then again you will have difficulty in chopping. Main हो गया? हाँ, ठीक. You can go to the next. So we'll cover sir each step. हाँ, आगे चलो. Next. So as I was saying, so put your limbs directly where the point of the blade is coming out. So it will prevent the globe rotation. Otherwise, you will always have rotation of the globe while making the incision. As you can see, the globe will rotate away. If it's right opposite to the main the blade, the rotation will be much less. You will have better control over your incision. Secondly, don't pull on the conjunctiva, because you are not. The tendency is to hold the conjunctiva with the teeth of the limbs, so you don't get any actual force going on to the globe which you want at that time. So you are trying. So the idea should be to impinge on the, so press on the sclera. We can go to the next part, the next step. Yeah, Afreen, next step? Okay. So as Sir had highlighted in one of the videos regarding the hydro, so always remember that when you inject something into the eye, whenever you are trying to replace something in the eye, it has to be done through the main port. Like for example, when you are trying to say do hydro or something, you want the anterior contents to come out. At that time, those things have to be done through the main port. That's the generic rule. If you're trying to add something to the eye, for example, adrenaline or pilocarpine, that can be done straight through the side port, because there you don't want things to prolapse out of the eye. Next. One more trick which I actually learned from the residents: when you stain the capsule with the, you should stain all cases. In the beginning phase, you should stain all cases, irrespective of the glow or no glow, because the stain actually not only in the rexes, but it also helps you in chopping to visualize the capsular rexis margin. The other trick which our residents use is that, pause kar do aapne.
Anyone, any comment about the incision?
Surgery is going to be very difficult sometimes. So make sure tunnel is also adequately done. So normally it happens in cases where you are not comfortable, or your blades are little blunt, or it is you have to push little harder, or a deep set eyes. As Dr. Tushar is saying, if your control of the counter pressure is not good, that this is what is going to happen. So this is a slightly longer incision.
So when you are removing the dye, instead of removing it solely through the main port, try to also tap on the side ports. So when the dye comes out through the side ports, it stains the side ports as well. So because a lot of times in the beginning you find it difficult to locate the side ports. So that's another trick you can use. Regarding rexes, when I teach, I have a strong opinion that at least in the beginning phase you should rely on rexes forceps. Of course, the initial flap has to be raised through with a capsulotomy needle, but you should always, I mean, it's much easier to learn with a good rexis forceps, which has smaller, small fine limbs and slightly blunt ends, so that it will not puncture the capsule inadvertently, and you should try to learn with that. Now you have micro incision rexis forceps, because the main complaint which I used to receive from my residents was that when they use a rexis forceps, the viscoelastic tends to leak out. So that can be circumvented by the use of micro incision rexis forceps, which open very slightly, and even with Visilon you can do it with them. And once you are comfortable, you can always go back to needle. But you should all try and learn with rexis forceps. And actually, rexis I take a separate class, so it's difficult for me to teach here.
Afrin, you could just go back a few clips. This point is very important. You see, when you are lifting the flap, what she did is she little bit extended from this side.
This is after post.
See, if you see, the extension towards the center is very small. So what the surgeon did, he also extended it little bit towards the center. Then he lifted the flap. So that is what you people should do. If you simply lift it and rotate from here, it's not going to give you adequate size rexis.
So normally the flap, the flap which you initiate, it should start from from the center of the intended rexis, and the cut which you make initially, it should be about 60 to 70% of the intended radius of the rexis. Because if you make it, for example, you are targeting a 5 millimeter rexis, if you make a 2.5 millimeter initial cut, and when you raise that flap, it will extend further. So the idea is that you keep it around 60-70% of the intended radius of the rexis, and then when you raise the flap, it will come to the original, the intended size. We can move forward, Afrin. We can move forward, yeah. We can go to hydro, yeah.
वीडियो लास्ट स्टेप जो दिखा रहे थे ना उसका
नहीं बंद नहीं किया, प्लेलिस्ट बना हुआ है।
चल रहा है?
नहीं चलेगा प्लेलिस्ट
ये था, ये सेम पेशेंट था?
नहीं सर, आगे आना पड़ेगा आपको।
ओ सॉरी नहीं गो टू,
हाँ बिल्कुल आगे आना पड़ेगा आपको, लास्ट में आ जाओ। आ जाओ लास्ट में आ जाओ। सही है।
I wanted to point it out, when you are using the instrumentation, the incision was like this and your forces like this. So that's going to create a lot of traction onto the incision area, and your rotation will also be difficult. I think this यही case था क्या? Towards the end.
So a trick to avoid that issue is that when you make any incision, make it according to the direction of the instrument. So you can actually have a dry run before making the incisions. You can put your phaco probe or something over the cornea and just see what angle will suit you the best. So you may not make it exactly at 180 degrees. So it might be slightly temporally shifted. That's fine. But at least you'll get the intended line, because your hand will try to go to the position in which it's most comfortable. And if the incision is not along the same direction, it will always have a distortion. So you can place a phaco probe just over the cornea. Don't touch it, and just see what angle it is making, and accordingly you can make the incision. Next पे आ जाओ, next series पे आ जाओ. So coming to hydro, always through the main port, and always decompress the anterior chamber first. Take out the helon. The eye should be soft. The second trick is that the hydro should be done at 180 degrees. So never take your cannula across the lens and then do the hydro, because the cannula will keep on pressing on the nucleus. It will not allow the fluid to go behind the lens, behind the nucleus. So if your cannula is at 180 degrees on either side, you can choose either side. It will give the fluid wave a free run to go across the lens. Next hydro पे आ जाओ ना, जो start किया होगा. Yeah. So this is what you need to avoid. Coming across the lens and then try to do the hydro, because the cannula will keep on pressing on the nucleus. It will not allow the fluid to lift up the nucleus. So if it is on the sides, either on the left or the so if your cannula is coming across and pressing on the nucleus, it will not allow the fluid to lift the nucleus. But if it's on this side, so you are going tangentially. The idea is to go tangentially either on this side or on this side. So if you inject the fluid here, it will come. So if, for example, this is tangentially, so the fluid can go right across the breast of the lens. So again, we try to discourage residents from doing this, going across the lens and then injecting the fluid. Always go tangentially like this and then inject on either side, whichever you like. Next. इसी में next. नहीं थोड़ा. You can go to the next case. थोड़ा हाँ, okay. So. Which part is this?
Hydro.
Because hydro हो गया ना. Next पे आओ. हाँ? नहीं वो तो ठीक है. So the goal is basically to achieve a nuclear rotation, free nuclear rotation inside the bag. Don't proceed to phaco without having achieved free nuclear rotation, because that means that most of the forces going to the capsule from the nuclear elements have been disinserted. If the nucleus is not rotating and you initiate phaco and then you try to rotate, the forces will go to the capsule, which will further go to the zonules, and you can end up with a dialysis. Next. तुम्हारा वीडियो है इनके पास इधर है वो जो आएगा से हुआ था ओके आफरीन इसमें कौन नेक्स्ट
यस
नहीं नहीं इसी सीरीज चलो कोई बात नहीं इसी सीरीज में दिस इज चॉपिंग
यस एंड
so what we teach here now is I mean vertical chopping is what we teach to all residents. They start with vertical chopping and some variations of that, minor variations of that, but most of the cases you can handle with vertical chopping. Mostly I don't now go into divide and conquer and crater and chop and all those things. So those things, the hardware and the software part of the machine, if you have access to wet labs, you can learn very well in them. Even if you don't have access to wet labs, your normal OTs, you don't need to learn those things in the patients. I mean, you should be having a good hang of the parameters, all the parameters, what they mean, what they do, what does each value lead to. I mean, if you keep bottle at 90 or say 120 or 60, what does that mean? Or if the flow rate is high or low, what does that mean? That you should be aware of. Beyond the scope of this lecture, but the hardware and the software of the machine you should learn not on the patient, either before or in the wet lab or in the OT. You can do. So in chopping, if you're trying to do a direct chopping or a primary chop using vertical chopping, you should have a sharp chopper with a pointed end, and make sure it should be somewhat moderate in length. If it is too long, then there are chances of reaching the posterior capsule with the chopping itself. And if it is too small, then it will not give the desired depth of the first track. So moderately long sharp chopper is what you are looking for. And the basic steps are that you have to remember that you go in with the irrigation on. Most of the residents try to keep irrigation on continuous mode so that their chamber doesn't collapse. So after irrigation, that's foot switch 1 usually. So foot switch 2 will initiate the aspiration out of the eye, which will create a vacuum. So the basic steps of primary chop are you start with the aspiration, create a vacuum hold on the nucleus, and then initiate some amount of phaco, which will advance the probe further into the nucleus. That creates the hold, and then you come back to position 2, and that will keep the hold on. And then you initiate the chopping with the chopper, and you have to just repeat this movement. So it is 2 3 2 2 3 2. 2 is aspiration, 3 is phaco. If you come back to 1, it will leave the hold. If you don't go to 3, it will never hold enough. So you will find that a lot of times you hold the nucleus with pure vacuum and you apply the chopper and it keeps rotating freely in the eye, because there is no hold you have created on the nucleus. The hold will come only when you go from position 2 to 3, and of course 3 you have to stop midway. If you continue to go in position 3, it will continue advancing and can take you behind the nucleus. So it is 2 3 2 2 3 2. You were wanting to ask something? No, the girl. You were raising your hand, no?
Out here in this video, you see this your other chopper hand is not the correct way. You can just hit the axis margin also.
So this is an example where you saw that there are a lot of movement, rotation of the nucleus. If you're having a lot of rotation of the nucleus while chopping, it means your impalement of the needle is not there or it's inadequate. And that is generally because that you are not given enough torsion in the nucleus. So you will never have a good hold with vacuum. So normally we are using Appa Swami, instruments. So there is a chopper by Dr. Amar Agarwal, not this Agarwal, Amar Agarwal. So it's called it's come as a sharp chopper, and that's a generic name. So you can see under the microscope, if it looks dangerously long, it is long. And that's it. And little longer than Sinsky. That's the product of the gross idea. The length of the Sinsky hook tip is small. It should be, you can compare it with the Sinsky hook. So it's slightly longer than the Sinsky hook.
So the average thickness of nucleus at center is 3.5 to 4. If you take out the epicortex, it becomes 3. So if you are asking for exact size of the length of the tape, then it should not be more than 1 mm to be on safer side. And one more thing I would like to add, sir suggested step 1, 2, 3 of the foot switch. If you are getting confused, you can take help of the machine also. They have a parameter. There will be a beep once you are in between 2 and 3 and the occlusion is there. So you can maximize that sound, and whenever you see that sound, try to keep your foot there only. Then you will be able to chop it.
Next.
Afrin?
Yes, sir.
You can also tell us, no, what is the step here?
Folders के नाम मेरे को पता नहीं, वो मैंने लिस्ट सारे निकाल लिए ना उसमें से.
Nucleotomy only.
So let us see one nucleotomy. We'll see one nucleotomy video in detail and try to see what we can learn from it. So this sleeve you can see. So this I would call a wrong position of the probe. So probe, the open mouth of the needle should always be facing towards you. Never on the sides or on the back. Secondly, the coverage with the sleeve. I would definitely correct this, because you need to have good exposure of the needle. So because when you're trying to impale with the needle, it will have a hard stop once it reaches the silicone sleeve. So if it is not exposed enough, it will hit the sleeve and it will not go further. So I would, for example, in this case, I have to make a correction. I would ask the resident to make one whole turn of the sleeve more, so that the exposure is adequate. And then, of course, the direction of the needle. You can see it's hardly anything is coming out of the sleeve. Praful, sorry, Afri, next case में चले जाओ.
Yes.
Next case, this is the same case. No, not that much. Go about इतने ना one. वापस आओ इसमें इधर जहाँ पे चॉपर है ना इनका, हाँ यहाँ पे हम बस left to that left. Yeah. Okay. So do you have access to wet labs? No? None of you. So see, then you have to maximize your OT time without the patients. Microscope, suturing skills, non sort of go-tie things you should try and learn, or try and get some working arrangement going with some regional center. A lot of companies are now running wet labs with medical colleges. Yeah. Not recommended. Bevel down chopping, I mean, people do that, when we teach residents, we just teach the straight thing to do, and the easiest and the safest. So bevel down chopping, yes, people do, but not advisable.
Bevel down only after you do 500 to 1000 picoes.
Okay.
Then that gives you control.
So let's see. So again, this is an example. You know, most of the residents undergo through this phase where they try to hold, because they have seen videos of consultants that, you know, the probe goes and the chopper comes and, you know, chopping happens, but it never happens. Never. So the commonest reason is this, that, you know, that the impalement is not there, and the impalement is not there because you're not giving enough phaco. So a very clear-cut sign for that is that when you give vacuum, you should see a cloud of that emulsification cloud. If that is forming, that tells you that yes, you have given some torsion or some longitudinal phaco. And at that time, if you stop in position 2, the chances of getting a chop going are much higher. Simple hold on vacuum is not going to give you any chopping. You also might have noticed in your cases, people who have done say about 10-20 cases, that you struggle in the first or the second chop, but once you are through to the fourth or the fifth piece, the chopping becomes progressively easier. You get more chops. The reason is that in the first or the second attempts, you are not confident during that particular case, and you are not giving torsion. By the third or the fourth piece, you are confident enough, and then you start to actually give the torsion, and that's the reason the chopping becomes easier as you go along. We can go to the next case, not the next file, next case. We can pick up some new things. Next, और आगे चले जाओ, next case में चले जाओ. So, any specific questions regarding difficulties you have encountered in nucleotomy or chopping? Because, sorry?
Rotation.
Yes. So exactly. So most of the cases, I would say 9 out of 10 is because you are not impaling enough. And the key point, which I think I forgot here, is that the chopper should come, when it comes down in the nucleus, it should come down in a line running through the middle of the needle. If you draw an imaginary line, stop कर दो, हाँ, pause कर दो, हाँ. So we'll have less time. So if your chopper, the position of the needle is wrong, we'll ignore that, ignore everything. The chopper, if it comes right in a line which is coming like this, then the rotation would be very less or minimal or no rotation. If your chopper is not in line with this needle, you will always have rotation, because you will induce a torque. So make sure you are trying to chop on a imaginary line running through the center of the needle. So that rotation thing will not happen. Assuming that you have impaled the needle. If you have impaled the needle and still there is rotation, there is only one possible reason, that your chopper is not in the line with the needle. It's either head of the needle, I mean right side of the needle, or the left side of the needle. Anji, Profile, anything? Okay, next. Next file में आ जाओ.
And the chopper has to be, at least if you go through the textbook, they say it should be 0.5 to 1.5 away from the phaco probe. And don't put it in the equator and phaco probe here and try to do direct chop.
It's nucleotomy.
Nucleotomy.
So again, going through the steps, repeating them. Your idea, what you want ideally is that when you impale the needle, it should be at the center after impalement, somewhere along the center. So you have to begin somewhere here. You start the impalement process, the torsion process, the vacuum, the position 2 here, position 3 somewhere here, so that by the time the impalement happens, you are in the center, in the thickest part of the nucleus. If you start your whole process from somewhere here, you will end up impaling it around at this point, which is already very close to the rexus. You want your needle to lie in the center 3 millimeters through the entire case, because for the simple reason that the nucleus is thickest at that point, and secondly you are farthest away from the endothelium at that point, because the globe is like this, the cornea is like this. Afrin, aage chalo.
Yes, sir.
Time is very less, so I think you can go to
Next section.
you can go to IA or something, you know. Those things are more sort of learnable. Okay, in this setting. $30 to $45, I think, is a good compromise, because you might have read in theory, because you understand the angle of the tip, right? So it's a graph, it's a vector graph between hold and cutting. So 30 to 45 is a good thing.
IA.
Coming to IA, you might have seen in morning cases and everything, sir of course does even IA with phaco probe, so don't do that. You can do that once you have done enough cases, as he has done, but my advice to people is to do even especially in the first 100 cases, do even the epinucleus with the, I mean, your goal should be to get rid of the phaco probe and the chopper as soon as possible. As soon as their main job is done, you should get rid of them, because those are the most common culprits in getting PCTs, bad PCTs. So even epinucleus can be removed nicely with the IA probe. It will take slightly longer, but it will be safer. And IA, of course, you will use an IA probe. So I'll go through quickly through basic tips of IA probe, how to do it. So have adequate exposure of the port. Always keep the port in view. If you have the port in view in front of you, chances of rent are very, very less. Secondly, always start from one side and go contiguously. Don't leave skip areas of cortex in between. It's very difficult to remove small fibers individually. So if you go contiguously, on either side, you can change your direction midway. You start clockwise, you go anti-clockwise, that's fine. But go contiguously. Don't leave any skip areas of cortical fibers in between. And hold the anterior fibers. Don't catch the posterior fibers. Even if you catch the posterior fibers, use the reflux system to let go of them. Always hold the anterior fibers and try to peel. The motion is peeling of the fibers from the bag. And once it is peeled right till the center, at that time increase the aspiration to take them out. Don't try to take them out in the peripheral area, because again you will leave posterior elements behind. Your goal is to remove one entire chunk. So the cortical fiber is running like this, right? So you hold the anterior fibers and peel it from the equator region till the center, that chunk, and then aspirate it, and go contiguously. Profit? Huh? You can go one more case. We can see of IA, if something we can pick up. Afrin,
Yes.
IM, during? Okay, so the question is any important tips regarding handling of the second instrument during phaco? Please remember what instrument we are talking about. The second instrument is a generic name, so probably there are two second instruments, right? One is Sinskey hook and one is chopper, right? So Sinskey hook would normally use in the eye when only stabilization is required. So that would be mostly very near the limbus, very near the port, just to hold on to the globe. So for example, in IA or IOL implantation or something like that, I will be using Sinskey hook. Chopper, of course, when I am putting my chopper, my most of the times I am using it to actually do something in the eye. So always in the center, because my probe is in the central 3 millimeters. So the outer Lakshman Rekha for the chopper is the rhexis margin. So not much area to move around. And during the actual phaco, that's another part where you're not using the chopper, but the chopper is still in the eye, somewhere in the midway. But don't try to feed nucleus particles into the phaco probe. I've seen a lot of people do that. It can cause chipping of the steel chips come off the needle, and they remain permanently embedded in the iris and the tissues. It's not a good thing even in the incisions. So so let the phaco machine and the needle do their job, which is to emulsify and remove the nucleus. You can use the chopper to slightly direct the nucleus towards the needle when you are aspirating, but don't try to physically feed the nucleus after you have chopped into the needle. We can go to the next thing. We are already out of time. So the question is whether you can use a chopper to protect the you know, if you're doing things correctly, you will never need to do that. Because the nucleus is going to be in the bag always, right? And it's just to sort of it's how to put it, you know, एक सहारा होता है मतलब कि you know that you're not actually physically doing anything with the chopper at that point. It's just that something is, you know, the nucleus piece is going in a direction, unintended direction, then you can give a slight nudge to direct. But don't, I would not recommend using a chopper to do much of the movement of the nucleus in the eye. Because it's very easy to catch the PC with it. And that's why once the chopping is done, I always tell them to get rid of it ASAP. Even if you want a second instrument to stabilize the eye, use the Sinskew. But once the chopping is done, get rid of the chopper. Manpreet, you can add on, you have been silent. IOL. So IOL again is very easily, because you must have seen the, you know, lot of how many, I mean 5, 7, 10 cases they must have seen today. So the normal, when a consultant is putting the IOL insertion, is about 5 to 10 second job, and you know, when beginners put, it can range anywhere from 2 minutes to 20 minutes. So that gap is very easily coverable. So in residency or in learning curve, don't do a wound assisted insertion, which means that wound assisted insertion means that your cartridge is at the wound tip. It's not fully it's not opening in the anterior chamber. If it is opening anywhere in the tunnel, it's a wound assisted insertion, which means that when the lens will come out of the cartridge, it will go into the tunnel for a short while. So the tunnel also acts like a cartridge, and then it opens. The drawback is that when the opening is out of your control, when you do a non-wound in the anterior chamber insertion, which means that the cartridge, the definition is that when the cartridge, the whole of the cartridge is opening in the anterior chamber beyond the inner lip of the tunnel, then you have a direct contact and direct, you know, connect with the lens and lens opening. So when you're inserting the lens, it opens in the eye. So if it is opening on one side, you can manipulate. If you're doing a wound assisted insertion, it's very difficult to change the orientation of the lens. It will open as it wants to, because the final molding is being done not by the cartridge, it's being done by the tunnel. So you will give up 0.2 millimeters of the incision, but it's worth the enlargement. The second tip is that if you saw Praful's video in which the IOL, I wanted to stop but I didn't. So you saw that video where there was a rent with the lens, with the lens. So pause kar sakte hain yahan pe. So a major cause for that thing, because it's usually you will tend to blame the folding or something is stuck. It's generally not that. The general cause for that thing is why, if you leave the lens too far out in the cartridge and there is a lot of viscoelastic ahead and the incisions are very tight, and when you try to inject in the eye, so what is physically happening is that you have to first unload the entire viscoelastic in the eye, and then the lens will come and take its position. So and if you begin with overinflated eye, on top of it your lens is too far out in the cartridge, and then you start your IOL insertion. So in an already extra pressurized chamber, you are inserting more viscoelastic. So that back pressure which you are getting is not because the the plunger is stuck somewhere. It is because there is no room for anything else to go in the eye. And then you keep on increasing the pressure. And what it leads to is that at some point of time, the side ports give way. Viscoelastic like a pressure cooker valve. And that leads to an immediate reduction of pressure in the anterior chamber. But the force you have applied on the plunger is very high. You don't have time to react. And that went, and that was the probable cause for the PC tear in that case. So don't overinflate the chamber with viscoelastic. So your goal is to inflate the bag and not the AC. So it should be moderately soft when you go in. Secondly, try to put under the microscope, try to advance the lens right till the inner lip of the smaller side of the cartridge. It should be fully in the cartridge. Nothing should be popping out of the cartridge, but try to bring it right till the edge of the cartridge, so that when you go for the actual insertion of the IOL, you don't have to push much of extra viscoelastic in the eye. Secondly, there is very less excursion left of the plunger. So most of the plunger is already used. So you will have a very easy time putting the lens. And thirdly, of course, as I recommend that do an in the chamber insertion of the lens. Don't do in the beginning phase. Don't do a wound assisted, because your final molding will be done by the incision, not the cartridge. So these 3-4 things will make IOL insertion quite easy and predictable. Most of it is done, sir. Yeah. Yeah, sir, we are IOL tak to aage. They have improved. So towards the end, I think we are done. Repeat. Sir, repeat. नहीं वो repeat हो रहा है, आप ही नहीं stop I think we're done with this. Obviously, this is just a sort of a trailer kind of thing. If you have any questions, you can get back to me.
You can practice all this thing in wet lab.
That's absolutely correct. I think whatever you are seeing today, you all would have experienced these things. Only thing is should be visible to your mind. Sometimes what you do, you don't see yourself. So always try to see what you have done. That means you have to record your surgeries, at least few of the surgeries, and try to see in the evening. And try assess yourself if you have been doing that correctly or not. And any stage, in my stage where I see most of my videos within a few days, or if not possible within a day, then I feel sometimes very shameful that I am not doing correctly. So this is the learning for us. So you make a practice that you record your surgeries and see. So as I said, it should be visible to you. Because when you are doing surgery, it's not visible to you. You are just doing. Visibility will come when you are actually seeing the recordings. Then you can pause, you can think, see the axis. All those things we are discussing can be judged by yourself. And you all are teachers. You can see your own video and teach yourself. And be a better surgeon, a better teacher for yourself, for patient, for everybody. Okay, thank you for being with us. All of you are welcome for lunch upstairs. Then go to wet lab, those who are interested for wet lab. There will be definitely some discussion, some improvement. People would have done many surgery, but seeing somebody doing a wet lab, you can put your input, give some input there, and you can also understand what difficulty people are facing. And we are always open for our discussion. You can send us email, you can send us questions. If you have access to some of the phone numbers, we have 2 people always available, Dr. Namrata Sharma and Dr. Rajesh Sinha. You can talk to them, get your queries cleared every time. And Vanaj is also there, always available. You can talk to them and give a call, discuss, share your thoughts, okay? And hope that we'll see you very soon again in the center and have a much more memorable gathering again. Thank you, all of you.
Sir, a group photograph.
हेलो हेलो। हाँ, देख तो रहे थे लेकिन क्या करें, आज मेरी मेड नहीं आई तो हम मेड बने हुए थे, खाना बना रहे थे। किसका? हाँ, मेरा एक मिनट रुको।